the onset of psychotic symptoms, there are a gamut of symptoms which happen, maybe the cognitive symptoms, maybe the social impairment which happens. While they are very obvious, they are not pathognomonic of schizophrenia, which makes life a lot more challenging. Even with the respect of what was called the early prodromal symptoms, very often it is difficult to differentiate from the adolescent adjustment disorders. Why does that happen? We have two predominant hits which happen during the developmental phase. The first hit probably happens within the first 5 years of life. While I am not a big fan of Sigmund Freud, he did really predominantly invested on early 5 years of development. Predominantly makes sense. And what are those early problems? Essentially the problems of childbirth, the number of things that happens around childbirth, the infection, the malnutrition, genetic makeup and whatnot. Most important issues which are becoming increasingly popular, what we knew for over 100 years from sociologists, is about influence of urbanicity. If you have a lot of green spaces, less stresses, probably precipitation of psychosis does not really happen. On the other hand, immigration is another important misnomer. There is a lot of literature saying that immigrant people are at higher risk for developing schizophrenia or psychotic-like states. But if you really look at the data critically, in fact this has been extensively published by one of the Indian origin psychiatrists in UK in Warwick, SP Singh, talking about the immigration of skilled people have in fact much lesser prevalence of psychotic disorders. It is those who immigrated as a part of refugee, those who immigrated as a result of social adversities in their host country, those who had a number of developmental traumatic experiences probably have higher risk for developing psychosis. There is a huge parliamentary inquiry which happened in the UK which actually changed their mindset and hence the way they look at even immigration policies as a result. The second hit which is important is what happens in the late teenage years. The big issue is the substance abuse disorders. The stress in the adolescent is paramount, whether it's an academic stress or otherwise. Interestingly, a developing country and the country like us, there are a lot of protective factors. We have a good family, supportive family life for an adolescent growing up, which is a huge protective factor in prognosticating not only the onset of illness but even the response to treatment. Why does that happen and how do you correlate that with the neurobiology? Again, you can see you do have in the early 5 stage in the development of brain the number of changes which happen in the brain which corresponds to the first hit, and you have other changes particularly relating to synaptic pruning, the sexual maturation and the hormonal effects and the cortical myelination, which are all extremely important in terms of psychotic manifestations. How does it get translated into clinical environment, for example? A drug like risperidone, to give an example, produces hyperprolactinemia, and we all criticize the adversities of hyperprolactinemia. But remember, one advantage of having increased prolactin is prolactin actually improves the cortical myelination, and there is a substantial data on this. Now it's a catch-22 situation. While it does help get your brain better, it also causes significant problems. So that's the second issue. So what we really need to do as a clinician is to find that window of opportunity around the late teenage years which actually can impede the onset or delay the onset of psychotic symptoms. So if you're really thinking about intervention in psychiatry, it is that period of the time, and what is best termed as early intervention in psychosis. Let me spend a minute or two on what happens in the brain. As you know, you have very few synapses as a newborn. As you grow, by the time the child is about 7 or 9, there's enormous number of synaptic connections which happen. Very, very dense. You can see there in the middle 6-year-old, the connections are huge. But those connections, in fact, reduces the productivity. So the brain has a natural way to cut off those unwanted connections and help those mature connections to develop better. A process what is called as pruning, the same way how you prune a rose plant. And by the time somebody is between the age of 14 and 20, most of this pruning does happen. The initial understanding of this is that there is an increased aberrant synaptic pruning which produces losing of very important connections and causing significant problems because of a lot of unwanted connections remaining. How does that differ from autistic disorders? These connections don't cut off. There's a reduced synaptic pruning. They have an increased connectivity. That's where some of those immature connections could be skilled ones. You would have heard of idiot-7 syndrome, for example. If you look at Steve Jobs, for example, fantastic example of autistic spectrum, extremely good in certain areas of life, terrible, destroy their own life in other parts, because those connections also have a lot to do with the social and neurocognition. So this synaptic pruning is actually a final phase of synaptogenesis, and more often it has a pattern. The early occurrence happens in sensory cortex and much more later which happens in frontal cortex. There is a gender difference. Women mature their brain much earlier and men take another 2 or 3 years. So that's why the women perform better in year 10 and year 12 compared to men. Men catch up a little later. Our brain gets better by the time it is 21 or 22. What's the second implication? Around this time, something else will happen. This crucial period, the final stage of maturation of the brain, men tend to cope by finding a quick short circuit, what is called recreational substance use, which in turn increase their risk for developing psychosis. Now, is it a fact? We thought this is a very good theory. It took some time to understand, and we also looked at what happens in the brain. You do have a progressively increased prefrontal dopaminergic innervation which happens during this period. You have a progressively increased prefrontal inhibitory GABA synapses. On the other hand, you have a competitive elimination of synapses, particularly the arborization of the dendritic processes, a very exponential process, and this crucial 3 changes probably forms the pathophysiology of schizophrenia. Years later, one of our own people, extremely well known, who is currently the chair of the Harvard, anybody knows who that is? Macheri Keshavan, actually expanded this on synaptic pruning theory and subsequently talked about the importance of glial cells and how these glial cells will manage the imbalance between the excitation and inhibition, which could be actually the responsible. Glial cells actually nurture the neuronal cells and they produce. And that was a fantastic theory. Just last year, Oliver Ho from Institute of Psychiatry, London, close friend of mine, actually published in Molecular Psychiatry advancement to what Macheri Keshavan talked about, which is how does this happen? There are 3 things which happen. These glial cells are influenced by the immune system, that is immune activation. He looked at a number of genetic theories of schizophrenia. How do they really modify that? And finally, what's the role of stress? If stress really causes problems, it does causes problems to these glial cells and then to the neurons. So there are three things which will happen. Again, these three changes in the glial cell ultimately produces two kinds of problems. One which produces neurocognitive deficits, the second one which produces hardcore psychotic symptoms. Often in combination, some people predominates with the neurocognitive deficits more than the other, and hence the prognosis of schizophrenia would be quite different. Option 2, this also will explain why about 10 to 15% of the people probably have treatment-resistant schizophrenia at the very first episode of psychosis. And with each of the relapses, by the time somebody has 3 or 4 relapses, that proportion becomes up to 40%. We have the authority in rehab psychiatry today who is going to probably expand on some of these issues. 40% of our patients, 40%, which is 2 out of 5 people, have treatment-resistant schizophrenia. The question is this treatment-resistant schizophrenia and treatment non-resistant schizophrenia, are they biologically similar? And that's a huge data which you really need to look. Just to summarize, there are certain areas in the brain such as dorsolateral prefrontal cortex, which is a very, very important part of the brain, ventromedial prefrontal cortex, which is again an extremely important part of the brain when we talk about the structural changes in the brain. I'm not going to spend too much of time on talking about genetics, but in reality, the genetic theories keep evolving, coming out with all kinds of technologies. Answer is probably far away from what we hope to. It looked like schizophrenia is a biological disorder. I spent my first 30 years morbidly preoccupied with chemistry, biology of brain, and I was convinced. But I don't know whether it's an aging phenomena. I'm tending to now understand how the environment is changing the way brain behaves. To me, the biological changes could be a consequence of adversities which happens in the environment. In the last 5 years, all my work has been on the trauma, looking at a variety of trauma and a variety of developmental phase of trauma. Essentially, I'm looking at even the animal models and how things change, and I'm increasingly getting convinced that that's the way we need to forward. If you really need to look at that, what does the literature tell me? This is a beautiful article for postgraduates to read from Nature, almost 15 years now. Very, very wonderful data, very good review article talking about what does the environment does. You really look at the extended phenotypic population as a general population, you do have certain symptoms which are predominantly had an impact from environment, and there are things which are developmentally impact. If you really look at the neurocognitive changes, you probably tend to think a lot more developmental impairment related issues, whereas the affective component of schizophrenia, probably for that matter even psychotic symptoms, predominantly are influenced by environmental impacts. So what do? They do a number of changes. The first and the foremost change is the way the brain represents the social world changes. And it happens because you do expect a lot of neurocircuitry changes. For the want of time, I'm not going to go too much detail into it. And these neurocircuitry change, even if you look at the cellular level, you will find a number of changes. If you look at the DNA, if you look at the RNA and the changes, again, you can see what environmental impact can cause. Why was I interested? I was looking at a variety of psychosocial trauma during the developmental period. What does that do to these brain cells? And my next 5 years of my life probably is going to be on this era. Such of those who don't want to understand that and make life simple, I think this is a diagram which explains everything. So where does the environmental changes will cause? When we talk about dopaminergic, hyperdopaminergic state in schizophrenia, we are essentially talking about mesolimbic pathway. And what are those significant areas? Most important one is prefrontal cortex. Why is it important? That's where we talk about neurocognition and social cognition. The second important pathway is those pathways which run from ventral tegmental area to the nucleus accumbens, what are otherwise called reward pathways. And these reward pathways are very heavily impacted by environmental influence. Why are reward pathways are important in schizophrenia? Apart from explaining anhedonia and variety of other negative symptoms, these pathways also explains why patients with schizophrenia have an increased use of substance use disorder. We know that 80% of our patients in the acute inpatient unit would have started smoking. At least half of them who have never smoked started smoking for the first time when they developed psychotic symptoms. The third issue which we need to really know is the complex role of amygdala and hippocampus and what do they do. But the more fascinating part is it is the neuroendocrinal axis. It is how does the autonomic system, how does the neuroendocrinal system change the pathophysiology in the brain. So that's what the current understanding is. This is a typical undergraduate slides. We have a number of dopaminergic pathways, the mesolimbic pathway producing negative symptoms, nigrostriatal and associated striatal cortex probably have a lot of role to play. Psychosis, mesocortical pathways are responsible for depression, the negative symptoms, the cognitive symptoms, and finally the sensory motor striatal cortex probably are the predominantly areas where you talk about involuntary movements. Now, often we blame involuntary movements to antipsychotic therapy. If you go back and look at original Kraepelin textbooks, when there was no antipsychotics, movement disorders were very well defined. What does that tell me? Probably those involuntary movements we talk about as a antipsychotic induced probably are exacerbated by medications rather than sole focus on that. So what's the clinical implications? The underactivity of the circuits, particularly in the mesolimbic cortex, probably we need to be managing well, and we probably are able to do that because all that you need to do is to increase that activity. We also need to reduce the nigrostriatal circuits associated with schizophrenia by reducing their hyperactivity. Now, unfortunately, the problem we have is when you use a anti-dopaminergic drug or a D2 antagonist, they reduce dopamine everywhere, and that causes Parkinson's. They produces variety of movement disorders. They produces problems in neuroendocrine systems in terms of hyperprolactinemia in particular, and a secondary mood symptoms and whatnot. This is a Lieberman slide which is modified. Most important point I really want to emphasize here is the significant clinical deterioration happens in schizophrenia in the first 5 to 10 years. Number two, the relapses are common and pathognomonic of schizophrenia. More number of relapses, your decline in functioning progressively increases. And after a few relapses, the person probably do not have significant further decline. But such of those who work on long-term rehab, they probably are a lot more interested in what can we do about that. And a lot of authors in the world have tried to explain this phenomena by staging, just like what we do in cancer pathophysiology. What people do and describe that by the time somebody has psychotic symptoms, you're already in a stage 3 disease. But if you learn from cancer, you probably need to intervene them much before even onset of psychosis, and this is where we are at. We probably are at the later half of stage 2 or early stage 3 where we do early intervention. Word about are the treatment resistant schizophrenia and non-treatment resistant schizophrenia are quite different, and how does the ultra resistant schizophrenia manifest? I'm not going to spend too much of time because this becomes a lecture by itself. As I said, this is quite a bird's eye view for you to just go and have a look at them. What does this mean to a common person who suffers from schizophrenia or his family? It's the burden of caregivers, the financial, the social, the economical burden. Number 2, loss of social supports. Why is that important? Very directly related to medication non-adherence. What does medication non-adherence lead to? Significant psychotic relapse. You also have an increased rate of premature death. Why does that happen? Apart from other neurobiological pathways, the commonest issue is people are having too many negative symptoms. They are too emotivated to seek help even though they experience symptoms. 2, their priority changes in the presence of significant distress associated with psychotic symptoms. They probably find it extremely hard to prioritize their physical health. Let me now navigate through some of the fundamental stuffs which we need to know. I'm sure each one of them are going to be presentations later today. We know that about a third of the patients with schizophrenia actually develop their psychotic symptoms as a child or teenager. And the earlier the onset of illness, difficult is the prognosis. There's some suggestion that early onset also correlate with long-term outcome, and generally this disorder is really difficult, mainly because it sometimes take up to 2 years to figure out is this psychotic symptoms at all. The biggest challenge you have is to deal with a group of people who have lost their ability to express what they're experiencing. And this delay actually happens because, as I said, symptom identification, clinical workup. We don't get to see them. They often are taken to the pediatricians. They do the vital signs and say everything is all right, eat good diet, which is not going to help. It highlights the importance of educating our fellow medical colleagues. Other issue which we need to be aware of childhood schizophrenia or psychotic disorders is their more acutely severe symptoms. And this is where we commonly hear a teenager has committed suicide, and it's a big issue, right? The risk of violence has peaks, and a lot of violence you find in the teenager. If you really go back and look at them, they probably had psychotic symptoms which has never been picked up. Wealth of any country is the young population, and you have a resource depletion. We lose these people, we lose the support for these people. When the child is too difficult to manage, people say hands up, let him do what he wants, and a lot of people will have a huge problems, and it's a huge cost to the nation because too many hospitalization, too many legal services. In very, very easy words, having a childhood onset schizophrenia probably causes discontinuity from an adolescent years to one's adulthood years. The same graph, if I have to look at what happens in childhood onset schizophrenia, you will see the second one, the decline right from the pre-morbid state, social decline and functioning decline happens quite rapidly, quite dramatically compared to adult onset course. Now, there are a number of other impairments people talk about. These are all developmental impairment you notice in people with schizophrenia. What you really see here is nearly half of the people probably pre-morbidly had a significant developmental impairment. And patients with schizophrenia, the other significant issue is how much do they know about their symptoms, what we call as lack of insight. The lack of insight could be particular to a particular symptom. If you globally look at 3 out of the 5 patients with schizophrenia probably have a moderate to severe loss of awareness that they actually have a mental awareness. As a result, help-seeking behavior becomes a lot more difficult. Very often, these people need to be involuntarily brought into the hospital. So, a lot of interventions in the last 2 decades has been on early interventions in schizophrenia. Again, a huge lecture by itself. All that I am going to do is to summarize. What we know from the first onset of psychosis, that despite what medication you use, very first episode psychosis, 80 to 90% of them respond to the very first dose of very first type of antipsychotic, and whatever antipsychotic use, they still respond. The dose you require is much less than what we learn therapeutically, and we also have learned there is a huge difference in level of treatment resistance and the problems we are likely to have. Having said, we have other challenges in the first episode psychosis. The big issue is the risk of developing side effects is much higher with antipsychotic therapy in the first episode psychosis. And if you were to have early manifestation of these kind of side effects, for example, amenorrhea, sexual side effects in a young teenage girl or a male, it's going to cause a significant burden on getting this person engaged in the treatment. And finally, those patients, even with what is called good side effect profile, you have an intense need to monitor them continuously. We have a center called Origin, which I am sure all of us heard, led by Pat McGarry in Australia, who has done a lot of work on early interventions. There's enormous amount of resources being used, and when they get transitioned to adults, despite doing intensive work in the first 3 years, the outcome is no different than the treatment as usual, suggesting treatment for psychosis just not in the early phase. You really need to invest throughout the development. Yeah, so this is what talks about. Even though you have a very high response, the 2 important challenges is, number 1 is the relapses. Relapses are very common. Often it is the multiple relapses. If you ask me one single prognostic factor in the person, it is the number of relapses. So, just to summarize this component, determining the outcome of first episode is challenged now with a lot of things what we learned even 10 or 15 years ago. Today, we don't really believe that what is called early quasi-psychotic like symptoms, what were best called as PLES, the psychotic like experiences in the clinical syndrome of psychotic disorder, do not really correlate well with psychosis. There are a lot of such signs, lot of terminologies people have used. What we have learned today is only 35 to 40% of them inevitably converted into a psychotic process. So your prediction for intervention even before the onset of psychosis becomes a lot more harder. The second issue is, if you were to start antipsychotic therapy even before the onset of psychotic symptoms, your risk of developing side effects is much huge compared to those who have an established psychotic symptoms. Those who had an established psychotic symptoms respond very well to antipsychotics. They tolerate much better compared to non-psychotic patients. So this is a summary slide again from Rajiv Tandon. This is about 10 years ago, holds good even today. What are the 10 reasons why it is critically important to intervene early in psychosis? I'm not going to go into the details, but something which all of us need to be aware of. Let me switch gear and talk about treatment. While, as I said, about 10% of the patients in the very first episode have significant treatment resistance, the response to treatment in the first episode could be 80 to 90%. But what you really see, overall response to rate of what you call functional recovery in schizophrenia is only 1 in 7 patients. Which means 6 out of the 7 patients will live with the morbidity, which makes schizophrenia not that wonderful diagnosis. Nobody wants to have this diagnosis. What we need to do? We need to change from a medical model to a recovery model. When you talk about medical model, you have symptoms, you do treatment, and you get well. But when we talk about recovery model, what we are going to talk about is where are you now and where do you need to go? What are your goals? The next thing you're going to do is what are those steps you need to take to go there? And then you look at what are the roadblocks you have in your treatment process. And understanding of that probably is the way to think about helping our patients to reduce their burden. Again, this is a complex slide telling you the milestone development in antipsychotic therapy. 74 years since the very first chlorpromazine was discovered or invented or marketed. You have 74 antipsychotics have in the market internationally. Literally one antipsychotic per year. And how much did we progress? Probably not. We still talk about this, so we still worry about it. 1950 was the first anti-cancer drug come in. Where are they now? They have done fantastically well. But I shouldn't be that pessimistic with respect to psychosis. The reason why I say that we should be more optimistic is look at this ad. This was an ad of the chlorpromazine in the 50s. The criteria of improvement was chlorpromazine reduces the destruction of personal and hospital property. It increases the capacity of the hospital to serve more patients than ever before. It reduces the need for frontal lobotomy. And they were the novel indications for treatment. In other words, if somebody is screaming loudly, shut him down, fantastic. It's an antipsychotic, very good efficacy. It took 20 years for people to realize that management of aggression is a huge issue. It took another 10 years to realize negative symptoms are the bigger problems to the family. While we have reduced hospitalization, but we actually transferred that burden of care from the hospital to the community and the family. And that's when a lot of work has been done. Are we right in using simply D2 antagonists? Do we need to do something different? And someone came out with the serotonergic, dopaminergic antagonist, theoretically in the lab with the mice models, found to be extremely useful. And we said late 80s and early 90s, that's when I was getting my degree, that atypical antipsychotic is the best way to treat negative symptoms. Looked fantastic to me, right? All of us. Little did we understand that animals don't smoke cannabis like us. Little did we understand that animals have a perception, at least we don't know, of the trauma, and there are a number of things which happen. So animal models in schizophrenia has its own limitations. We can't really translate that to the humans, explaining don't get learned from those 7 rooms outside this hall. They teach you a lot of things because they have a different goal compared to us. And just to summarize that component, the two big challenge today in any clinician is to balance between what are my pharmacological domains versus what are the side effects I can tolerate. Can I have an EPS or EPS related syndromes? Can I have cardiometabolic problems, or can I have a sexual dysfunction? Or what of those target symptoms? Am I targeting only positive symptoms? Am I looking at neurocognition or negative symptoms, or I'm happy with managing the mood symptoms, or a combination of them? And if this were to be true, we can reclassify so-called antipsychotics into several different classes. And the art of pharmacotherapy is to titrate at which stage of an illness, what treatment would you like to give in. And you can have a number of permutation combination. Divided here into several segments. If you want to have a patient who should not develop diabetes, cardiometabolic profile, or a problem so the QTC, we have actually out of 74, only 4 drugs available. You have risperidone, paliperidone, you have asenapine and aripiprazole. On the other hand, you don't want to have prolactin elevation at all, you have 7 different options available, except the risperidone, paliperidone groups, and you can use most of the antipsychotics. On the other hand, your goal essentially to avoid excessive sedation, again, you have the partial agonists, aripiprazole, you have iloperidone, paliperidone, and ziprasidone. If you don't want to have EPS related problems, we have very little to offer. We have quetiapine, we have iloperidone, and we have clozapine. Our patients are much more sophisticated, want to have minimized side effects. If you don't want to have cardiometabolic profile and you don't have to have prolactin related problems, then we are stuck with only 3 drugs: aripiprazole, asenapine, and lurasidone. You don't want to have any excessive sedation and prolactin elevation, again you have only 3 drugs. You have ziprasidone, you have iloperidone, and you have aripiprazole. If you don't want to have sedation and EPS, you're left with one single drug, iloperidone. On the other hand, if you don't want to have cardiometabolic profile and EPS, hands up. None of those 74 drugs help us. This is where the futility of antipsychotic therapy lies today. That leads to make us think, are we really in the right track? All these 74 years, we have been preoccupied with dopamine, particularly D2 antagonism. Can we really move forward? And there are a lot of evolving agents which are coming in, looking at variety of things. Non-adherence is a big issue, and this is a John Keynes article, a very good article for somebody to write in the exams. Why long-acting antipsychotics is the way to go when we talk about antipsychotic therapy. What we really don't talk in the routine clinical practice is we educate people saying that antipsychotics don't produce withdrawal symptoms. They are not like benzodiazepines, but the reality is there are a significant groups of antipsychotic withdrawal symptoms. A couple of days ago, I was talking about another talk called de-prescribing at the Mangalore Psychiatric Society, and I was expanding on what are the strategies we really need to think about when we think about antipsychotic withdrawal symptoms. And this could be very distressing. It can increase the risk of relapse if we really don't know how we are going to taper off antipsychotic therapies. Why schizophrenia is difficult to treat? You have a number of psychosocial factors. Our patients tend to isolate themselves. Their presentations are variety of different ways. They often have lack of education. Last night I was talking about some of the highly educated patients who simply don't understand psychiatry at all. Patients have a poor functioning. By the time they come in, they're unemployed. Often they have no support systems and they're homeless. Then we have pharmacological and clinical factors, and that includes the risk of substance use, the degree of relapse people have, the inherent problems of the illness such as cognitive impairment, the need for lifetime treatment. In other words, any chronic illness has this problem, as well as the side effects of medication. Why do the patients don't take medication? We often tend to blame our patients because of the cost, lack of complete information, patient preference if you think about autonomy, and not really able to understand what these clinical trials tell us. But there are other issues. Many of us health professionals, even in mental health, have a very, very limited knowledge about the realities and what are the artifacts. Why relapse is important? To me, there are 5 different things which really worries me. The cost of hospitalization is huge. The place where I work, on an average day, a single patient costs $722 if they need to be in an acute unit. We have a 20-bedded unit, so per day, my hospital, the unit where I work, costs $14,400 per day, which is $200,000, which is more than $25,000 just for the hospitalization. Forget other indirect costs. Relapse increase the risk for incomplete recovery. The functional and cognitive decline is progressive. It increases the risk for treatment resistance, which I discussed, and they also reduce the ability to maintain relationship, and they lose their family ties. Having a preoccupation with neurobiology, what does relapse means to the brain? And what kind of changes which happens in different parts of the brain? These are all the work we did probably about 15, 20 years ago, still valid because there is nothing more which has come in. So we looked at what are all the hospitalization, which are those patients who have increased hospitalization, what's happened to their different regions of the brain. We also looked at the brain volume loss associated with the increased social needs with schizophrenia patients. And finally, what happens to the volumetric analysis in the brain? Are those patients who are more disorganized have different kinds of disorganization compared to who had lesser disorganization? And similarly, good outcome versus poor outcome, what happens to the different regions of the brain? Again, each one of them becomes a huge lecture by itself. This is just, as I said, a bird's eye view. I'm not going to spend time. This is a very important issue which all of us need to be know. This is an undergraduate slide talking about the functional outcome and the negative symptoms. Simply, patients with negative symptoms have reduced eye contact, reduced speech, and reduced interest in activities of daily living. They present to us as poor grooming, reduced affective responses, and a reduced social drive. What does that mean to real life? Very obvious. A lot of work has been done to try and understand why serotonergic and dopaminergic interactions have a significant role to play when we talk about negative symptoms. Again, these theories have not really stood the test of time. For me as a clinician, this becomes a lot more relevant, which is, if you were to have severe positive symptoms, or how about I treat my patients? If somebody were to have moderate to severe positive symptoms, all that you do is adjust the antipsychotic therapy, reduce stimulation, consider clozapine if 2 or 3 antipsychotics don't work, and use other agents. But if the person has medication-related side effects, my goal would be titrate the antipsychotic dose and, if possible, switch to a different antipsychotic profile. The person has presented predominantly with the depression or mood-related symptoms, and if he is on a first-generation antipsychotic, switch over to second generation, if need be, add an adjuvant of antidepressant therapy. The person were to have comorbid substance use, you probably treat both of them simultaneously, and if there is a social deprivation, you probably think about a lot of social interventions, particularly in those specific skills which will increase social activity and skills training. The point which I want to really emphasize, drive home today, is the disability in schizophrenia starts actually much before the onset of psychotic symptoms, and they progress. The most important symptom for me is the cognitive symptoms and negative symptoms, because they are the cause for the burden and they are the ones which will persist. Good thing about cognitive symptoms is, after a while, it is not like dementia where the decline is progressive. It does have some degree of plateau which happens. The tools which we have today essentially addresses the positive symptoms. Why are they important? End of the day, what matters to our patients is their functional outcome. Do you have any understanding of how the recovered and non-recovered patients are different? This is a huge meta-analysis which looked at 3 broad areas: those who are whether got back to their work or education, or they got back to their stable relationship. And you will really see here 1 in 7 patients with schizophrenia who have not had a significant recovery are the only ones who got in. This is the best possible circumstances. Whereas those who had a significant improvement and good management strategies, literally up to 2/3 of them have managed to get back to work. Social relationship still remains only 1/3, which means a lot of work needs to be done other than simply pharmacological interventions. Again, this has been subsequently looked at by a long meta-analysis, which I'm not going to details, except saying that targeted interventions in a community mental health service probably is the way to go forward. I'm not going to spend a lot of time. We have an expert today to talk about this later, but for the completion, cognition probably is a very important issue. We talk a lot about cognitive remediation therapy. It's an expensive strategy according to me. The Premier Institute can afford it. If you really look at the number of patients we see in a day-to-day practice, CRT becomes only a hope. We do have a lot of digital technology, and the digital technology does help. On an optimistic note, there is a consortium of cognitive deficits in schizophrenia, and the phase 3 trials are about to complete, and there are a couple of promising molecules which my understanding is second half of next year is likely to be approved by FDA. And if this were to happen, our clinical assessment of schizophrenia will completely change. We no more get morbidly preoccupied only with phenomenological understanding. What I taught 30 years ago or 20 years ago, I have to forget. The whole focus needs to be, what does that patient want? How do I identify these clinically significant cognitive symptoms which causes functional impairment pretty early in the course of illness? Accordingly, your goals of treatment will change between acute and chronic phase, and the treatment needs to be optimized in each individual to improve outcome. I'm not going to spend time for the want of time. Just for very first years, there are activating and sedating side effects. We have cardiovascular, metabolic, sexual side effects. In antipsychotics, how do I classify, and in a given patient, what side effects a person can accept, and accordingly you need to change. You also need to understand how over the course of illness the side effect profile change, and what happens in the acute problems may not necessarily consistently persist when somebody has continued to take the treatment. But bottom line is the bigger issues of stigma, bigger issues of getting them socially active and improving the quality of life is something should be the goal of every single person. These are the three important antipsychotics which are right now with the FDA. Hoping pivavanserin is extremely well known for perinatal related psychotic disorders, but probably is going to be used for other disorders like schizophrenia. Again, this is a huge story about non-adherence. What are those factors? You cannot only blame the patients. We have a lot of stigma related to the illness. We have treatment related issues and variety of environment and relationship issues which complicate the whole concept of non-adherence and partial adherence in schizophrenia. When it comes to psychosocial intervention, we don't have a single tool. You look at the profile of the patients and you tailor the intervention according to what are the significant issues. And here is a picture which essentially tells you what are all the domains you really look into a person's social life which you need to think about in the practice. We all talk about psychoeducation, but what is that we talk about in psychoeducation? That is not really spelled out, and it's only recently people have come out with the importance of early warning signs of relapses should be a mandatory activity in every psychoeducation process, and the best thing to do for a evolving mental health professional is to give them explicit what are the do's and don'ts when it comes to psychoeducation. Early warning signs of relapse need not necessarily be psychotic symptoms. They are often non-specific symptoms, and I've talked about thought, perceptions, and behavior here makes much more explicit from a psychoeducation point of view. With that, we have a number of unmet needs in schizophrenia. Negative symptoms and cognitive symptoms, the comorbid medical conditions, breakthrough psychotic symptoms, substance use, apart from that, the residual positive symptoms. When we talk about recovery, recovery has a huge gamut of number of things which you really look for, and word about what recovery is. You have two kinds of recovery we talk about. One is recovery from illness, which is an absence of illness, versus recovery in illness, which is being in recovery, which means a process of how does our given person learn to manage his illness more effectively, has a more meaningful life in his community to go ahead, move ahead in his life. So the successful outcome of positive symptom is not a predictor of social functioning in schizophrenia. So to me, recovery function is very simple. These are the 4 goals. Apart from symptom remission, get him back to school or get him back to work, let him get back to a peer relationship, and get him to lead an independent life. Very simple. The reality is you really need a comprehensive, continuous, coordinated, consumer-oriented service in order to do this. Do we have that? Probably not. Even in the best resource countries, this is only a dream. What we need is this dream. This is a nice picture which demonstrates how a psychiatry unit should look like. This is a nice picture drawn by one of my colleagues, Neil Phillips. He does everything in cartoons and presents that. So, summarize, we have a number of unmet needs, and more than half of patients perceive an unmet need during the past year, suggesting that's a big issue for us despite all our understanding of schizophrenia. Make it simple: social and family, physical health, getting back to work, and living arrangements. And all that you do is to match to what that patient requires and how do I address that. So you essentially work like a traffic control police. Identify what the issue is, identify what the goal is, how do I get there. And let me move on to why schizophrenia or psychotic disorders in mothers are quite different. We have a huge lecture today by someone this afternoon, I think. Yourself, yes. So I'm not going to steal his time, but to give you just a slide or two talking about there are specific changes even in the brain during a motherhood period in a normal person who is likely to have a significant gray matter changes. We also have a number of hormonal changes which you're going to hear a lot more details. And what does that implicate in the management of psychosis? You will have an hour to discuss on. You are also going to learn probably a lot of risk factors specific to perinatal period, which I'm not going to spend a lot of time on. But it's important for us to recognize 5 important issues. As every clinician needs to understand what are the possible symptom variation during the menstrual cycle and perimenopausally, you need to inquire about menstrual irregularities and related symptoms in every single person who presents to mental health interventions. It's important to talk about sexual side effects, indiscriminate sexual activities, birth control, and you also need to inquire about unprotected sex. And we're talking about my favorite area. Again, we have a separate lecture, so I'm not going to spend too much of time. But the challenges in old age. We really don't have a specific diagnostic criteria for a late onset schizophrenia. We have a huge problem of cognitive decline as an aging process, which makes things difficult. What is a late onset? What is a very late onset? How does it change? What are the different phenomenological differences between somebody who develops psychosis as a late onset versus somebody who develops as a adult onset illness? And lastly, the plethora of cognitive symptoms, which of those are natural aging process, which are probably are indicative of early dementia, which are of indicative of psychotic process. One thing we consistently know about old age is the social isolation. The way late onset psychosis in schizophrenia occurs in female is quite different than in males. Again, the structural changes. We see probably a lot more structural changes, including the white matter changes compared to those who did not have psychotic symptoms. What does that mean to us in clinically? Does that respond to directly to pharmacological treatment response? The answer is completely not convincing as yet. Again, people have made an attempt. This is almost 25-year-old classification system. The fact that there is nothing revised on this tells me that a lot of research needed in this area. There's a lot of clinical work which people have looked at. How are the early onset schizophrenia different from late onset schizophrenia and very late onset of schizophrenia? From a phenomenological and a clinical point of view, but what is more important to us is to know at what stage, what kind of a pharmacological intervention you need to do, and what are the prognostic issues. There are a number of differences clinically between adult onset versus late onset. Again, they are all good to understand as a clinician. The challenge for us as a common clinician is when a patient asks, okay, how does this change with respect to pharmacological interventions? How does this change with respect to, can you really predict what is going to happen? Answer is, I don't know. So, what I do normally in my practice is to tell them that I don't know a lot of things. Confession upfront. However, my job is to work with you with what I know. And this is where I talk about the differential diagnosis, a possibility, put them on the plate, tell them this is what is. Let's become a partner with you in your journey of psychosis and figure out what really works best for you. That I still managed in 1 hour. Thank you very much.
Thank you so much, sir, for incredibly insightful and inspiring presentation. Your expertise and wisdom have truly enlightened us all. I now request Dr. P.V. Bhandari, our chairperson, to provide his insights on the session.
Sorry.
At the outset, I thank Dr. Nagesh Pai sir for a very lucid presentation. So, in fact, if you look at the whole presentation, it was a bird's eye view from childhood to old age. How this psychosis, though we think we know a lot about it, but very little is known and very little is under our control. And in fact, if we look at it properly, only 1 in 7 psychotics, they recover fully. So these are certain things which are eye-openers, and especially for our newcomers. You should know that this psychosis, though it is our bread and butter, many times it is very jammy. It's not so easy. And of course, the presenter has very lucidly pointed out how if you look at even the childhood psychosis, we think that the psychosis starts by the age of late teenage and early adulthood, but the manifestations are there very early. And in fact, he has discussed in detail about the things as clinicians we should bother about. One is, apart from the treatment, why there is poor response, and of course our failure in utilizing non-pharmacological management, then importance of rehabilitation, and we are not able to give much towards improving the quality of life of our patients, and of course a lot of unmet needs which exist. So what actually fascinated me was his talk about this particular this one about recovery from illness versus recovery in illness. This is something we all need to think about. And the last part, when you this old age psychosis, even now generally our tendency is whenever somebody presents with psychosis in the old age, we most of the time think it is dementia. But so many times I have seen, even in my clinical practice, and I am sure sir will also agree, and other clinicians here, we start noticing that with the low dose of antipsychotic, this patient starts improving. Then we realize it might not be dementia. So this is one more thing, and as sir rightly pointed out, very little is known about this old age psychosis. And of course we get confused because of the cognitive deficits which are age appropriate, and also the social isolation which is existing in old age. So overall, as when he started, he pointed out that he is going to run through whatever is going to be discussed in the CME, and I think he has done a good job, and I don't think we would have found anybody better than Nagesh Pai. He hails from Brahmavara, which is very near to Kota. I am reminded of Kota Shivaram Karant. In a way, when it comes to knowledge and when it comes to presenting things, I don't think our Dr. Nagesh Pai is no less than Shivaram Karant when it comes. And he has, they say in Kannada, Kosha Odi Nodu, Uru Sutti Nodu. He has done both. And he has done justice to this topic, and I feel really honored that he is my teacher, and I thank Dr. Nagesh Pai for this lucid presentation, and I request the audience, especially the new PGs and all, it's the time for you to in fact think on important things sir has told, because see, we have all lived with this risperidone, olanzapine. In fact, I will tell you, when I finished my PG, that was the time this risperidone came into market. So my teachers were excited, we were more excited, thinking that, and we were noticing so many patients are improving. Now, if you ask even my teachers and also my contemporaries, many times we now wonder what these drugs are doing. So don't think drugs only can do anything. This is what is the message Dr. Nagesh Pai has conveyed. And of course, our own lot of things we need to think of, which we are not doing it in routine practice. Again, for our own reasons, maybe the lack of time, many times lack of knowledge, because what the mind does not know, eyes will never see. So that's where so many things are happening. So I open the floor for discussion. ಶ್ರೀನಿವಾಸ್ ಕ್ವೆಶನ್ ಕೇಳಿದವ್ರಿಗೆ ಒಂದು ಸ್ವಲ್ಪ ಮಾರ್ಕ್ಸ್ ಇಟ್ಕೊಳ್ಳಿ ಈಗಲೇ, ಅವಾಗ ಕೇಳಕ್ಕೆ ಶುರು ಮಾಡ್ತಾರೆ.
Sir, today's presentation on these sessions, that is who to talk, is aptly fit into your presentation. So I thank you, sir. It is for many years I am listening to you. What I could understand is that the first day I became your student, you told me the one word, that what you have learned, you have to unlearn something and you have to learn new things. I think I continue to do that till today. So it is very important that whatever you have learned so far about any, it may be a subject, it may be a disorder. So every day is a learning for us. So whatever I could do, I just missed the first part, because I came a little late, but whatever the presentation is, it was excellent. I have a few things to want to ask to you, sir. The many times, like we see the psychosis is right from the childhood to the adulthood, right, for elderly also. The most enduring problems that we come across is like suppose you say is schizophrenia as a personality disorder, like you say paranoid personality disorders. This most often come because I work in the government setup. Many times the judicial people will ask. Sometimes we are diagnosed with paranoid schizophrenia. So, paranoid personality disorder. So, is it a illness or not? Whether we should take it considered as a illness, as a immunity of the for the judicial proceedings. That's the main thing that comes to my mind. Whether they are asked definite this question. So, whether we consider the paranoid personality disorder as a continuum of the illness. And the another thing is that beautiful carton. I think you mentioned about Neil.
Even I also.
I was very impressed about this part, sir. And what you observed when they delivering the services at the government level, even at the grassroots level, it may be the very primary care level, is that main problem you have identified is the continuum of the drug delivery to the patients. So we have seen that many patients, we don't have any uniformity of a drug delivery systems throughout the nation. So what is my opinion is that the drug delivery should be a single window and uniform. Many patients who discontinue medications, they go to the other, they don't get the same message. Medications, discontinuation, illness also gets relapsed. So these are the main things with respect to the psychotic disorders. Just I want to have some opinion from your understanding across the globes.
Yeah. Let me start off with the very first thing which you talked about. I still believe in one thing. One of the earliest things which I learned in my psychiatric career is there are two things we do with our teachers. One is what to do. What we learn better is what not to do. So each one of us are brainy enough to learn what mistakes our teachers do, right? And not to make that practice again and again. So, coming to your paranoid personality disorder, thankfully, in the last 2 decades, there's a number of longitudinal studies have been done on everything. And I'm really fascinated to look at the evolution. While I'm a huge critique of classificatory system, as you very rightly pointed out, non-mental health professionals often hold on to them as Bible. On a good note, if you look at ICD-11, there is only one personality disorder called personality disorder. All other subtypes of personality disorders have been vanished. So we don't have to worry. We can always tell legal system that we follow the latest. We look at ICD-11. ICD-11 has one section called personality disorder. At the most, for satisfy those who are a big proponents of borderline personality has come as a specifier at the most with no validity. So that's a very positive change, because personality disorder, even in immediate past classification system, whether it's ICD-10 or DSM-4, 4R or even 5, the reliability of any of those personality disorder was with a kappa value of maximum 0.35, probably the highest being borderline personality. All the rest have a kappa value of less than that, suggesting a very poor reliability. This is despite using an instrument like IPDE, which will take 2.5 hours just for administration. So that's a good news. So we don't have to worry about it now. We can say, latest, he has a personality disorder, full stop. Are those personality disorders like schizoid personality? They have nothing to do with schizophrenia. Schizotypal personality, what was construed, probably has a higher prevalence among those who are having a history of schizophrenia. But today, that correlation is also being questioned. Is it a personality disorder at all? That's another huge no is an answer for that. Coming to the continuum of antipsychotic care, my approach over the years have changed. Now I tell my patients that I am your partner. You are the sufferer. You are like a driver. I am a pillion driver. I am with you in your journey of suffering. The word patient actually has come from the word compassion. Somebody who gives a passionate care. That's how the word etymologically has come across. So as a clinician, all that I do is I am in your journey of your suffering to support you, guide you, but you are the driver, which really gels well with a lot of patients. It helps them to establish a good rapport with us. Right? So our job is to motivate them. You probably can even use motivation interviewing, very effective tool to learn, to practice how to improve adherence. Not a huge therapy, but really very effective. Thank you.
So thank you for that presentation. It was really wonderful. From presentation, some questions arise in my mind. So as you said, the schizophrenia starts from before birth, from home. So does our traditional social system has an importance in preventing schizophrenia? First question. Second is, are we moving away from that social system? That's why we are seeing more number of cases of mental disorder and mental illnesses. And what about the resilience in childhood, which plays a part in preventing these illnesses or maybe improving these illnesses?
All are very, very valid questions. The first is about what do you do? Is the social factors responsible? Obviously, it is very obvious that we are not attuned with the social situation. I think role of a mental health professional needs to change from just pharmacological intervention to spend a lot of time on public health education. When I say public health education, it starts from educating ourselves. How much importance really we give in understanding the societal changes, and it's really difficult to get an idea about social changes. Let me give an example. Right now, worldwide debate is on ADHD, adult ADHD, and in the Western world, our referral have increased by 20 folds for ADHD. I don't know what's happening in India. Everybody wants ADHD. They come, they do an online check and say, I have ADHD. Some of those brightest of the brightest, 99.9% medical students who scored 99.9% and then come and tell me I have ADHD and fulfill the criteria, justify why you should not be giving me stimulants. And their justification is completely valid. The question is this inattention is a consequence of things which are happening around the social milieu which I don't have an answer. 2, is it because we have a number of other disorders where we have not been successful in managing with our tools, which is either psychotherapy or pharmacotherapy? Take an example of borderline personality or any personality vulnerabilities. For that matter, even mood disorders, our treatment response is not the best. People have to live in the mental health with chronicity, and they want a quick answer, and there is no answer. So, if there is a hope of taking a medication which can cure my problem, things are going to be much better. If you ask me how many referrals I get from psychologists, 85% of the referral actually is instigated by psychologists. Because does that reflect a failure in finding the optimized treatment to our patients? Is that increasing the seek for help? The third question is, are we really competent to deal with the socio-political issues? Right? Apart from Dr. Bandari, I don't think any one of us really worry about the social causation. He violently speaks up the social issues and makes it a point. I think if each one of us do, and I believe it's a need of the hour, that we also learn leadership apart from getting a good social dimensions. And that's why I say every question which you asked is
Virupaksha, last question. I think he's already with the mic, so I don't want to disappoint him. This will be the last question because already we are in want of time.
No, actually there is no questions. While sir was presenting, I made some notes to ask, but at the end of the session, I remained silent, and many of us would be feeling that what are we doing? So finally, sir has led us to, every time when we meet Dr. Nagesh Pai, sir, we go back with that silence, that unlearning process starts, and what has to be done again freshly. We should thank the organizers for calling him here, because we could hear at length 1 hour lecture on detailed discussion about psychosis, and coincidentally today is Guru Purnima day, so we owe a lot to you, sir. We give a standing ovation to the knowledge you keep giving us every time you come to India, and we are indebted to you for your knowledge sharing whenever you find time to. Thank you so much.
Now, I would like to invite Dr. Srinivas Bhatt sir to present a small token of appreciation to our esteemed speaker, Dr. Nagesh Pai sir.
I now invite our Associate Professor, Dr. Shishir Kumar sir, to present a token of a sincere appreciation to our Chairperson, Dr. P.V. Bandari sir.
We now move on to our next session, which focuses on a critical aspect of adult psychiatry, rehabilitation services for persons with severe mental disorders. It is my pleasure to introduce our esteemed speaker for this session, Dr. Krishna Prasad M., who will share his valuable insights on this important topic. Our session will be guided by our distinguished chairpersons, Dr. Nishi Guru ma'am and Mr. Praveen Kumar sir. Please join us in extending a warm welcome to Dr. Krishna Prasad M., Dr. Nishi Guru and Mr. Praveen Kumar as we embark on this enlightening exploration of rehabilitation services.
ಪಾಯಿಂಟರ್ ಇದೆಯಲ್ಲ ಸರ್, ಅದರಲ್ಲೇ ಇದರಲ್ಲೇ ಮಾಡ್ತೇನೆ, ತೊಂದರೆ ಇಲ್ಲ, ಅಲ್ಲಿ ಇಲ್ಲಿದ್ರೆ ತೊಂದರೆ ಇಲ್ಲ.
It is my pleasure to introduce one of our esteemed chairpersons, Dr. Nishi Guru. Dr. Guru is a consultant psychiatrist at Mangala Healthcare Center, Padil, Mangalore, and brings over 20 years of experience in both clinical and academic psychiatry. Since 2021, she has been serving as a consultant psychiatrist and previously held the position of assistant professor in the Department of Psychiatry at K.S. Hegde Medical Academy. Her early career includes works as a junior resident research associate at NIMHANS Bangalore, and she has a substantial experience in rural psychiatry and rehabilitation care. Dr. Nishi's areas of expertise encompasses adolescent and adult general psychiatry as well as neuropsychiatry. We welcome you, ma'am.
Please join me in welcoming our second chairperson, Mr. Praveen A., who is affiliated with the Department of Psychiatry and Home Belako Psychiatric Rehabilitation Center at KMC Manipal. Mr. Praveen holds a master's in medical and psychiatric social work and MPhil in psychiatric social work from Manipal University and is currently pursuing a PhD at Manipal University. With 14 years of experience, his expertise spans community mental health, psychosocial rehabilitation, psychosocial interventions for persons with severe mental illness and their families, suicide prevention and mental health research. We welcome you, sir. We now invite our esteemed chairpersons, Dr. Nishi Guru and Mr. Praveen A., to introduce our speaker for this session, Dr. Krishna Prasad M.
Good morning, everybody. No response? Okay. Yeah. First of all, I'd like to thank the organizing committee, Shema Psychiatry Department, for giving me an opportunity to be one of the chairpersons. And it's a pleasure to be a part and parcel of this team, wherein Dr. Krishna Prasad will be talking about basically rehabilitation services for the persons with severe mental illness. Coming to the curriculum vitae of Dr. Krishna Prasad, he's been a professor of psychiatry and currently he heads the psychiatric rehabilitation services at NIMHANS Bengaluru. His field of interest has been primarily in psychiatric rehabilitation, geriatric psychiatry and acute care psychiatry. He has worked in pioneer institutions like AIMS Bhopal, AIMS Vellore, NIMHANS, AJ Hospital and KS Hegde Medical College. He did his MBBS from Bangalore Medical College, and after that he specialized in MD Psychiatry in National Institute of Mental Health Neuroscience, NIMHANS. He's worked in various other places as well, which I think I've already mentioned. Also, he has done a fellowship in emergency psychiatry in NIMHANS. So, he's got a strong basis in biological psychiatry and neuropharmacology. This is because I've been his contemporary and I had the opportunity to work with him and observe and be a part of his working experience in KS Hegde Hospital. This is about Krishna Prasad very briefly. Okay. Now I think Praveen will have to tell a few things about Dr. Krishna Prasad and his experience.
Yeah. Good morning. Thanks for keeping this topic as well as inviting KP sir as a speaker. He is the right person to talk about rehabilitation. Since I'm associated with the rehabilitation, the people, trainees as well as my mental health profession friends, usually they will ask, those are the patients having illness 20 years, 25 years, having chronic mental illness, persistent symptoms. Now what are you doing with them? Are they going to recover? Maybe in the previous presentation Pai sir has mentioned about recovery of those patients. So I think sir will present about rehabilitation is the umbrella term. Under that, what and all psychosocial interventions usually we will carry. So those things sir will mention. Maybe after that we can have a discussion. So over to you, sir.
Thank you, Praveen. Hope I'm audible.
I think you have some 45 minutes of time for that. And then question and answer session follows that.
So I think there are three important messages which Dr. Nagesh Pai gave in the presentation before this, and I think those three important messages are quite crucial to understanding how we manage and care for people with severe mental illness. I think one of the first things that he spoke about is about the effectiveness of antipsychotics and the limitations with the use of antipsychotics. So a whole lot of patients respond to antipsychotics, and there are a large number of patients who don't respond also to antipsychotics. and we somewhere have to mitigate their suffering. The second thing that he mentioned is there are certain forms of presentations like the positive psychotic symptoms that respond well often to medications, and negative symptoms and cognitive symptoms don't really respond very well to antipsychotics. The third thing which was very striking for me was that have we transferred care from the hospital to the families and to the communities. I think that was a very evocative statement that he made, and probably I think somewhere we never had a structure for psychiatric rehabilitation anywhere, including at NIMHANS. So what I'm going to present is more like what we have understood what should be a part of rehabilitation services at any institute or at any place. Now, I struggled to find a good definition of what psychiatric rehabilitation is. This by Helen Gillespie, who is a professor of rehabilitation psychiatry in UK, probably is the closest that we could understand as relevant to us. So it says, it emphasizes certain words like whole systems. So I think that picture, that cartoon from Dr. Nagesh Pai's presentations summarized the importance of the entire intersectoral coordination that is required as far as rehabilitation is concerned. And he focused on another word called recovery from mental illness and recovery in mental illness. I think this also is an important word when you look at psychiatric rehabilitation. And another important facet or important aspect is looking at the quality of life of people that we deal with, health-related quality of life. An important issue which people with mental illness face is social exclusion. So bringing them to the from the marginalized status to a more mainstream society is an important part of rehabilitation. Now, in our context, more and more we are looking at people who are asking for being treated as collaborators or as partners in treatment. As Sir mentioned, I think more and more we realize that as we move ahead in times, we no longer cannot take a very patriarchal, very fatherly kind of a clinician position. So rather, we are looking at autonomous individuals who are capable of taking decisions for themselves. And most important aspect of any treatment when they come to us is hope. I think somewhere we should be providing hope to people if we were to be good providers of therapy. And large number of our people struggle to live in the community. So support for living in the community is an important aspect that one has to look at as far as rehabilitation of people with mental illness is concerned. I think this definition summarizes what we should do as clinicians when we look at people. And I think the system is also responsible to provide some of these services. Everything cannot be done by us. When we look at people who come to us, at least in NIMHANS, in the psychiatric rehabilitation services, we see predominantly non-responders or people who don't respond well to treatment. Like Sir mentioned, more than a third of our patients don't respond at all to medication. And in such situations where people are non-responders, interventions are difficult, there is very much a challenge to look at evidence-based. So there is very little evidence-based, or evidence-based generation becomes very difficult. Challenges that usually accompany people who are non-responders are developmental issues or personality issues, like Dr. Koski asked that question. So personality issues are, people who have personality issues are likely to break relationships, are likely to have challenges of living in the community, and added to that, if they have psychosis, then it becomes a major challenge. People with autism or people with intellectual disability and who develop psychosis, again, these are another category of people who have challenges. One important fact which he brought out in the domains of schizophrenia which was again very striking for me, was that he included physical health. So we often ignore physical health in the context of mental illness. I think multimorbidity is now the norm across all illnesses and not just mental illness. This is something that one of our patients said, if life is possible, recovery is possible. And in this journey of recovery, you see that there are barriers in terms of negative symptoms, depression, expressed emotion, discrimination that happens, financial difficulties, side effects, poor insight, impulsivity, and the lack of opportunity in the society. So there is a large gap between what we define as remission and what people experience as recovery. It is important that we divide bridge this gap, this divide that is there between remission and recovery, we bridge this gap. Rashmi is probably now working in Father Muller Hospital, earlier working with Praveen in KMC, as a part of her fellowship in psychiatric rehabilitation, she qualitatively asked to people as to what do they mean when they say they have recovered from illness. Some of them said it is cure from illness. Some of them said it is return to normalcy. Some of them said holding a job was very important. For some, simply being happy was recovery. For others, it meant being independent, being active, leading a better lifestyle, feeling in harmony and peace. So we see that people have a very personal definition of recovery. So what we think as recovery may be very different from what people actually think as recovery means to them. We have a lot of policies in the country. I mean, we have the National Mental Health Policy, which came out in 2014. Probably for the first time we had a policy ever to guide us. We have the Rights of Persons with Disability Act 2016, which probably talks about as a disability and recognizes it on par with other physical disabilities. We have the Mental Health Care Act of 2017, which again talks about rehabilitation, emphasizes rehabilitation. We have a special department from the government, the Department of Social Justice and Empowerment Ministry has a special department for persons with disability. So we do have framework and a system to help people from the government and policy statements to guide us. Now, one of the most important facts that I have realized while working for people with severe mental illness, at least in a hospital, government hospital setting, is that we do see a large number of people who face homelessness, and many of our patients are institutionalized. And majority of the patients who come to us as unknown are actually people with severe mental illness or those who have intellectual disability plus severe mental illness. And there is no place for us to send them to. For example, we do encounter family reintegrations happening, but they are far and few. And there is always a risk of them getting institutionalized in another setting, in an NGO or in another long stay facility. So there is always this risk of institutionalization or reinstitutionalization that they carry. Now, this was an important survey which was done in 2019 because even the government recognized this as an important area to look at, and Hans Foundation funded this survey, which was done with the Ministry of Health and Family Welfare and conducted in 43 states, 43 hospitals, psychiatric hospitals across 24 states. It is important that you note that more than a third of these people were staying for more than a year in these hospitals, and the median stay was 6 years in these hospitals. And more women tended to stay in these hospitals than men. If you look at the figure there, 93.5% never stepped out of the hospital during their stay in the hospital. So you imagine staying in a hospital for such a long time without being exposed to the outside world. And only 15% were engaged in any kind of skill acquisition. So I think this highlights the challenges that people who get institutionalized face. We also did a survey because the government was concerned about homelessness in people with mental illness, and Supreme Court kept giving strictures to the government to look at means of addressing them. So suddenly, all of a sudden, the Chief Secretary decided that we should fund a study which looks at people who are homeless and living in institutions. So in Karnataka, there were, according to our assessment, 144 facilities that provided shelter to people with homelessness. So we enumerated 9,000 people, and around a third, 3,190 had severe mental illnesses amongst these people. So it's almost a third. We may have missed many, but it is possible that it may be closer to 5,000 that these people may have had severe mental illnesses. And again, here if you look at it, it is mean duration of stay was nearly 5 to 6 years that they were staying in these hospitals. But the good part is that district mental health program was reaching to these facilities, and nearly 82% of the participants, at least amongst the 3,000, were on some form of psychotropic treatment. So psychotropic treatment is happening even in such situations. Ministry of Women and Child Development also wanted to look at what kind of challenges do women who stay, because they run 8 state homes and 4 reception centers across Karnataka. And again, a large number of their patients are people, a large number of the inmates there are people with mental illness. So nearly 60% of their patients had severe mental illness in this women and the state-run homes for women. Again, the mean duration of stay, imagine they are staying there for 10 years. Again, very little autonomy, they don't get to go outside these places. We have a lot of changes because of the new RPWD Act that has happened, and a lot of action from the government in terms of getting disability certification done for people. But even in government settings, less than 30% of these people had disability cards. And when we looked at their quality of life, it was much poorer when compared to people who did not have mental illness but were living in state homes. Majority of them wanted to go back to the family. So if you ask people, do you want to go back to the family, despite the fact that families would have abandoned them, they all want to go back to the family. And our health systems, our social justice systems are not geared to helping these people get back to the family. 1/3 of them were mothers actually. They were having children but not living with children. So these are all the challenges that are there when we look at people with severe mental illness, and sometimes you worry as to what, you see clinical situations where you see patients, parents are aging, you don't know what happens to them next. So I think these are situations where we feel very bad that we are not able to alleviate people's suffering. So we, even a premier institute like NIMHANS did not have a halfway home. So again, it is because of judicial activism, because of some intervention from the director, that we looked at whether we could start a halfway home for people with mental illness, primarily those who are overstaying in our closed wards. So we have had a fair bit of experience of family reintegration for these patients. Even people who have stayed for more than 20 years, we've been able to trace families. So I think vocational rehabilitation is another important aspect that we have considered while looking at the halfway home facility. Our experiences are very limited to the last 2 years. There are other organizations like RFS and Medico-Pastoral Association which have run halfway homes in Bangalore for a long period. But again, they cater to a clientele which is primarily middle class or the upper middle class. So those challenges of making these affordable for people who come from lower socioeconomic status is another important challenge that we see. Work is something that Sir mentioned amongst the 3 things that they looked at when they looked at functional outcomes. Work was a very important thing, and work is very important for people with, all of us work is very important, but particularly for people with mental illness, it is a challenge to get back to work. And if you look at recovery now, even the definition that Sir was giving, I think work is central to the paradigm of recovery from mental illness. So again, Rashmi's contemporary did a qualitative study on what is quality of life for people with schizophrenia. So I think work stood out as the foremost amongst what patients felt is important for their quality of life. So one of them said, when you have some job, then you have some responsibility, you will have some dignity, and you will also have some income. So it is not so much about income alone, it is about some social standing that they get, self-satisfaction, and also about building self-esteem, improving their social life. I think from all those facets, work is a very important aspect as far as recovery is concerned. So one more of my thesis students looked at what kind of, we do see in Bangalore a lot of people with professional degrees and having severe mental illness, and they face a lot of challenges in either joining their IT job or joining their management jobs or joining, some of them even doctors joining, getting back to work. I think what seems to matter is facilitators when vocational challenges are looked at. I think personal strengths, if they have individual strengths, they do well. Those who have good degree of social support, those who get an accommodative work environment, and sometimes disclosure helps. In some cases it does not help, but in some cases disclosure of mental illness helps. And one crucial factor is support from mental health professionals while they are working. Our assessment should not necessarily stick to symptoms, but also about other dimensions of life. Barriers are again symptoms, relapse, side effects, poor social support. Those who have had poor academic achievement even before the onset of illness, they are likely to not do so well in the future. So for everybody, work may not be a goal. For some work, they may not be job ready. They may require some degree of engagement through the day. So they should have something to do instead of being at home and not doing anything. So one of the solutions or one of the approaches to such situations is providing some degree of structure to the day through a daycare center. So there are different types of daycare centers. You have work-oriented daycare centers and you have meeting-oriented daycare centers. You have multitude of opportunities of graded vocational training that can happen here. And people also build a larger social network. They also may sometimes assume a worker role because you have to come at 9 o'clock, you have to go back at 4 o'clock. So the people who provide such services usually are occupational therapists or social workers, and you do have doctors who pitch in once in a while to support these patients. At NIMHANS, we have 11 training sections, and at this point of time, there are more than 130 people from in and around Bangalore who come to attend the daycare centers. And we again look at providing a structure to the day, some degree of vocational training, cognitive retraining, recreation, social skill training. These are some activities that our patients learn. So some of the new initiatives that we have looked at is providing opportunities with the help of NGOs, non-governmental organizations. Everything the government system probably will not be able to achieve. So partnering with non-governmental organizations becomes important. And particularly one of the initiatives I would like to highlight is looking at producing holy color and rangoli powders with discarded flowers. So again, the profit generated from this is usually distributed back to the patients. We recently also started a cafe which was run by patients and caregivers. Again, this experience has been enlightening to us because there are several challenges as a government system that we had when we ran this. Similarly, there was a lot of appreciation that patients and family members gave in terms of opportunities that they got, and also some of them were able to generate income. So it was a source of income as well in the process. So similarly, I think Karnataka government also looked at starting daycare centers in district headquarters in Karnataka, but I don't know to what extent it has been helpful, but I think Kshema also at some point was running the daycare center supported by the Manasadhara services. One of our students looked at the challenges that are there in Manasadhara services. I think inadequate and untimely fund release from the government. And when we ran this in Chikbalapura, we had several other bureaucratic hurdles that we had faced. So I think though the intent of the government is there, there are a lot of practical challenges that are there when we look at implementing what we think is important, like Manasadhara daycare services that was there. Similarly, government-run halfway homes are there in two places. They are called Manasa Kendras. Again, they have their own unique challenges. So when we look at work and employment, the traditional approach has been to people with mental illness is to look at train them first or retrain them first and then place them. But in the high income countries now, they are looking at placing and training people. I mean, you place them back to the job that they have lost and then again train them. So there is stronger evidence now that probably place and train model works when compared to the earlier train and place model. So with this in background, several high income countries run supported employment programs. Supported employment programs are where people are put back into competitive employment, and there they are provided some kind of support by the mental health system and allied services. Again, they get to choose what they want. They have to keep that, and they get help in keeping that job. One specific form of supported employment program called as individual placement and support. If you look at current evidence base, probably amongst all the psychosocial interventions that are there for people with schizophrenia, individual placement and support has the maximum evidence. But I mean, these are the important criteria that one has to fulfill. That is, you should look at providing rapid job to a person who simply gets out of hospital and gets back to job. They should be in competitive employment. They should be provided time unlimited support, and they should be, they should get based on what they want to do. Important aspect of this is integration of vocational and mental health services. Again, these kind of services require a lot of human resource, a lot of non-medical staff to assist also. In the high income countries, they are also looking at whether adding other components besides psychosocial, like say for example cognitive retraining, which is relevant to the work itself, or social skills training which is relevant to the work itself, whether this can help. So there is some evidence to say that both cognitive retraining and social skills training, in addition to simply providing supported employment, can be helpful. So other aspects like motivational enhancement and illness management training are also probably important. So this is a meta-analysis which looked at the supported employment and what could be its effectiveness. So it not only impacted vocational outcomes, that is significantly better vocational outcomes when compared to treatment as usual, but also importantly non-vocational outcomes like quality of life, general mental health and global functioning. So the evidence is not very robust, but there is some indication that providing such services is probably useful in improving not only vocational outcomes but also non-vocational outcomes also. But again, now I think with more than 2 decades of their experience in the high income countries, they are questioning whether this is the right way to go ahead, because they are asking about the cost that is involved in it, because there is a huge amount of cost that is involved in this. And what kind of outcomes are they looking at? I mean, the outcomes that these studies look at is getting a job, but retention in a job is a major challenge for people with mental illness. Not only getting a job, but retaining them in a job is a major challenge. Now, the focus here is that everybody, I mean, at least in the US, the focus is on being economically productive. So economic productivity is the focus for everybody, whether it is ill or non-ill. So whether that logic itself is skewed in a way, because everybody should take personal responsibility to work. People with mental illness, some of them may not be able to work at all. So whether this logic is okay. So is there a better way forward? There are no alternatives that are currently evidence-based at this point of time. And from our point of view, I mean, we don't have so many resources. We don't have medical professionals. So where is the question of having enough psychosocial providers for this? So I think these are some challenges when we look at even so-called evidence-based practices. I think we need to question as to whether they are really going to help us. So one of our colleagues looked at supported employment in our context, whether we could provide with limited resources any form of supported employment to our patients. So before that we had to assess patients. So she developed a vocational potential assessment tool and a small counseling module. Now using this and looking at outcome at 1 year, she looked whether supported employment could make a difference to our patients. Of course, we don't have the resources. In the West, we do have vocational officers, we have placement officers, there are specialists who help them, there are job coaches, there are people who shadow them at work. All those facilities definitely are very difficult for us to have. So with the help of 2 MSW social workers, she tried to do this and primarily looked at assessing people for their work readiness, counseling them about work, networking and liaising with employers, potential employers. She reached out to more than 40 potential employers, and then training and placing, or placing and training, mixing both. And there are other services. Many of our patients require sometimes shelter to stay, a PG to stay to go to work, or say getting some disability benefits. Some of these services are also a part of providing support to people with mental illness. So at the end of 2 years, what she looked at, 32 people were employed. So of the 60 that were recruited for this study, 32 people were employed, and at least for 17 more, there were active attempts that were made to get them a job. But like I said, the challenge for people with mental illness is retention in job. So only the number of days that they were sustained in a job was only 60 days. So I think job retention is also something. So that is where in the West you have people like job coaches or other officers with the employer who provide support. And the reason for termination could be from having relapse to people being discriminative to people with mental illness. Now, as per law, non-discrimination is something that is mandated as per law in employment. So no government establishment shall discriminate against any person with disability in any matter related to employment. But in practice, there is a lot of difference between what the law states and what happens in practice. And there are people also, because of their own personality issues, bring up unique challenges in the context of this law as well. In government offices and in government settings, there is a mandatory requirement of not less than 4% reservation for people with disabilities, of which 1% is for people with mental illness, intellectual disability and autism and multiple disabilities. So it is 1% that people with mental illness get. Very often we get calls from the government of Karnataka asking whether these jobs are suitable to be reserved for people with mental illness. And most people, most departments want to exempt themselves from giving reservation for people with mental illness. So citing one or the other reason. So there is a law, but there are challenges to the implementation of the law, and the attitudes that people have towards mental illness also is something. Say for example, for village accountant, one of the reasons they gave was that these people with mental illness will become dangerous. They cannot talk to people in the village. They may hit them. So these are the kind of reasons that the government officials give while they look at denying this reservation for people with mental illness. So there is also supposed to be a special employment exchange. There is a special employment exchange, but we don't see any action on that front also. When people go to work, and I said job retention is a major challenge, the challenge that they have is that they don't get some adjustments that they require. We see that our patients are not able to get up on time because they are on antipsychotics that can sedate them, or that, because of several other reasons also they may not be able to wake up on time. So timing of the doses or regimen that is there. So all of these can contribute to challenges in them coming back on time, so to work. So whether they should be provided flexible working hours, whether we should give them breaks, sufficient breaks in between. So one of our students looked at what kind of reasonable accommodations. According to law, reasonable accommodation has to be provided for people with mental illness. So at least in government establishments. So in private establishments they have not mandated it, but in government establishments it is mandated that reasonable accommodation should be provided. So for physical disabilities, for example, you create a ramp, it's a one-time investment and you don't have to really make changes. Say for example, with people with visual disability, creating systems that addresses their, say, braille or some other voice to text kind of conversions, these are one-time investments. But for mental illness, it is human resource that is required. So people will not be convinced about investing in human resource, particularly when they are having economic challenges themselves. So I think these are some challenges that one needs to understand when one looks at government strictures or government orders as far as reasonable accommodation is concerned. We have had experience of working with several government organizations, non-governmental organizations in terms of placing people with mental illness. I think many of them have been very receptive. I think it is sometimes that we don't realize that there is a vast potential for engaging with people outside. So including corporates, because a lot of corporates look at corporate social responsibility as an important, inclusion and diversity, equity and inclusivity as important policies for them. So they do include people with mental illness, but it involves a lot of negotiation and bargaining with them. One of the other things that I thought may be useful, at least for an institute like KSECD, to look at whether there are some in-house services which are readily providable, like group-based social skills training, role-play-based social skills training. We have found that to an extent, at least some group of patients, it really matters to them, particularly if it is related to work and employment that is concerned. Sir was mentioning about the challenges with cognitive remediation and cognitive retraining. We have a computer-based cognitive remediation facility which is run by our clinical psychology colleagues. We've observed that at least in some cases there is some transfer of skills to real life settings. There are challenges that are there, and people have challenges to come to the hospital and get it. Home-based tasks can be provided, but the question mark as far as evidence is concerned is whether it really transfers to real life settings. At least to work you can tailor it and do. One other aspect which I thought is important is our lack of focus on very basic skills, like what we assume as things that people should know, that is activities of daily living. So instrumental activities of daily living is something that we can focus on when we provide rehabilitation services. So we had a nurse who looked at it in terms of providing this to our patients, and we found that it has been effective. So she did a systematic review before that, and she found that it improves both relapse rates and also functional outcomes. Besides functional outcomes, there are non-vocational, non-functioning outcomes also that improve. If you simply train people in, say, helping them manage their finances, in helping them, say, navigate bank systems, in helping them go use the bus or the metro. So some of these things can make functional differences to people. So, and it is only a nurse, a psychiatric nurse, who is able to do that. You don't require a specialized cadre. Of course, they should have some understanding of what behavioral techniques you might need to use to help people, and also provide some degree of social skills training. The underemphasized part which I wanted to mention is our lack of focus on physical health when we look at people with severe mental illness. So we did a multi-country survey of this. Evidence is actually primarily from high-income countries that people with mental illness have higher physical health related issues. From our country, probably we did 3-country study that from South Asia. We found that more than 60% of the patients were overweight or obese, and 20% of them had either diabetes or hypertension, and cholesterol issues in nearly 50% of the people. What is more important is that more than 3/4 of the people with these issues were not aware that they were having these issues. Again, that brings the back focus to our role and responsibility in educating people about several physical health issues that they may face, and our lack of focus, because our primary focus is only on mental health. We can again change some things to at least tobacco related behavior, which is very, very closely associated with illnesses like schizophrenia and bipolar disorder. So the prevalence being as much as 35 to 40% in our settings, I think we can make a difference if we address at least these addressable health risk behaviors like tobacco use. So one more of our nursing students looked at whether we could bring about some changes to people who are on antipsychotics but not yet reached a stage where they have metabolic syndrome, whether a nurse-led counseling can make a difference. She found that it was effective at 6 months in terms of several metabolic parameters. So we have the resources, we should use them probably to look at some of these under-addressed issues for people with mental illness. Increasingly in the substance use framework, you are getting to see a lot of use of terms such as recovery capital. Now, in the context of schizophrenia and severe mental illness, we probably are not in a position to assess what are these inter-individual community level resources, individual resources that we should tap in the process of recovery. I think one of our students is actually doing, understanding what can be such things that are a part of the capital that people already have towards recovery. Working with family members in our context is very important, and we realize that at least from the olden studies, and it is probably relevant even now, that our recovery rates are far higher as far as clinical recovery rates are concerned because we live with our families. So our families have several questions and addressing those become important. So from the NIMHANS Psychiatric Rehabilitation Services, we are running online programs every month, Road to Recovery programs. So if any of your patients are interested, we could send I could share it in the WhatsApp group. So every month we have Road to Recovery programs which addresses one specific issue that they want to be addressed. So a common concern which patients come to us and their family members come to us is what after parents, what after us when parents ask this question. So there is no straightforward answer to this question. It is very individual specific, individual and situation specific. So but this is a very important concern, and increasingly even in private practice you will realize, and in private hospital settings, what after us, and there are simply no solutions available to this. So I think as a group of people who address mental health concerns, I think we should look at addressing this important issue as well. Insurance cover from mental illness. Now I think though the law mandates it, the insurance companies and the third parties kind of try to ensure that people with mental illness are excluded. So we have to look at getting them enough coverage. I know that IRDA has had a meeting and will look at addressing some of these concerns that are there. Another question that we get asked from the family members is provide care at doorsteps. Now we don't have resources to provide care at doorsteps, but this is what family members very often want, because our patients don't come to hospitals for several reasons. Either parents are not able to bring them, or because they don't have insight. So can you provide care at doorsteps? We don't have such a system as of now in our country. So one of the family caregiver associations came up with a unique experiment, I would say, that 40 families got together and they bought a plot of land, huge plot of land, with their own money, and they looked at building houses in these plots and taking care of each other's patients. So suppose one patient's parents pass away, other family members of other patients will look at taking care of these family members. Again, whether this will succeed, what challenges they will face, their experiences alone will tell us. This is a book which has been written by, edited by Mr. Amrit Bakshi, who is a caregiver for people with severe mental illness. He's based out of Pune, and the Indian Family Caregivers of Persons with Mental Illness. I think it's an interesting book to read because it gives a very different perspective from what we clinically see as important from our standpoint. We have looked at, most of the things that I spoke about is about hospital-based rehabilitation, but community-based rehabilitation is most important because we have to reach this large society and community that we have to look at whether we can do anything in the community. So under the Kshema project, we looked at adopting 10 taluks under the district mental health program and see if the psychiatric social workers can make a difference by providing services to people at their home or as close as possible. But we have had major challenges in implementation, from bureaucratic hurdles to grassroots troubles. So because the family caregivers kept insisting on providing care at doorsteps, we also started something called as assisted home care, at least in the BBMP limits. So again, that is without saying it has its own challenges. So some of our colleagues, Dr. Jagdish Tirthahalli has run community-based rehabilitation programs in Tirthahalli and Turuvekere taluks, but the primary focus there has been on ensuring continuity of medications and medication adherence. Other things that happen from disability certification to vocational rehabilitation have been, they have also been a part, but primary focus has been on ensuring adherence, because at least that was the challenge that they felt was a problem. Now, I think we have to change our focus from looking at patients as patients with symptoms to people who have their own individual choices, their wishes, their desires, their goals. So I think our perspectives should change from, as Sir was already saying, from clinical recovery to personal recovery. And I think physical health is an important part of personal recovery as well. A lot of things should happen because of intersectoral coordination. And I think that, again, cartoon which Dr. Nagesh Pai put up, I think that probably summarizes the different kind of services that people require, from pharmacy to housing to several. So we don't have a well coordinated system anywhere in the world. So in our country, we don't have some of these systems at all. So I think these are challenges that are there. We had 2 patients who chose to write about their mental illness recently. In the last 6 months, they got published, and I think it is important that we encourage people also to write about their problems. So one of them wrote about the cognitive impairment in an episode of schizophrenia spectrum disorder, and he said dramatically his cognitive symptoms vanished one day when they responded to medication. So our own understanding of what cognitive deficits are, as far as mental illnesses are, at least severe mental illnesses are concerned, may be very theoretical. People experience it very differently. Another of them, actually one more of my patients, wrote what she felt as recommendations for a truly inclusive society in a journal that is run by, the editorial board is from our department. So if you wish to write anything, you could write on the Journal of Psychosocial Mental Health and Rehabilitation that we have. So I think that is where I end my presentation. If there are questions, I would be happy to take.
Thank you, Dr. Krishna Prasad. It was a very insightful presentation. We got a blend of practical clinical tips about managing a rehabilitation center and providing the services, and also it was kind of evidence-based as well, which gave, I'm sure the PGs would start thinking about doing some work in rehabilitation psychiatry. Way back when I joined NIMANS in 2004, when I was working there, we used to go to the rehabilitation center to buy cakes, biscuits, and candles. When we were that name, that we were not really knowing what was exactly happening in the rehabilitation center. But when we worked with the patients there and with our teachers who worked in rehabilitation, we got good insights as to how important it is. In the earlier days, it was a non-glamorous field in psychiatry. But now we realize it's very, very important, as Dr. Pai and Dr. Krishna Prasad mentioned. It is very important that just clinical recovery is not important. Personal recovery is equally important, and he repeatedly stressed the need of it. Having worked with Krishna Prasad and in KS Hegde Hospital, we have got a lot of help from Krishna Prasad because he's working in rehabilitation center. We have had 2 difficult clients and we were finding it very difficult to handle those patients because of the violence and also inability to work because he had developed resistance to the medications. And Dr. Krishna Prasad helped us in his kind of placement and trained him to manage his day-to-day activities. Violence came down with the inputs from the team, rehabilitation team in Bangalore. And apparently I got to know that both the patients are doing well. I think Dr. Satish Rao sir, if he's around, would also contribute to that. I mean,
yeah, I think two of the patients that I was just remembering that I think one referred by Nishi and one by Dr. Satish Rao. Both of them are working in full-time employment for the last 4 years. At least one of them was a major challenge too.
We had reached the therapeutic nihilism actually. We didn't know what to do.
Both of them are in full-time employment.
Thank you. Yeah.
As ma'am said, rehabilitation is not glamorous compared to acute ward or other areas of psychiatry. Maybe sir has mentioned various provisions from the government, variety of interventions, social skills training, cognitive retraining, vocational rehabilitation under that multiple approaches. So, PGs or if you have any questions.
Also, one additional point that I would like to make is that though we believe that a lot of things can be done in terms of biological psychiatry, in terms of molecular or genetics, or say, for example, big epidemiological studies, but I think some things can be done even clinically. I mean, things that you see about recovery capital, some of these things are readily doable as MD thesis and topics that are very easily approachable, qualitative studies. So these are potentially publishable also.
I think all the clinicians, the psychiatrists need training in that field especially. And one more thing, like just we say going desi, we as psychiatrists maybe every day we can just spend some 5 to 10 minutes going to a rehab center or a place, sit with the inmates, have a meal with them, get to know them better. I think conscious efforts from clinicians is required. Buying things from the rehabilitation center, gifting our relatives with those things, all that matters in day-to-day activity. These are the practical tips we can think
inclusion,
of.
I mean, people look forward to be included, and I think we should also be concerned about not doing it as a part of charity, but rather as a part of true inclusivity. I think that is where the challenge comes.
It's a very lucid presentation, very informative. I congratulate you on that. The present scenario of the rehabilitation. So I've been exposed to this rehabilitating, especially chronic mental ill patients, because ours is a tertiary care center. Ours is a tertiary care center. We have a very huge populations with chronic mental illnesses, aftercare issues. What we have identified is that the drive of rehabilitation is coming from mental health professions. What is the failure that has occurred is the drive from the community level to rehabilitate and incorporate these people into the mainstream of life has not occurred. So, like if you look at the 2006 before, so we had the system in our hospital where the patient were, if you are ill, they will come and dump there and we have to communicate to them. So they will come and take. So there is no responsibilities owned by the family members and caregivers for treatment and aftercare treatment. So both all the responsibilities. Now many of them society wants like, okay, you do the same system should be made available now also. Okay, so there is what I have identified is a failure from the society to properly respond towards the needs of the mentally ill. Okay. So the other part, like we have though our state government has come up with a lot of the programs like daycare system, the Manasadhara, the program and all. So there are two issues. One is the focus of this Manasadhara program was like skill development, basically nurturing the potential abilities of the patients to get trained and live back. And there is a specified parade for training them. So many the patients who have been left here, the family members, some of them actually they are doing well. They want it to be continued. The continuum part is because the financially is not available from the government side. Okay, they will be continued. And there are and another is logistic issues we have come across.
Transport.
Yeah, transport. So what has happened is each district headquarter will have one rehab center. At the district is a huge one. Almost it caters towards a range of say 50 to somewhere even to 70, 80 kilometers range it is there. So the people transporting from there, really there are genuine cases in the village level. So there is need of the extension of these programs to the on the village levels. Also there is some NGO based. Now what happened initially, this program was started, the NGOs came into a role, and NGOs actually made it failure. Now most of these Manasadhara programs are being is managed by the government based institutions like medical colleges and all. So this is the one issue that we have come across. Second is aftercare. Aftercare, what happens once a patient is mentally ill, they are unmanageable in the family members wants, like they want to put him into some center for at least say 6 months to 1 year. They don't want to see these patients. So again, the question of the financial issues will come. We don't have the system where they're economically difficulties they come across. Because to put any institutions at minimum is they have to spend 10 to 20,000 rupees, which is not possible. Again, what happens? These patients will come back, and again there is a frequent relapses. So these are some of the practical issues that as a policy matter, as a approach. So what I identified is that there should be a strong society-driven initiatives to address these issues, especially the role of the non-governmental organizations. Because non-governmental, it's like they are working more like a profit-based, sorry if somebody said, so profit-based rather than really looking into the issues, core issues. So this is my just viewpoint, and also I want few responses possible from your end.
Yes, thank you, sir. I think very important points that you made. I think increasingly family caregivers associations are pressing for several of these things. They are asking for these to be done. They have not sangatitavagilla avaru. That is the major issue. They are not the people who have come together, and you don't see them have a voice similar to say people with visual impairment, or say people with hearing impairment, or families of people with cerebral palsy or Down syndrome or autism. They don't have such a forum at all. Very few organizations are, very few such groups are working. One of them is Face MI, which is working in Bangalore. They've looked at opening branches in Calcutta and Mumbai also. Similarly, Pune, which is run by Amrit Bakshi, is also another organization. But they are very far and few, and the numbers are not enough to be heard as voices by the government. So community is making voices, but it is very feeble for people to hear. What happens is, if there is a lawmaker whose family is affected with mental illness, then they become concerned. Then they make a change. Then they make a small change here and there. But otherwise, for the voices to be heard, I think we have to help the families to get together and ask for these things.
Okay, maybe the last question we can take.
In the state level, it lies not with the medical side. Okay, the onus of rehabilitation lies with the Department of Social Welfare.
I'll tell you, sir, what the response is.
Mother and
when we have met,
Welfare Department.
No, when we have met the Ministry of Health, what Ministry of Health tells NIMHANS is, rehabilitation is not Health Ministry's job. It is Social Justice Ministry's job. Social Justice Ministry says, rehabilitation of people with severe mental illness is not the job of social justice. We don't know anything about mental illness. people with in the health ministry should see. So there is a new institute called National Institute of Mental Health Rehabilitation, which is coming up in a place called Sihor in Madhya Pradesh. So this is a National Institute for Mental Health Rehabilitation. So when I attended their meeting last month, he said halfway homes and long stay facilities are needed for people with severe mental illness. नहीं हमें नहीं चाहिए, क्योंकि हम ये लोग यहाँ chronic हो जाएंगे. So one of the fears that they have is they will be long term institutionalized there. So there are fears that are there, and there is a turf war that is difficult to breach.
I think you also had visited our institution also to look into. There was an initiative of the government of Karnataka to put a rehabilitation center in our institution, which is not actually feasible from the administrative point of view to look into. Yes. So then we withdraw this because it involves lot of manpower, management issues and all. It is only possible through this thing. And the other is Nirashita Pariyar Kendras, which they have the policy like you should not admit the mental ill patients into the NPK, though we have been giving them. And they also have their own guidelines. I think we have, as a rehabilitation, the policies have failed to put a proper rehabilitation program to these people. So I think we need to make a drastic changes in the policies. We should have at least district level one each rehab centers. Not very needy people, those who are abandoned, no caretakers are there. At least these people should lodge there. And they should have also associated daycare systems there too, which can put them back to the society.
So as students of psychiatry or as students from the medical professional, sometimes we wonder whether providing shelter, whether providing work, whether integrating them to society is our job. But I think looking at the kind of response to antipsychotics and the suffering that people have, we cannot be saying that this is not, we simply cannot deny that this is a part of our job. So I think that is the final statement that I would make.
Yeah, I think due to the shortage of time, we need to stop. So sir has mentioned multiple interventions. Usually that questions will come. So we don't have separate rehab center or daycare center in our institution. I am fortunate I have multiple models of rehabilitation services. But for others, so when I asked with my mentor, Dr. Sharma, he was telling no need to wait for no special daycare program or center rehabilitation. Whenever you meet your patients with mental illness, you initiate. Just for 5 minutes you ask whether the person is doing some work at home. Maybe bringing milk or something, helping other caregivers. Maybe you can initiate in that way. So no need for, these challenges will remain from the systemic level. So no need to wait till the end. So start from the beginning whenever you meet your patients at first, meeting. Okay, so with this I'll conclude.
This brings our second session to a close. We are grateful for the enlightening presentation and extend our sincere thanks to both the speaker and chairpersons for their invaluable contributions.
At this outset, I would like to highlight efforts by our own rehabilitation program. Our welcome kits are made by various patients who are part of our rehabilitation program. The cloth bags were made by Mrs. Parvati, who is a known case of multiple sclerosis, and she was referred to us by our neurologist. Her sisters and son have helped her to make these beautiful eco-friendly bags. Also, the paper pins were made by the patients who are attending our daycare center at Shema. And the crystal mats are made by the patients who are regularly attending the daycare at Nitte Rural Psychiatry Center, Karkala. Please give a round of applause for their effort. If anyone is interested, please let us know. We can provide about their further details.
I now invite Dr. Satish Rao sir to kindly present a token of our sincere appreciation to our speaker, Dr. Krishna Prasadan.
Now I would like to call Dr. Smita to bestow a gesture of gratitude to our chairpersons.
Let's now move on to our third session of the day, From Blues to Blooms, an in-depth view of psychotic disorders in pregnancy. This session will delve into perinatal psychiatry and the impact of psychotic disorders during pregnancy. We're excited to have Dr. Anish Bhatt as a speaker. Guiding us through this session will be our esteemed chairpersons, Dr. Prabhat and Dr. Gunasagari. Please join me in welcoming them.
We are delighted to invite our chairperson for the upcoming session, Dr. Prabhat Gujari Kodancha. Dr. Kodancha is a distinguished consultant psychiatrist at Western Health, Melbourne. He completed his MBBS from Bangalore Medical College and Research Institute in 2011. Dr. Kodancha pursued her fellowship through the Kishore Vaigyanik Pratsona Yojana at IISc DBT medicine stream, which he completed in 2011. He then earned his diploma in psychological medicine from NIMHANS between 2012 to 2014, followed by an MD in psychiatry from KIMS Hubli. He furthered his expertise with a clinical postdoctoral fellowship in stem cell discovery at NIMHANS. In 2019, he was honored with the Sakura Fellowship DBT/JST Young Faculty Award, recognizing his significant contributions to the field. He achieved fellowship of the Royal Australian and New Zealand College of Psychiatrists in 2023. In his private practice, he specializes in OCD and neurodevelopmental disorders. His broad experience and prestigious qualifications makes him a valuable chairperson for our session.
It is my distinct pleasure to introduce the second chairperson for this session, Dr. Gunasagari Rao. She is currently serving as a counselor at A.V. Balika Hospital in Udupi. Her extensive career in psychiatry and psychotherapy spans several decades, having worked in the Department of Psychiatry at KMC Manipal and later at Shema. She holds an MSW degree from Roshni Nia, Bangalore, and an MPhil in psychiatric social work from NIMHANS, Bangalore. Ms. Rao completed her PhD at Roshni Nilaya, Bangalore, and is a certified transactional analysis therapist from the International Association for Transaction Analysis, USA. Her areas of interest include cultural issues in mental health, psychotherapy, and counseling. Please join me in welcoming Mrs. Gunasagari Rao. We now invite our esteemed chairpersons, Dr. Prabhat and Dr. Gunasagari, to introduce our speakers for the session, Dr. Anish Bhatt.
Dr. Bhatt is a professor and head of the Department of Psychiatry at MIMER Medical College, Telangana, Telegaon, Pune. Okay. Where he has been leading since February 2020. In addition to his academic role, he serves as a consultant psychiatrist at Manasparsha Neuropsychiatry Center, Telangana, and at the Roshni Rehabilitation Center in Karjat. His previous experience includes serving as an assistant professor, consultant psychiatrist, and sub-investigator for clinical trials at KS Hegde Medical College and Hospital, Bangalore. Dr. Bhatt is also a founder member of the NGO Center for Community Mental Health in Bangalore and serves as a medical advisor and partner to ISRI Technologies Private Limited. Dr. Bhatt's expertise spans de-addiction psychiatry, technology and mental health, preventive health and wellness, general adult psychiatry and AI, and predictive analysis in medicine. He is also passionate about photography and trekking. His contributions to the field are widely recognized, having served as a faculty member for TIMCON conferences from 2018 to 23, the FOGSI and AMOGS PGOS Clinico-Legal Conference in 2019, and numerous workshops. He has also been a mentor for the Manasa Co-Ithon 2023 and a chairperson for the scientific sessions at TIMCON. I invite Dr. Bhatt to take over the seat.
Thank you, ma'am. So, good morning all. So, today with the pious shloka,
Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara, Guru Sakshat Parabrahma, Guru Tasmai Shri Guruve Namaha. So I salute all gurus over here, all teachers over here who mentored my life and also who are mentoring others' life also and who would be teachers in future. On this day, we have a great knowledge-filled session today, starting from Dr. Nagesh Pai to Dr. Krishna Prasad, and now I am adding a little bit of sand in this session, a little bit of part of my in this session. So when sir gave me this topic from perinatal psychiatry, it was a question. Then he said, you go ahead, we are narrowing down on the psychotic disorder of pregnancy.
So it was a blessings for me because I had to concentrate on a small part of it. Because perinatal psychiatry is a vast ocean where if you start venturing, you will reach nowhere. When I was preparing for this presentation, the presentation says blues to blooms. So in-depth review or in-depth view of psychotic disorder in pregnancy. So when you say in-depth view, it's difficult to get real in-depth view because it has so many facets to it, it has so many details to it, and to present in 45 minutes, it's really difficult. But let me try to present a glimpse of it so that you can go ahead and read more about it. So goals of my presentations are understanding pregnancy, hormones and its effect on emotions, pregnancy disorders in psychiatry and postpartum period, psychotic disorder in pregnancy and postpartum period, understanding importance of recognition of psychotic condition in pregnant and postpartum women, recognizing postpartum psychosis versus postpartum blues, recognizing psychotic disorder in pregnancy and postpartum, treatment guidelines for psychotic disorders in pregnancy and lactation, understanding consequences of untreated psychotic disorder in pregnancy, and know how to assess the level of care needed. So, what is the prevalence of psychotic disorders in pregnancy? So, it is said that WHO study says that about 10% of pregnant women and 13% of postpartum women experience mental disorder, mainly depression in pregnancy. In developing countries, the percentage still goes higher, 15.6% and 19.8%. So we are a developing country yet, so consider 19.8% postpartum females develop mental health issues. A very common phenomenon observed was postpartum blues, which is around 40 to 85% of females. Whereas perinatal psychosis, that is postpartum psychosis, observed between 0.1 to 0.25% of general population or females. Those who have already psychotic disorders like schizophrenia, their postpartum psychosis is around 12%. Whereas women diagnosed with bipolar and schizoaffective, the percentage goes up to 72 to 80%. So you see the difference if the person has previous diagnosis of mental illness, psychotic illness or bipolar illness, definitely postpartum period or pregnancy period has higher prevalence of disorder or exaggeration of symptoms. If the patient experiences psychosis during previous birth, means not patient's previous birth, previous pregnancy definitely, the risk of recurrence is estimated to be 50 to 90%. So again, all this indicator shows that pre-morbid or pre-pregnancy psychotic disorders or mood disorders or any mental health condition acts as a risk factor for pregnancy or puerperal psychotic disorders or exaggeration disorders. So pregnancy and childbirth and the puerperium are the series of transformation and huge changes in women's life. It is a change where a lady becomes mother, which may also be accompanied by various mental health problems. Very often women experiencing mental disorder during this period and their doctors face a decision on safety of treatment. So we all experience, students are there, we are consultants, we all experience dilemma, what to treat, how to treat, when to treat, and which medications to use during the pregnancy. And after nearly 15-17 years of practice, still I face this dilemma in my day-to-day routine clinical practice. So let us go through how the hormones
Why pregnancy is different from normality? Because of hormones which changes during the pregnancy. So as you see, estrogen, cortisol, progesterone, prolactin, all these hormone increase over a period of 9 months. So from first week to 40th week or 36th week, all hormones increases. So these hormones do have their emotional effects on pregnant female, effect on brain. After delivery, all these hormones suddenly drops. So sudden drop again causes different effects on mental health status or brain. Again, few hormones continue to remain high, like prolactin for lactation. So it has its own effects on mental health. So changes, drastic change of hormones in these 9 months do cause lot of emotional changes and causes problems in the woman. So which hormones are very important? Human chorionic gonadotrophic hormone, which is important for conception and maintenance of conception, progesterone, estrogen, prolactin, relaxin and oxytocin. So every hormone plays its own role in during the pregnancy, in the middle part of the pregnancy and maybe at the part of delivery. Oxytocin increases, so it plays its role during that time. So females go through these hormonal changes and how it acts on neurobiology. So estrogen, progesterone has its own action on dopaminergic synapses. So it has dual effect. It increases dopamine release in striatum and dopamine release is decreased in prefrontal cortex, and also enhances transmission of dopaminergic neurotransmission is enhanced. Serotonergic synapses enhances transmission, has another dual effect on serotonergic transmission also. So all glutaminergic, serotonergic, GABAminergic, all these neurotransmitters are affected because of changes in these hormones. So does it also affect the treatment? Definitely, because when dopaminergic neurotransmission is affected, we have there our antipsychotics which are acting on dopaminergic, correct? So it do affect on symptoms of psychosis also, or symptoms of mental illness also. So pregnancy, they pass through emotional roller coaster. So in initial part, it is excitement to get pregnant. That is excitement which females have. After few weeks, maybe they feel isolated. The morning sickness causes lot of trouble, lot of stress. Decreased sleep causes lot of stress on their body and mind, and they feel fear whether pregnancy will be lost. They are insecure. They are anxious. As they go through pregnancy, the experience itself, if they have social support, they feel more relaxed, comfortable, and if they don't have social support, definitely they are still anxious and more stressed all throughout. And at the end of the pregnancy, again there is an emotional wave where they have anxiety about the labor, outcome of the labor, whether the child will be born live or not. So all this roller coaster thing happens all over the pregnancy. Most of the mothers who are sitting here must have experienced the same thing all throughout their pregnancy. So it is a sensitive period where they need lot of emotional support, social support, and also maybe those who are mentally ill need lot of support from the professionals, psychiatrists, and also their family. So what are the psychotic disorders we see in pregnancy? Usually postpartum blues, postpartum psychosis, schizophrenia, acute psychosis, delusional disorder, schizoaffective disorder, non-organic, otherwise unspecified psychotic disorders, pregnancy-induced exacerbation of previously diagnosed psychotic disorders. So all this can happen. You have whatever diagnosis in ICD can occur in pregnancy also. So we are dealing here with the psychotic disorder of pregnancy. Now coming to classification, our new classificatory system ICD-11 has given a good importance to postpartum psychosis or postpartum peripartum or puerperal psychotic disorders. So here it comes. It is categorized under 6E20. So mental or behavioral disorder associated with pregnancy, childbirth or puerperium without psychotic symptoms. So they have given commencing within about 6 weeks after delivery is a criteria, which again gives a specifier mental and behavioral disorder associated with pregnancy, childbirth or puerperium with psychotic symptoms, without psychotic symptoms. These two categories are there. And the third one is mental and behavioral disorder associated with pregnancy, childbirth or puerperium, unspecified. So when we say without psychotic symptoms, most of the mood disorders or most of the depression is classified under that. When we say with psychotic symptoms, most of the psychotic spectrum conditions are classified under with psychotic disorder. And when it doesn't fit both, when they have both symptoms, that is mood symptoms and also psychotic symptoms, it is classified under unspecified. So ICD-10 gives better classificatory understanding about this condition during the pregnancy than ICD-10 and DSM-4, whereas ICD-10 identifies only the diagnosis of postpartum depression applied only to puerperium beginning up to 6 weeks after delivery with exclusive criteria for other diagnosis. So there we used to have code F53, mild mental and behavioral disorder associated with puerperium and not otherwise specified, that is postnatal depression and postpartum depression. In DSM-4, for the first time in the classification, the term mental disorder with onset after childbirth is introduced, whereas in DSM-5, in depressive disorder, episodes are distinguished in the perinatal period up to 4 weeks after delivery. It is a 4 weeks. That's what they have mentioned in DSM-5. When diagnosis of psychosis, it should be determined whether it was related to the onset of puerperium up to 4 weeks after delivery. So in this classification, ICD-10-11 gives a better classification and incorporates most of the illnesses which occur during the post-pregnancy period or during the pregnancy period. So why it is important to recognize psychotic condition in pregnancy? So women are at greater risk of developing psychiatric disorder between age 18 to 45. Pregnancy does not protect against relapse of psychotic condition. Because of hormonal changes, relapse do occur. Psychiatric illness during pregnancy predict postpartum psychosis and exacerbation of psychotic disorder, as we seen in statistics earlier. The risk of perinatal psychosis is 0.1 to 0.25% in general population, whereas it is up to 50% in women with bipolar history of bipolar disorder. Nearly 20-fold increase in relative risk of psychosis occur after first month after the childbirth. There is a risk of recurrent postpartum psychosis up to 50 to 90%. So all this validates for importance of recognizing the psychotic condition in pregnancy. Definitely, by not treating, there is a harm to mother through poor self-care, poor nutrition, poor judgment about her own condition, lack of obstetric care which they get because of negligence, IUGR babies, low birth weight babies, fetal malformation, intrauterine deaths, spontaneous abortion, preterm labor related complications. And if she crosses all these things, what we see is after the childbirth, the baby is separated from the mother because community considers that the mother is not ready to take care of the baby. So that is the biggest trauma what the female suffers after giving birth, after her passing all these hurdles in the pregnancy. So sometimes this disorder do cause harm to self, that female, and also the child by infanticides or maybe homicides also, or suicides. So these all complications which occur, that's why it is very important to recognize them early and treat them early. So we need to see risk versus benefit. What is the risk and what is the benefit? So definitely 4 major considerations for risk we should see. Risk of untreated maternal psychiatric illness. What is the risk? What are the benefits of avoiding medication exposure? What are the benefits of adequate control of mental illness, maternal mental illness, and risk of medications? So if we weigh risk on these 4 points with the benefits during the pregnancy, we are at the right position to tackle mental health issues during the pregnancy. So let's go how to assess the risk benefit and how to assess the mental health issues in the pregnancy. So this slide shows what we need to really collect the data from the patient when we see the patient at the first time, or maybe the patient who is planning for the pregnancy. In history, there, as we go, history of current illness, history of medical or neurological, past history of episodes of psychiatric illness, treatment history of prior episode, relevant family history, past pregnancy and their outcomes and whether they have faced some problems, history of traumatic pregnancies or past obstetric violence, especially in severe labor related post-traumatic stress disorder are there, history of child sexual abuse or sexual assaults. Inquiry must be made into certain aspect of pregnancy such as planned or whether it is unplanned or accidental pregnancy, wanted or unwanted pregnancy, whether it is a precious pregnancy, if woman has specific worries about her own health and the fetus health. Inquiry should be made into detail about the spouse and family members available for the support. History of substance use disorder in the woman as well as spouse must be inquired. So all these details which we usually do not take in normal history taking should be asked in pregnant women or the woman who wants to get pregnant. In examination, definitely detailed physical examination should be conducted. General examination should be conducted. Systemic examination, mental status examination should be in detail. Particularly emphasis should be placed on attitude towards pregnancy, motherhood concerns and worries about pregnancy and infants. Any psychopathology, whether there is a depressive symptoms, delusions, hallucination relating to infants specifically should be noted. Suicidal risk assessment should be done at the initial point only. Diagnosis is made using standard criteria. Now ICD-10 criteria are there. You can make diagnosis with that. And psychometric tool can be used at the initial part only to assess the patient which comes with the psychiatric illness to you before pregnancy or during the pregnancy. So all this detail, when we collect, how it helps us? Definitely it helps us to plan the pregnancy for the patient. So there is an interview called a structured clinical interview, which is usually used for research. So it is a Stafford interview detailed interview in 9 parts for pregnant women with the mental illness. The first 4 parts forms a prepartum section including the psychosocial context of pregnancy, whereas next 5 parts forms a postpartum section beginning with labor, childbirth and mother-infant bonding. Interview schedule provides probe questions along with answers with anchor points and helps to rate the severity of clinical findings. One or more section of the interview schedule may be applied in isolation for specific clinical or research purpose. So we have specific interview for this which we can use for these females so that we can get the accurate data and also we can use them for the treatment of the patient. So what now when you receive the patient or when you get the pregnant female, what discussion should go along with the patient? Usually what we have seen is this patient comes to gynecology OPDs and patients are referred to psychiatry for counseling purpose. And when we receive such patient, we have no idea what to counsel and what exactly to do because gynecology is separate. How she is going to go about the pregnancy, we don't know. What will be her problems during the delivery, we really don't care about it. What we care is only mental illness. Okay, so most of the time it happens that patient lands up in the OPD and we just continue those medication as per the safety and tell patient to continue with the gynecology OPD. So there we go wrong. As a mental health profession, we should discuss about these things. The risk of relapse and deterioration in symptoms, the woman's ability to cope with untreated and sub-threshold symptoms should be assessed and should be discussed. Severity of previous episode, response to treatment and women's preference to treatment should be discussed because lot of time taboo is there that during pregnancy even you shouldn't take a paracetamol tablet. And I have seen n number of females who are pregnant avoiding tablets even if they have fever of 103 and 104. So such taboos do occur with mental illness more and they stop treatment immediately as soon as they understand that they are pregnant or they change to lower dose of medicine. So if they are taking BD dose of medicine, they take half tablet. So such things they do on their own because they don't have knowledge about it and we fail to discuss these things with the patient. So we need to discuss the severity of episodes, response to treatment and their preferences. Possibility of stopping the drug with known teratogenic risk after pregnancy is confirmed may not remove the risk of malformation. So sometimes patient is on lithium and get accidentally pregnant. So definitely it warrants more investigation, ultrasonography scans to detect the malformation. If you suddenly, even if you stop, the exposure has occurred already. So such things has to be discussed with the patient. The risk from stopping the medication abruptly has to be discussed. Need for prompt treatment because of potential impact on untreated mental disorder on fetal and infant should be discussed. See, in our society, we are more concerned about side effect of allopathic drugs. So side effect to mother and side effect to fetus, but we are not considerate or concerned about side effect of mental disorder on fetus. So that definitely awareness should be brought in the pregnant female regarding what can happen if the mental illness continues during the pregnancy, what can happen to the child, what can happen to the fetus. Increased risk of harm associated with drug treatment during pregnancy, postnatal period, including risk of overdose, can also be discussed with the females. Background risk of fetal malformation for pregnant women without mental disorder can be told. See, in normal pregnancy also there are fetal malformation which can happen. So if it is 1%, how much percentage, or 1 in 100, how much in 100 can happen with the mental illness on treatment? So when you give such data, they get more confident about their treatment and they get more confident about the outcome of the pregnancy. So we need to discuss these things during the first discussion, first contact with the female who is going to be pregnant or who is pregnant. So now coming to directly to illnesses in the pregnancy, it's always been difficult to diagnose postpartum blues and postpartum psychosis. Most of the time in general practice, consultation license practice, we have seen gynecologists referring us patients saying that it is postpartum psychosis. And when we go and see patient is all right. Only patient's concern is patient is anxious, she is not getting sleep, she is worried, she is not able to sleep properly, she is feeling very much anxious because of that. And the consultation is for postpartum psychosis. Most of them who are dealing with consultation licensed psychiatry, they will have this experience. So let us see what are the differences. So postpartum psychosis is a really rare condition, 1 in 1,000. Whereas postpartum blues is nearly 70 to 80% females have postpartum blues. It is whereas postpartum psychosis is unexpected and rapid. Within 48 hours it starts and less than 22 weeks it is there. Whereas postpartum blues usually has after post-birth 1 to 3 days duration, where they have really passed through the delivery process, they have sleep disturbances, and the baby is there, they have to feed the baby, they don't get proper sleep, rest, and they get anxious. So postpartum blues within 1 to 2 days, at max 3 to 4 days, not more than that. In postpartum psychosis, there are severe mood swings, confusion, there are strange beliefs, hallucinations, delusions, disorganized thinking, confused cognitive state, cognitive impairment that represent dramatic change from previous functioning. They may become suicidal and homicidal, or they may have homicidal or suicidal ideas also. Whereas in postpartum blues, there is more of a tearfulness or crying for no reason. There is a mood swing, irritability, there is anxiety, questioning one's ability to whether I can take care of my baby or not, difficulty in making choices, loss of appetite, fatigue, difficulty in sleeping, and difficulty in concentrating. So you can see the difference. In postpartum blues, there is no confusion, there is no cognitive impairment, there is no hallucination, there is no delusions, there is no homicidal or infanticidal tendencies. Whereas in postpartum psychosis, all these things are there. So when you get the consultation, do see these things, whether it is postpartum blue, whether female is talking in clear consciousness, whether she is not confused or whether she is confused. So you can easily identify both things. Still we need to be careful, because sometimes postpartum blue definitely can turn into the psychotic condition also. So what are the risk factors for postpartum psychosis? So again, bipolar history 30%, postpartum psychosis in previous pregnancy more than 70%, Schizoaffective disorder or schizophrenia during the pregnancy has a higher preponderance, nearly 12%. Family history of postpartum psychosis, bipolar disorder, if mother had postpartum psychosis, definitely consider that this female also going to have a risk for that. First pregnancy, discontinuation of psychiatric medication during pregnancy, all these are risk factor for postpartum psychosis. So puerperal psychosis or postpartum psychosis or postnatal psychosis, different names are there, usually occur in 48 hours to 2 weeks giving birth, may occur up to 12 weeks of birth also. Sudden reduction in estrogen leading to dopamine supersensitivity is one of the reasons said to be behind the postpartum psychosis. Also increased cortisol levels and postpartum thyroiditis also known to cause postpartum psychosis. Potential consequences associated with this is mainly self-harm and harm to baby. So suicide after delivery or harm to baby after delivery is very common. I remember one patient here in Shema only, a teacher by profession who went into postpartum psychosis after her second delivery, and we went called by gynecology department for that. We have counseled them, we have started medication, but husband was very adamant to take the lady home, and I think Srinivas Bhatt sir must be remembering the case. And once she went, she jumped into the well and committed suicide. So it was a very sad state when postpartum psychosis occurs. Even after trying so much, after counseling so much, after giving them so much knowledge, things do happen as per their wish. So it is an emergency condition. It requires urgent attention and treatment. Usually postpartum psychosis is characterized by mood, thoughts, perception, behavioral changes. So mood symptoms, affective symptoms are nearly 80%. They are changing, continuously changing symptoms. Manic depression symptoms, psychotic symptoms appears together. Schizophrenia symptoms around 15%, whereas acute psychosis symptoms 5%. So these symptoms are polymorphic, changing, but you see clear confusional state during postpartum psychosis. So it can appear as a manic symptoms, it can appear as a depressive symptom. So with the mood symptoms, if postpartum psychosis is with mood symptoms, there are manic or depressive symptoms, both are there. So lack of sleep, increased energy, increased libido, feeling strong, powerful, unbeatable, hearing of voices, seeing things, having false belief, having feeling of special powers, okay, being disorganized, talking quickly, often not finishing sentences, making lot of unrealistic plans, seeming confused, forgetful, overspending, getting into arguments, sexual indiscriminations. So all this can occur in mood manic symptoms, whereas in depression it is opposite. So thought of harming them, hearing of voices, deteriorating voices, having false beliefs, difficulty in concentrating, difficulty in coping with the usual activities for babies and self, withdrawal from everyone, unable to enjoy anything. So these are depressive symptoms. So these symptoms can occur in postpartum psychosis. So how to manage? So you have mood symptoms, you have psychotic symptoms, you have confusional state, and it is emergency. So how to manage? So it requires emergency hospitalization, it requires admission, requires close monitoring, where lot of time people do fail to tell relatives that 24/7 we need a bystander with the patient. I know one case where bystander just went to toilet and patient just jumped from the hospital window. So just 5 minutes of left alone can lead to suicides or even homicides also. So close monitoring of mother and baby unit. If we have mother and baby unit, it's really good. Treatment, here again question comes whether to keep the baby with the mother or not. So there is big debate with it. Some people say for the safety reasons, it's definitely during the breastfeeding you keep baby with the mother, otherwise you keep it away. And some people do say that you need not break the bond, you should keep with baby with the mother under the observation. So it is up to you to decide with the risk. So antipsychotics, definitely the antipsychotics improve the psychotic symptoms like olanzapine, risperidone, ziprasidone, aripiprazole can be used. As it is postpartum, the lactational indications or contraindications are very less with these antipsychotics. So definitely we can use them with monitoring of the baby, whether baby is very sedated, whether baby is very much drowsy, irritable, or whether baby has any extrapyramidal signs. Mood stabilizer, lithium, carbamazepine, lamotrigine can be used during this phase. If postpartum psychosis is very severe, electroconvulsive therapy can be used for treatment of postpartum psychosis because it is a very emergency condition. Thank you. So I have another 15 minutes or 10 more minutes, very fast. So psychological therapies are useful once your pharmacotherapy is continued. Second condition is a catatonia during pregnancy. So catatonia is a common in pregnancy, around 8% of admission in acute inpatient psychiatric units come with catatonia in pregnancy. So here it warrants treatment with benzodiazepines. Symptoms: withdrawal, refusal to eat, causes dehydration, hypoglycemia, electrolyte imbalance. Even stupor and immobility increases the risk of venous thrombosis and deep vein thrombosis during pregnancy. So benefit of treatment with lorazepam often exceeds the risk of catatonic symptoms. So we do give lorazepam 3 to 8 mg per day in divided doses. In case of inadequate response in first 24 to 48 hours, we increase the dose of lorazepam. Further, you need to monitor the pulse of the patient, that is it shouldn't go below 60 beat per minute and blood pressure below 90 to 60 millimeter of mercury. Heart rate, fetal heart rate shouldn't go below 100 beat per minute. So we need to monitor these things while giving lorazepam to the patient. ECT is another option if patient doesn't improve with the lorazepam. So it is one of the again emergency condition within pregnancy which has to be treated. Now schizophrenia and other psychotic disorder. So you know how to diagnose schizophrenia, you have all the criteria. There are 1% per people who suffer from schizophrenia during pregnancy. Though there are very few studies present of schizophrenia during pregnancy, treatment, outcomes and all, there are variable results of these studies are there. Profound social withdrawal, mental disorganization, misinterpretation of reality, all this can happen in schizophrenia pregnancy. Negative symptoms, positive symptoms may become predominant. Though it is said that psychotic disorders improve during pregnancy because of estrogen, but the data is very inconclusive. Lot of research go opposite this also. So dealing with schizophrenia, in general population, if it is 0.83 to 0.44 men who suffer from schizophrenia, the mean number of offspring among patients 0.83 for women and 0.44 for men, compared to 1.83 and 1.65 among women and men in general population. So offspring, that is pregnancy ratio with schizophrenia and general population is very different. So maybe because of contraception, maybe because of prolactin increase which causes infertility, maybe because of obesity which causes infertility. So pregnancy rate is very less in schizophrenic patients, maybe because of chronic nature also. So they need support, training in health promotion, family planning, relationship issues, safety issues, preparation of pregnancy, provision of smoking and substance cessation program, managing nutrition, sedentary lifestyle and obesity. So we don't see just schizophrenia as schizophrenia, whereas it comes with whole gamut of lot of complications, obesity, sedentary lifestyle, not having proper health promotion activities, family planning activities, everything comes together. Effect of pregnancy outcome is again stillbirth, infant death, preterm delivery, low birth weight delivery, small gestational age child. All these complications which are associated with schizophrenia do reflect in the pregnancy, leading to fetal malformation and fetal IUGR and again loss of fetus also. So coming to treatment of schizophrenia in pregnancy. So we have different psychopathology. This is the list of symptoms which that indicates, okay, like delusion that fetus is already dead, it may be a psychotic depression or maybe patient is going into psychotic depression. So you can access through the following reference in this. Now coming to treatment, we have antipsychotics. We have scales, so you need to assess the patient with the help of different scales what severity of symptoms currently patient has. so that you can keep the track of the symptoms, so that you can keep the follow-up of the symptoms. So scales do help, like PAN-SS, SANS, SAPS, and brief psychiatric rating scales. All these scales help in rating the patient at what level of severity they have. Now coming to general principle of treatment. See, in all women who have childbearing potential, always discuss about possibility of pregnancy. Avoid using drugs that are contraindicated during pregnancy. So patient is coming to you, maybe she is in married and maybe going to be pregnant. Use drugs which are more safer in pregnancy. Mental illness in newly diagnosed pregnant women, try to avoid all drugs in first trimester because they may cause. There are incidences where risperidone has caused malformation. There are studies which says that. So try to avoid the medication as possible. If not, give medication which has very less effects. If non-drug treatment are not effective, use established drug with the lowest effective dose. So lowest effective dose you should give. If woman is taking psychotropic drug and planning pregnancy, consideration should be given to discontinuation of treatment if woman is well at low risk of relapse. Discontinuation of treatment for women with severe mental illness and high risk of relapse is unwise, so consider shifting to the low risk drugs. If woman is taking psychotropic medication, discovers that she is pregnant, abrupt discontinuation is not preferable. Better to reduce the dose or shift the patient to low risk agents. Considering depot preparation, if woman is on depot preparation, better to use oral preparation during the period of pregnancy. If patient is smoking, definitely smoking cessation has to be done. Ensure that the prospective parents are involved, means both partners are involved in the care of the female. So both counseling has to be done. Use lowest effective dose. Use the drug which has lowest risk to the patient. Prescribe few drugs as possible. Use drugs which do not act or induces some other drugs. Consider referral to specialist perinatal services. Ensure adequate fetal screening, that is regular sonography in those patients. Be aware of potential problems with the individual drugs. So be vigilant for them, what malformation can happen. Inform obstetric team about the psychotropic drug and its effect on pregnancy. Monitor the neonate for withdrawal effects after birth. That is a very much important. Fetus after birth may suffer from withdrawal effects. As sir has mentioned, withdrawal of psychotropics. Fetus also can suffer, so do monitor for that. Discuss all the decision. So in treating schizophrenia or psychosis during pregnancy is little bit tricky because it has, in pregnancy there is an increased body fat, which means greater storage of antipsychotic drugs, because all of them are lipophilic. CP is cytochrome P450 enzymes such as 3A4, which breaks down quetiapine and clozapine, and 2D6 which metabolize risperidone, are induced. So are thought to be induced by sex hormones during pregnancy. So again the drug concentration goes down, whereas active metabolites goes up. CYP1A2, main metabolizing enzyme for olanzapine, is down regulated during pregnancy. So the dose which gives may not be enough. The total protein is reduced during pregnancy, thereby decreasing the drug binding and increasing the protein-free drug fractions. Glomerular filtration rate increases during pregnancy, speeding up the rate of clearance, and progressive greater level of estrogen augment dopamine receptor blockade in brain, leading to requirement of lower doses of drug during pregnancy. So it is all these factors play role while you are prescribing during the pregnancy. So you may have to prescribe the lower dose of drug, or sometimes you may have to prescribe the higher dose of drug also. So drugs which can be used, first generation antipsychotics are said to be safer to use in pregnancy, whereas now second generation antipsychotics definitely preferred drug for pregnancy with indication of metabolic disorders where it may induce pregnancy-induced gestational diabetes by olanzapine, and also risperidone can cause some malformation. So prefer drugs which have less. So first generation are preferred and second generation few drugs are preferred. Clozapine has to be avoided because it may cause fetal granulocytosis, which is again a very dangerous condition. So this should be the general approach to the management of psychiatry in the patient. So in which stage patient comes, whether it is pre-conception, pregnancy or lactation, any stage patient can come. Preconception, advise folic acid, consider contraception, trial of discontinuation of single medicine can be given or reduction of medicine can be given. In pregnancy, encourage early and regular antenatal checkups, anomaly scans can be done, fetal echocardiography can be done if patient is on lithium, SSRI or other medications. Plan childbirth in hospital settings with adequate maternal and neonatal care. In lactation, encourage exclusive breastfeeding on demand. No role of delaying breastfeeding in infants. You can space, female can breastfeed before taking medications. Consider relative infant dose less than 10 for the medication. So use those medication which causes less than 10 relative infant dose. Clozapine is not preferred because of granulocytosine. Adequate sensory motor stimulation is given to the baby so that baby may not become more drowsy or more lazy. So these approaches can be used in treating this psychosis in pregnancy. As per FDA, most of the antipsychotics come in C, that is evidence of risk to fetus in animal studies, but no well controlled studies in humans. So now it is given up to you what to be given. So up to you to choose what to be given. So choose wisely, which causes less problems. So risperidone increases the risk of gestational diabetes. So oral antiglycemic drugs can be used. Aripiprazole increases birth weight. Clozapine causes floppy infant syndrome, agranulocytosis. So haloperidol, no major congenital information, low birth weight, preterm delivery may happen. Third trimester exposure, extrapyramidal symptoms may occur in child also. So there are risks and benefits of using antipsychotics. So when we discuss risk, when to whom, why we give this medication, how we give this medication, all these things should be discussed with the patient and patient's family partners so that they will be well informed with our decision. So now coming to two important points, last 5 minutes. One is intervention specific and appropriate for women with suicidal risk in pregnancy. So suicidal risk increases a lot with psychiatric disorder in pregnancy. So if you find that even a small thought of self-harm comes in female's mind, do admit to the hospital under the care. Maybe high intensity care unit or intensive care unit can be used. Temporary separation from infant in postpartum mother till the risk of suicide elevates can be done. Ensure continuation of breastfeeding as much as possible. Use ECT. Educate family members about high risk of self-harm and continuous eyeball to eyeball monitoring, that is continuous monitoring. Twice daily risk assessment for lethality and intentionality should be done. Ensure that the ward or home is safe and with no sharp objects or any self-harming things. Women at risk for suicide may want to take their infant and leave home or hospital. Utmost care needs to be taken to ensure their safety. In high income countries, one of the foremost reasons for maternal mortality is maternal suicide, often due to severe mental disorder. So this is something alarming in high income countries. So maybe we are more protected because we have mother-in-laws to take care of females who do not allow them to commit suicide. So ECT in postpartum and pregnancy. Can ECT be given? Definitely. With some procedure we can give ECT. So prior procedure, obstetric consultation, overnight fasting, avoid anticholinergic medication, ensure adequate hydration. During procedure, pre-oxygenation is essential. Anticholinergic glycopyrrolate can be used. Right hip elevated position after 20 weeks of gestation to avoid aortocaval compression leading to fetal asphyxia or blood compromise should be used. So right hip elevated position can be used. Monitor fetal heart rate by Doppler just before and after ECT, and twice weekly NST can be done. Seizure disorder not lead to uterine contraction directly, but due to oxytocin release, painful contraction may occur. If persists, tocolytics can be given. So after seizure, if patient has contraction which are painful, consider it to be because of oxytocin. So tocolytics can be used in these cases. ECT during pregnancy must be given in setting where emergency obstetric and neonatal care is available. in postpartum period, if ECTs are given, ensure that infant is fed well before the procedure, and postpartum mother is prioritized in ECT chart to receive the ECT early, and express breast milk is available for infant. So, in postpartum cases, give breast milk earlier before ECT, and maybe express breast milk can be kept for the baby. So, lactation advices: use drugs which are low in relative infant dose. There is no need of withholding breast milk for few hours after each dose of medication, as medication achieves steady state in few days. So, they can give breast milk, because this question always comes from obstetrician whether patient can feed the infant, and they put the infant on the top feed or artificial feed. So, there is no contraindication as such, because very low dose of drug goes into breast milk. Infant should be monitored for signs of medication related toxicity. Definitely monitoring is required. Excessive sedation, floppiness, respiratory depression, cyanosis, excessive crying, irritability, diarrhea, jitteriness, all this should be looked after. So, any signs of toxicity, stop breast milk. You can definitely reduce the dose of medication also. So, with the final conclusion, psychotic disorder in pregnancy are definitely risk for postpartum psychosis and other conditions. Identifying them early, counseling the patient appropriately, lowering the dose of medication during pregnancy, maintaining on minimum dose, maintaining on the medications which are less risk causing is very important. During the delivery phase, maintaining the dose, maybe you need to increase the dose postpartum because of sudden estrogen drop leading to psychotic symptoms. So, we may need to increase the postpartum dose of antipsychotics. During the lactation, using the antipsychotics which are having less than 10% of RID, which leads to less problems in infant. Continuing breastfeeding with the close observation in the infant is the key to manage the psychotic disorder during the pregnancy. And definitely postpartum advice for next pregnancy, and look out for next problems of next pregnancy, and making them knowledgeable about their own health is very important in psychotic disorder in pregnancy. Thank you very much. I took more than some minutes, 46 minutes.
Thank you, Anish, for your comprehensive presentation. On this special occasion, I'd like to be grateful, express my gratitude to my teachers, past, present, and future. And I'll try and do my role as a to facilitate this lengthy presentation. So, I'll focus on both postpartum as to the topic, which is postpartum blues and psychosis. So, why are we discussing that here would be an interesting question. So, as we know that pregnancy is a very natural and high prevalence occurrence, even though it is that, it's a very mysterious and quite unnatural process when it comes to hemodynamics, hormonal changes, and socio-cultural changes and role changes, and that being the earliest exposure for the newborn. So, from the hormonal point of view, estrogen, high levels of estrogen, though it is not very conclusively demonstrated, high levels of estrogens are protective for not having psychosis during pregnancy, and when it falls, there is a risk for somebody to develop psychosis. From psychosocial or existential thing, it is very, very different for each mother to have what it means to be a mother, and it also varies from culture, so it's worth exploring, and it would probably have a lot of stressors or individual meaning that might require some tailoring or clinical non-pharmacological or pharmacological management opportunities. So, and childbirth is one of the major life stressors, so that itself can be another risk factor for psychosis. Again, there is a lot of safety concerns both for the mother and child, and there is a risk of having a poor attachment or attachment trauma for the newborn. So, that is from the illness point of view and the risk point of view. From the longitudinal course as a psychiatrist, what it would mean to have a postpartum psychosis, again, owing to all our teachers, it probably means that the closer it is for the birth, then it is more likely to be a bipolar kind of presentation, or and the father, it is from birth within 1 year period, it could be more likely that it is psychotic illness. So it could be acute psychosis kind presentation, or schizophrenia like presentation, as the longitudinal course is one of the important factor in diagnosing in psychiatry. So in terms of management, again, setting, where do we manage? It involves a lot of liaison with stakeholders like pediatrician, as he was mentioning, as well as family, their cultures, and even trying to address the stigma that is there, and trying to mobilize supports for the new mother and helping them to cope with the role changes, and medically just ruling out all of the physical health ailments during postpartum and ensuring that they get early treatments. And yeah, I mean, even though it is supposed to be stimulating discussions, I think because of the want of time, I was told there can be only 3 questions that we can take. So it'd be, yeah, thank you. Yeah.
Any questions?
Thank you, Dr. Anish, for presentation. And I'll have quick questions and one observation. The patient who is maintaining well on particular dose of medication, psychotropic, whether antipsychotics or antidepressant for her condition, and we consider that now they come and request that I'm planning for pregnancy, would you please remove medication or reduce medication? And many times we try to, we are forced to make those alterations, and they pretty well maintain well with that dose. And if pregnancy gives that protection over her symptoms and maintained on that dose, and we also know that there is possibility of worsening in the postpartum period. So whether we are restarting the increased dose than what is being maintained, and if we are changing, and what time that we are planning to change, or it's only after seeing the worsening of the symptoms in postpartum period. So is it wise to start knowing that there can be worsening, or we have to wait and watch and see the worsening? And the other thing is, when, as you really mentioned, for all the psychiatric symptoms, the change of what the traditions and cultures were there previously, and holds good here also, typical cultures, traditions that were practiced, taking care of that woman who is pregnant in the parents' house and taken care, given utmost importance. And nowadays in the modern life, they are working and they are away from homes, and in fact they are staying only in husband, wife, they are staying, and adding to more stress. And again, the role of family and traditions, cultures comes back, as you mentioned in the morning. So that was an observation. And another question. Thank you.
Sir, about the first question, medication when to change and whether to change. It's really a big dilemma for us. If patient is well maintained on some antipsychotic medication, and that antipsychotic medication has a low propensity to cause malformations or pregnancy issues, any issues in the pregnancy, as per the guidelines, Montessori guidelines also says keep it same. No need of decreasing or increasing the dose, unless it is in the dose level where it may cause harm to the, like clozapine, definitely it is dangerous. So we can think of changing the medications or using appropriate medication. Again, the question comes, what during, after the delivery? So postpartum psychosis is not just based on medication. It based on lot on social support, lot on as family support, stress during the pregnancy, sleep duration during the pregnancy, physical stress and strain during the pregnancy. All these things play very much important role in postpartum psychosis after the delivery also. So maybe controlling these factors, or making more the family and female more educated about these things, making the environment more comfortable for them during the pregnancy, can have protective effect in the postpartum period. And definitely if we have increased symptoms during the postpartum period, we need to increase the medication, maybe postpartum period only.
when they come for asking to change medicine, if it is first trimester or later, and even if they are not okay, there are some primordial prevention data for using wild fish or fish DHA for, again, all the data are not very conclusive, but say neural tube defects minimizing strategies like 5 mg of folic acids and other omega-3 fatty acid, which are safe in pregnancy, some of them. You will have to look at the preparation. Or just asking them to eat regular fish, if they are fish eating generally, to have fish provided that it is not mercury contaminated or any of that. But yeah, so those might be some protective factor, and it's always worth having discussion with the patient to explain the risk. I think the risk sometimes is overrated. When you look at the actual statistics, the number of congenital malformations in general is also quite a bit, and if it is untreated with mental illness at that time, it can be higher. So to try and put it in an understandable terms to the patients and leaving it to them, I think the confusion that we feel is when we are forced to make the decision, but we can also leave it with them and have a discussion with them too.
At our hospital, Medical College Hospital, we have a specific pre-pregnancy counseling for individuals who are suffering from mental illnesses. So in that we have detailed discussion with the patient and patient's partner, and also we involve their in-laws who are going to take care of the female also. We put them in front of them the whole scenario of the pregnancy, just like a story, where we tell them what complication can happen, how to handle it, when they should report, when they should go. Even with the USG, patients have a lot of concern that 4 times USG, something happens to baby, what will we do? So we do explain all these things in our psychiatry counseling unit, where all these details till the childbirth, and even after the childbirth, what care needs to be taken, what are the identifiers of increase in symptoms. That also leaflet we provide to them. So with this, what we have found is they accept it better way. The stress during the pregnancy, they take care of that lady in a more concerned way, and they don't consider her as usual female. They give special treatment to her. So that helps a lot. So maybe that kind of support we can ensure.
Thank you, sir. We extend a heartfelt thanks to our speaker and the chairpersons for their valuable contributions. I would now like to invite Dr. Jonathan to present a token of our appreciation to our speaker, Dr. Anish Bhatt. Now, I would like to invite Dr. Yashwant to present a token of our appreciation to our chairpersons.
That is fine, that's fine. Now it is meant for it. It is the folding. No, we are putting in the other one. This is ejected out.
Dr. Srinivas Koski would like to make an announcement. Over to you, sir.
For all the students and also for the faculty, we know that we have been trained in getting our degrees, but most of us, we don't know how to do research. Many of us, some of them us know that we can do the research. There's a potentiality to do research, but we don't know how to get the resources, from which agencies will give resources. Session.
Ladies and gentlemen, esteemed guests, and distinguished colleagues, a very good afternoon and a warm welcome to each of you. We hope all of you have enjoyed the delicious lunch and are fueled with energy for the next set of sessions.
My name is Dr. Priyanka, and I'm accompanied by my co-MC, Dr. Priya. And it is our honor to extend heartfelt greetings as we commence the next half of the scientific program. We are thrilled to be your host for upcoming sessions. We hope the first half of the program was insightful, and we look forward for the same with the second half. Welcome and thank you for being here.
For our first session, we have a panel discussion on the topic, Is grass really greener on the other side? We are fortunate to have a distinguished panel of experts who will share their insights and perspectives. The chairperson for the session is Dr. Santosh Prabhu. Sir is a consultant psychiatrist in Queensland Health, senior lecturer, University of Queensland. He has worked as a psychiatrist in India and Australia, former clinical director of acute care services at Toowoomba Hospital, former chief training supervisor. His areas of interests lie in neurostimulation, older persons' mental health, neuropsychiatry, and medical education. I now request our chairperson, Dr. Santosh Prabhu, to kindly introduce the esteemed panelists for the day. Kindly note that our chairperson and 3 of our panelists will be joining us online.
Hello, good afternoon to everyone. Can you hear me all right at the far end? Excellent, thank you. Thank you everyone for the opportunity. It's with great regret that I'm presenting this forum online and not be there in person. It will remain as one of my greatest regrets that I couldn't be there in person, but I think we'll have to do with what we have to do. Before introducing the panel, I'll just briefly talk about what we're going to do. The first time we started thinking about what we're going to do as part of panel discussion, the discussion was about this being a debate about brain gain versus brain drain. Then we realized a lots have been written about it. I don't know whether Dr. Nagesh Pai is there in the audience. Can't see from this far. I think he's there. He's written a paper in the Australian New Zealand Journal of Psychiatry on this. Then I thought the discussion will go into the ethical issues around all these specialists from low middle income countries going to high income countries, and there's been discussions about that, also called brain robbery instead of brain drain. So we decided we won't go into those ethical issues. The next point of debate was we thought we'll do whether grass is greener on the other side. Now we think even that debate was going to be a bit of a sham because 4 of the 5 panelists are actually speaking from overseas. So the debate wouldn't have settled or wouldn't have gone very well ahead. So we decided instead we'll have a panel of experts and we'll talk about our experiences of life overseas. What can students do if they want to go overseas or work towards having some overseas experience? What things need to be done, and then talking a little bit about how it is compared to life in India. And Dr. Shishir is there. He's one of the speakers who has done it all. He works in 2 continents at one time, so we'll hear a bit from him. So I think without talking a lot, I'll start presenting on. I'll start talking about our presenters today. Just give me a second while I share the slides. I believe the slides are visible. Yeah, okay, all right, thank you. So the first expert for the topic is Dr. Shreyas Shivanand. Dr. Shreyas is an alumni of Shema. She did her MBBS from Shema, and then she moved over to Australia to gain her specialist training in psychiatry. She's quite an accomplished academician. She's got dual fellowship in child and adolescent psychiatry and consultation liaison psychiatry. I believe two of the most difficult advanced training positions that to get into in Australia. So she's done well. She's also a lecturer and course coordinator at the child and adolescent psychiatry and at the Masters of Mental Health Science course, which is run by Monash University. It's quite a good course. And she spent quite a bit of time in these clinical and academical areas in Australia. She works as an adjunct associate professor lecturer in the Department of Psychiatry at Monash University. Her special interests are neuropsychiatry, perinatal psychiatry, and developmental psychiatry, which is going with the child and adolescent psychiatry fellowship, and psycho-oncology. So that's our first speaker. Our next speaker is Dr. Namrata Shetty, who again is an alumnus of Shema. She did an MBBS from Shema. She came overseas to Australia and got quite quickly into psychiatry training. She did her, she hasn't mentioned this, she did her advanced training in older person psychiatry, and I've done the same. So I can relate to her interests. She tells me that she's a private psychiatrist, and she tells me she's already running 2 practices, and she is now in the process of obtaining a 3rd practice. I believe that's quite an achievement. She has done really well, and I'll let her talk about her experiences. And that's the thing about women psychiatrists who do well and climb up the corporate ladder and the private practice ladder. At the risk of being called gender biased, I think I'll say this: women's life doesn't end at 4:30. I don't know how she manages family, work, 3 practices, but she's done really well. Our next speaker is Dr. Deepti Hudge. I've known Deepti since she joined as a psychiatry trainee at Shema. She did her MD psychiatry from there. She worked as an assistant professor at AJ Institute of Medical Sciences. I know she had a very busy private practice. She was working in multiple places in Bangalore until 2022, when she decided to move across to UK. So she currently is working as a specialty doctor at the Essex Partnership University Trust, and she's been there since August 2022. She currently has special interest in geriatric psychiatry and organic psychiatry, and she's working in the older persons unit. So we'll hear a bit from her about how she's been going in the UK. And our last panelist, I think most of you probably don't need introduction. Most of you know him already, Dr. Shishir Kumar, my partner in crime when I was working in Shema. He trained he did his MBBS in India, went to UK, worked in neurodevelopmental team, got his CCT in general adult psychiatry. He hasn't put it here, but I'm sure I remember him having a CCT in hypnotherapy as well. So yeah, good on him. One of the few psychiatrists that I know of who's got a specialist degree in hypnotherapy. He was an assistant professor in Shema until 2022. Now he works as an associate professor, and he keeps doing local jobs in the UK on short-term basis. His special areas of interest are early intervention, community and rural health, and I know Shishir runs a lot of community and rural health centers in and around Shema, in and around Bangalore. Spirituality, and his favorite, I think, area of all, hypnotherapy. So I welcome all my panelists. Thank you all for joining, and hope we have good discussion. So I'll move on to the presentations as such. There will be a short presentation that all of them would give, and then we'll proceed on to discussions. All right. I'll let you and Shreyas has got an interesting first few slides. Life and career highlights, especially Shema and thereafter. So would be good to hear from her. I'll let you drive, Shreyas. We can't hear you. And Shreyas, is it all right if we go over to Namrata and then get back to you while we try and sort out the technological difficulties? Is that okay?
Can you hear me?
Oh.
Is this audible?
Fantastic. Thank you.
Oh, can you hear me? Okay, sorry. It's just, I'm a technically challenged person, so I couldn't really figure out how to go about it. Hello, everyone. My name is Shreyas. I graduated from Shema about 2009, and my journey in medicine has sort of been from inception a rich tapestry with sort of interest in learning and also discovering myself. I did not anticipate me moving to Australia in any sort of way, and following my internship, I took the sort of deep run to the other end of the grass like we were talking about. My learning, the process of learning was sort of finding my feet in field of medicine, although challenging at times. I continued to sort of pursue various aspects of my interest from extracurricular, not just academic, but also extracurricular activities. I had the esteemed opportunity of participating at various events in Shema and some recognitions for my contributions. That first slide depicts what my life is today in some ways as well. That's the man I'm married to as well, Ram, and a lot of Shemites would know him as well. He's currently practicing, he's a general practitioner physician in Melbourne and has a practice of his own. And that's where sort of exploring myself truly began, not just in medicine, but in the field of dance, art, and life itself. Well, in some way, Shema has also fostered my understanding for medicine, but also helped develop a competitive spirit that I continue to propel in my career in a lot of ways. Psychiatry in particular in Shema has profoundly shaped my professional and personal identities. Lots of mentorship has taken present in shaping me who I am today. And I should mention Dr. Satish Rao, who I have a deep appreciation for, who has helped me balance that personal and professional pursuit. And I don't know if you remember, Dr. Rao, you're one reason why we students had that opportunity to participate in KLE University state level competitions, and we were the backbone behind the 13 awards that Shema won that year. I guess perhaps the most awards in a state level competition at that point of time, and for years. That's a bit of my other passion, a bit of artwork that I really enjoy doing. And beyond clinical practice, I guess art has taken me to be a part of the editorial board with Shema and contributed to some of the yearbooks. One of them noteworthy is Orain. And you could probably see Tejasvi, who is currently a radiologist at Shema. Vijay and Nithila practicing in New South Wales. Vijay is a radiologist and Nithila is an anesthetist. Haven't had really much contact with Shruti, but I'm sure she'll be excelling in her journey of life. These are some of the experiences that sort of help etch our personal history and an academic journey in many ways. Further on, I sort of moved to do my Australian Medical Council exam. That's some of the contributions, just some community awareness programs that we have sort of developed over the years and sort of had the opportunity to participate in. Going to sort of the pathway of Australian Medical Council, it was probably a bit of a moment of trying passing those exams, but the harsh reality of the job market kind of hit the wave in early 20s, not knowing very much what to do. Despite the efforts and qualification, and getting an employment solely on the exam results was a daunting task, and I found guidance from Dr. Nagesh Pai, and I'm truly grateful to him for who I am today, because my first job felt like a very difficult task, and I managed to sort of begin my journey in both medical and psychiatric fields as a medical officer in Wollongong Hospital that Dr. Pai works with and closely affiliated to the university as well. I was also warmly welcomed by his nurturing embrace and his family, whose home has been a comforting retreat for me during my days at Wollongong, and I truly cherish each of those. Moving forward, my career at Wollongong led to a journey in research academia with my first scientific presentation by some outstanding psychiatrists at Wollongong who are currently at Toowoomba. And I continued to sort of pursue my career, completed my master's through the Melbourne University, and my dual fellowship through the Royal College, and most recently I published my article with the article on Charles Bonnet syndrome. I'm currently working at Monash Health, and I'm sort of working closely with Monash University for the undergraduate and postgraduate training program as well. That's a bit about me.
Shreyas, if you want to continue with talking about, what did you want to advise people about how to pursue medical career in Australia, how to go about? I believe you got some slides. You didn't intend to cover all of it, but do you want to do that? Do you want to continue? And you just have to say next slide, and I'll move on.
Sounds good. So this is sort of the aim of the presentation is to sort of explore opportunities, challenges, prospects for those who are considering a medical career in Australia. Hopefully by the end of the presentation, my hope is that, you can have a comprehensive understanding of what it would mean and how you can sort of expect life along the way. Next. This slide sort of talks about the importance of the various primary medical qualifications and sort of aspects of the relevant authorities, which include the Australian Medical Council. This is the term you'll hear very often when you're sort of navigating through the process of transition to Australia, pursuing your career in Australia, and also the Medical Board of Australia. The steps of assessment basically involve submitting your documentation, which we'll sort of talk about in a bit more depth, examination, and possibly undergoing a supervised practice, and the AMC accreditation process, which helps sort of assess the bachelor's or the master's degree that comes along the pathways of assessment. Next. We sort of cover in this slide how to apply for assessment and verification of the medical qualifications in Australia. So what you're saying here is sort of, you can see a little website there. The URL provides list of recognized medical schools and details of the application process. So you basically have to visit the website, very simple instructions and detailed instructions around the requirements for the process. And the last sort of pointer talks about the EICS verification. Basically, it's to ensure that your primary medical qualification is verified through the Educational Commission for the foreign medical graduates. And hence, you'll have the International Credential Service assess that to state if it meets the Australian standards or not. Say, for example, I pursued my MBBS in Shema, so I applied for it through the website, and through this assessment, they will then say PG-CME then was under the sort of Rajiv Gandhi University of Medical Sciences. So if it is affiliated or not, and if it meets the Australian standard. And this verification is crucial for your eligibility for the AMC pathway. Next. In sort of simple aspects of it, the pathways, the main pathways for international medical graduates to achieve registration, and that's by competent authority pathway. Trainees from India are not eligible for it. It's largely for countries like Ireland, UK, etc. that come under it. It's one of the fastest pathways. The commonest pathways is a standard pathway, and a specialist pathway is the other one. Next. So I'll talk about the standard and specialist pathway. We'll skip the competent pathway in this. This slide outlines the pathways for the international medical graduates who are seeking for practice in Australia, and this is determined by the AMC, which we will talk in depth afterwards. So the standard pathway is the most common one, and it sort of involves passing a written exam, which is the MCQ exam or an AMC computerized assessment test, and a clinical skills exam, which is a clinical assessment. A specialist pathway is designed for IMGs who are qualified specialists from their home country and want to practice the same specialty in Australia. So it sort of involves meeting the criteria as assessed by the Australian College of Medical Specialists, ACMS, for the chosen specialty, say physicians training, anesthetics, radiology, etc. So the specific pathways. Next, we'll talk a bit about the two main components of the assessment process for IMGs who are seeking the general registration in Australia. There are various sort of registration categories that come by the registration board. That is a limited registration, provisional registration, and general registration. One is expected to have a general registration prior to pursue any specialist training. A limited registration is when you have completed the AMC MCQ exam and you are able to secure a job. Once you secured a job for a 12-month period of time, you then have a what is called a provisional registration. And after you've completed the second aspect, which is the AMC clinical, you are then, and have the rotations for 12 months, you are then able to secure a general registration. So talking a bit about the MCQ exam, it's a computer-based multiple choice exam that assesses knowledge of clinical medicine across broad ranges of specialties: general practice, general medicine or internal medicine, pediatrics, psychiatry, surgery, and obs and gynae, which sort of focuses on the understanding of disease process, clinical examination and diagnosis, investigation, therapy, and management, and they are sort of marked across various domains. And the clinical skills assessment, which is the AMC clinical exam, again, assesses your ability to apply your medical knowledge and clinical skill in a simulated clinical setting. And what that means is more like a practical exam or an OSCE-based setting. So you are assessed on your ability to take a medical history, perform a physical examination, communicate effectively with patients and families, and develop a differential diagnosis, provisional diagnosis, and a management plan for care. Next. So the next one, please. Yeah, that. So that sort of gives you a bit of a gist on how the AMC MCQ exam is conducted. So the computer administered exam delivered in about 3.5 hour session at an examination center on site worldwide. India does now have centers in various parts of the country, which was probably not the case when I sat the exam a decade or longer actually. The test uses a computer adaptive format, which is sort of means the difficulty of the question is just based on the performance throughout the test. So if you answer a question correctly, the next question will be more difficult and it will be on the same topic. If you answer the question incorrectly, the next question will be easier, which then sort of works around further assessments. Next. Sorry, could I just go back to the previous slide? So it's a 150 multiple choice questions and only 120 of them are scored. The remaining 30 are what is called a pilot question and that are not used in your final scores but are being tested for future exams as a trial for performances or utilization for further examinations. You're not penalized for answering questions incorrectly, so you don't have a negative marking. And your final score is based on the number of questions you answer correctly and the difficulty of the questions you have answered. Next. These are some of the resources that are used. They don't sort of while the AMC doesn't specifically dictate specific learning material, they suggest that the resources can be used, and that includes the textbooks for the AMC MCQ exam, are the Anthology of Medical Conditions and Handbook of multiple choice questions. I think there are about a couple of editions that's been published on that, and they sort of help familiarize you with the format, the question styles that are used in the actual exam and help you develop effective test taking strategies. Next. AMC clinical exam. So this assessment goes beyond written exams and is designated to evaluate how do you apply your medical knowledge and skills in the simulated clinical settings. So basically you have a 16 station assessments, and at each stations you'll be expected to perform various tasks as doctor typically does, that is taking a history, conducting a comprehensive physical examination, communicating effectively with patients, and diagnosis and a treatment plan. Demonstrating clinical skills competently is primal in these scenarios, and your ability to gather information from patients and communication with sound language skills is important as well. Using sound clinical judgment to arrive at a diagnosis and propose a management plan. You can see on the slides around the pass, what reads as a pass, a clear pass, and a retest. If you are to score within the retest, which then means you are able to sit another test, which is a retest, and you're only to appear for about 8 station examination. If you score anything 8 or below, it means you'd fail, and you would then mean that you are to sit the entire exam. Next. So this slide, you're welcome to sort of take a picture if you like. It sort of gives you a summary. It's an extract from the website itself. Sort of helps you understand the process of applying for the standard pathway. So before applying, you need to ensure that you pass the AMC MCQ exam, and the AMC won't process your application for the clinical exam otherwise. So basic idea is you start with the navigation through the candidate portal, submit your application electronically, then apply for the center you want to sit your exam in, and you score that. Prior to doing all of this, there's an expectation that you have a required score through a mandated English exam, which is a PTE, OET, or IELTS, and then that then on the system allows you to apply for this examination. There are a limited number of spots available for each exam date, and application early to be able to secure a preferred date and location is important. And it's important for people to keep a timeline of the application deadlines, scheduling processes, fees, etc. Next. Specialist pathways. specialist pathway is for graduates with degrees. This pathway sort of allows overseas trained specialists to gain recognition of their qualification and practice their specialty in Australia. There's a couple of sort of aspects to it as well, which I'll sort of talk about in a bit, but particularly the specialist pathway is designed for specialists who have completed their training overseas and want to practice their specialty in Australia. To be eligible, you will need to possess qualifications from a program comparable to the relevant Australian specialist training pathway, for which you will have a matching. You'll have a process where a matching of your qualification is conducted, wherein it's assessed by the specialist training program, and then by submitting your documents that includes CV, transcripts, and training certificates. You then undergo what's clinical skills assessment, which is required for an examiner to assess your clinical skills relevant to the specialty. Advantages of the specialist pathway is gaining recognitions from the AMC to allow you to register as a specialist with the qualification that you possess. The pathway can sort of provide a clear path for overseas trained specialists to integrate into the Australian medical workforce. Next. And this slide talks about the self-assessment, which is through, again, having your assessments for the primary medical degree and then assessing for the relevant pathways that you are eligible for. And that would sort of tell you what training pathway you can then go ahead with, and then you have a specialist medical qualification that qualifies for you to apply to the college. By carefully considering your qualifications and goals against the self-assessment criteria, you're then able to make an informed decision as to what would be the most appropriate pathway for you to consider. Basically, for a specialist pathway, it would also sort of derive on the years of your experience as well, which then means even though you're eligible to apply for a specialist pathway, it might be that you're expected to go through a standardized pathway given your limited clinical experience in your host country, in the country overseas, which then sort of takes you back to sort of have a bit more experience and then have a re-evaluation of your eligibility. This slide is sort of a bit of, there's a lot of words in there. Basically, this flow chart shows for specialist pathway the eligibility and the application process, which sort of compares your qualification to an Australian specialist training program and meeting of the AMC English language proficiency standards. The matching of your qualifications against the standards of the relevant specialist training programs, and you might be required to undergo a clinical skills assessment. That means you might have to sit an evaluation of the practical abilities relevant to the specialty, whatever the field that might be. It's not specific for psychiatry, more so just in general. And the outcome, depending upon the assessment outcome, the AMC will issue the decision as to recognition of your qualification, which then means if you're successful, you'll receive a recognition of your qualification, allowing you to be a specialist in Australia under the medical board. MBA, which is the Medical Board of Australia, or a further assessment might be requested where you are to undertake further training assessments to meet the Australian standards. An unsuccessful outcome would mean that the specialist board will provide feedback on the area that you require submissions or improvements, and you are able to reapply for this assessment after addressing those areas. There is also a SIMG pathway which sort of derives your training or your qualification overseas. Say, for example, if you haven't had an opportunity to do a psychotherapy for a specified period that from Australian sort of Australian college requirements, it's a 40 session, that's about 12 months training. If you haven't acquired that in your overseas specialist training, then you are required to sort of complete that or with the clinical exam. It's what the college derives. Next.
Shreyas, I'm just mindful of the time. So, yeah,
I think that's all. I have spoken about this in terms of the registration pathways already. So
okay.
That's what we need. Thank you, everyone.
Thanks, Shreyas. That was very comprehensive. Namrata, do you want to go with just talking about life and what people do once they finish their training, what other options are available? I'll let you take it from here. Thanks.
Thanks. There are, hang on. Am I echoing or? Can you hear me now?
Yes, we can hear you.
And it's not echoing or is it still? Hang on. Is it all good?
Yeah, it's better. Yeah, thanks.
Okay, hopefully it's not too annoying. There are plenty of opportunities for psychiatry, especially in Australia. I can't talk about everywhere else. It is, in terms of a quite high demand field, and I guess with that, it allows you to allows other people to be very flexible to your needs. So I think that's one of the bigger things in terms of actual opportunities here. I didn't expect to fall into private psychiatry as quickly as I did. It's just something that happened. But in hindsight, I'd say private working even decades in public psychiatry will not necessarily prepare you for private psychiatry. They're two very different kettle of fish. So it's just something that you'd have to sort of get in there, test it out, and see whether it's something you like or not. Again, it's so flexible. That's the thing, is you can decide what hours you want to work, where you want to work. With the advent of telehealth and COVID and how that pushed that aside as well, you do have the flexibility again to decide what areas you want to work in terms of even states are not that much of an issue, so you can work with other clinics. So that's primarily it. I mean, in terms of what I'll do is I'll just have you go on to the next slide. I can just sort of, so that's just briefly about me, and I completed fellowship relatively recently in 2021. And again, even the training program is quite flexible as well. I was able to, you can do advanced training and pursue your general psychiatry almost simultaneously. So you can come out with the certificates as well. In terms of my own career, and this is where, again, that flexibility comes in. So I had the opportunity to work in a private hospital, which was inpatient private work and outpatient. And initially I started my career in a doctor-led private clinic, which outpatient service, where I did understand and do most of my learning to start my own business. And I continued to work as a visiting medical officer, as a psychogeriatrician in a public hospital. That's the job I resigned about 18 months ago, and I'm still there. And that's primarily, again, them being flexible to allow me to do different things. So I've been fortunate enough to keep that role, which is primarily old-age psychiatry, which has been my great interest. In terms of my own clinic, the opportunities I have with being able to incorporate different things, next step treatments such as neurostimulation, esketamine, and right now we're looking at opportunities to whether psychedelic therapy could be introduced to the clinic as well. So that's, again, just what we do. I thought I'd talk a little bit, I just want to go to the next slide. I thought I'd talk to you a bit of the benefits about private practice. I mean, of course, the primary thing is you're your own boss. The issue with that becomes that you're responsible for everything. And things that I wouldn't have even thought that were important, like the electricity, the IT, the marketing, everything sort of falls on you. And that year is a very difficult year, the first year, but I'm going to quote my kid's favorite movie, Finding Nemo. As Dory says, just keep swimming. And that's pretty much it with private practice. Eventually we'll get there. You have the control to navigate your practice in the way you envision. And I think that's the biggest difference between public and private, is not only just how the service would work, but how you practice. It can be more in line with what your ethos is. And of course, the patient cohort is quite different. We're more likely to find patients who are very committed in their own recovery. And you've got the luxury of insight often. I'm not saying all the time, but there's a degree of insight into their own health needs, which can make it quite rewarding as well. And as I said before, you can look into therapeutic modalities that may not be viable within the public system in terms of staffing, financial needs, and everything, and so on and so forth. I'll just have you go to the next slide. In terms of challenges, as I mentioned, it's really running a business if you're running your own clinic. Of course, you can always be a contractor, and that's where you work with another clinic and they charge you a service fee or whatever it is, so that they can take on the administrative roles, which is quite beneficial too. So you don't have the headache and you can just focus on the medicine aspect of it. The clinic does often, if you're running your own, the clinic does often depend on you as a principal psychiatrist and your skills in clinical governance, which is something that you sort of tend to, no matter how much training you do, it's something you just learn on the go. I think one of the biggest challenges is actually managing human resources. Now, as I said before, it's a very high demand field. Now, what that happens, so it's also very difficult to find more psychiatrists and administrative staff that are that can help support the practice. So those are the biggest challenges, really. But otherwise, if we're talking about psychiatry in general in Australia, it's such an amazing opportunity here. To really sort of fit in with your lifestyle, everything really. It's a great field. That's pretty much it.
Thanks, Namrata, for selling the Australian dream. I'm sure you're living it. What I'll do is I'll ask our next panelist, Deepti, to just talk a little bit about how it was to get into United Kingdom. Now, the interesting thing about Deepti getting into UK was, whilst Shreyas and Namrata went there post MBBS, Dr. Deepti went there post MD, and whilst I believe getting into UK, the requirements are kind of very similar to how it is in Australia. I'll just get Deepti to still talk about how it is in UK. So I'll move the slides. Deepti, over to you.
Thank you. Am I audible? Hello, everyone. Hello, can you hear me?
Yes, we can. Thank you.
Okay. So I'm mindful about the time. So in this presentation, I'll just quickly take you through the work pattern and UK training pathways for psychiatry. So yeah, as you all know, that since till 2022, I was working in India and then suddenly planned to move towards UK. That was, I can say, as a family, we were thinking what are the other options and how to see what's on the other side of the world, and lockdown helped actually to sit back and work on it. I did speak to Dr. Santosh Prabhu and Dr. Shishir about UK and Australian opportunities. The funny part was we tried both sides, and I got into UK and my husband got into Australia, that is Adelaide. And as you all know, where wife gets, husband has to come. So we chose to get into the UK and work over here. So currently he's working in University College London Hospital nearby to where I work. So as a family, we moved in. Okay, quickly, I just added these pictures of SHIMA because it's a SHIMA alumni meet, and 20 years back, I started my undergraduation. And I've always considered the Department of Psychiatry also to be my extended family. Yeah, I think next slide, please. We'll just run through.
All right, so I am currently working as a specialty doctor in geriatric psychiatry, as you all know with the introduction. The unit is specialized for screening, assessment, and management of neurodegenerative disorders and also covers mental health disorders in older adults. I just put a slide on the model of job plan. Just to give you an idea about, many people think, okay, in the West there is a work-life balance and how is it managed, and and at this stage of life when I have already completed my MD and I was practicing how it is to come over here. So yes, mine is an outpatient, so it is Monday to Friday, 9 to 5 job. After 5 you're not expected to take because I don't have on calls. We have a protected time for academics and professional development. Clinics are well booked in advance, so you know your routine and day. So it gives you enough time for you to plan for yourself and your family. But just bear in mind that here we have to do everything by ourselves, and it's not what the luxury we get in India of domestic health. Yeah. So let me quickly take you to the UK training system now. Now you can see the flow chart. This is following the foundation training. That is, foundation training is the internship. Back in India it is 1 year, but here it is 2 years. And then you need to give an entry exam, that is the multi-specialty recruitment assessment, to get into the core training for psychiatry, which is 3 years. During this time, they are expected to complete the MRC psych, which is the paper A, B, and CASP, to get into the higher training specialty. It may be older adult, forensic, and it is 3 years for one training and 4 years for dual training. So during this phase of higher psychiatry training, there is no exit exam. It's about competencies, evidences, and to get the completion of certificate to become a consultant. So when I say consultant, it's the ultimate. We do not have the grades what we have in India, like post-MD, SR, AP, associate. So consultant is the final decision takes along with the team. Yeah. So right now I am in this pathway. You can see specialist and associate specialist, SAS doctor's pathway. So I have two options where with MRC Psych, I can directly jump into the higher psychiatry training to get my CCT, or I can continue to work in the specialist and associate specialist as an SAS doctor and get my Caesar evidence and get the CCT and become a consultant. Yeah, next slide, please. Okay, for those who are interested to apply for jobs in UK or to do fellowships, yes, strong CV is something which you need to prepare. And we have a good amount of exposure. We have skills back in India, but only thing we need to write it down. Prepare a CV, add in additional exams or training, the gaps or breaks in between the career, reflections, audit, or leadership. This helps to get shortlisted for the interviews. Register with the NHS UK jobs website. You get a lot of advertisements. There are criteria to be fulfilled for the applications. And usually the recruitment happens in Feb or August, but the advertisement can be 6 months to 1 year prior. Then work towards your GMC. For that, you need to have the English language skills exam, that is the IELTS or OET. I wouldn't go deep into it, a lot of information. The minimum band is 7.5 overall, and each is 7. And then EPIC or ECFMG, this is where your medical school, that is the MBBS, not the MD psychiatry degree. The MBBS has to be verified by them and sent to the GMC. Now, to get to the GMC registration, that is the license to practice as a doctor, you need to either complete the PLAB or MRC Psych exams. But just kindly keep a note that when you're searching for the NHS jobs, there has been opportunities where they sponsor for your GMC. So you can skip the PLAB exams. Next slide, please. Okay. So a person who is doing a training in UK, so you can see the lengthy process. So foundation is 2 years, and then go into the core training, which is 3 years, complete MRC Psych, then go into the higher specialty 3 years, and then you get into the consultant post. But I think what everyone are interested in is when you complete your MD Psychiatry in India. Next slide, please. How exactly, what are the opportunities to get your CCT quicker? So see, you're at an advantage because minimum 3 years of psychiatry, you can skip the core training in 3 years, but you need to have your MRC Psych and a certificate C, that is the evidence, core competencies of what you've done in your psychiatry in your med school. Yeah? Then you can apply for your higher specialty training or go through the CSER and continue to get to the CCT and become a consultant. Yeah, I've made it as simple as possible to put in a nutshell for you all to understand and run through the slides. Yes.
And I think people can take photos of the slides so that you know things are. But most of this is available online, I would think.
Yes. Yeah, I've tried to compile it because online you will start getting scared. There's huge process. So this is directed so you can plan it better and work. It sounds simple, but a lot of paperwork, interviews, the process is lengthier. Yeah. I've just added these pictures of UK. UK is a beautiful country. You get to culturally diverse, you get to enjoy the festivals. Weather is something, I think it's unpredictable. Everybody know about the British weather. So I used to, Santosh used to send some bright sunny skies just turning into grey, gloomy rains everywhere. So it's better to keep your jackets and umbrella ready, even if it's summer. Okay, thank you.
Thank you, Deepti. That was
quick.
Very succinct, very quick. Thank you. And I think we'll go to the man who has done it all, been there, done that, doing it, working in 2 continents. That was, by the way, the departmental picnic was a departmental photo. So over to Shishir.
Thank you, Santosh. We'll start with the slides because we've got very little time left. So that's where I did my undergraduate education, finished my MBBS in 2001 and finished my internship in January of 2003. Went through the usual route that most undergraduates go through, write your IELTS exams during internship. PLAB 1 I did during my internship as well. And by the time I finished my internship, I was ready to take the PLAB 2. So 2003, I did the PLAB 2 and went to the UK. Finished my PLAB 2 and did a couple of observerships in the UK, in London and one in Southampton. And I was fortunate to get through the run-through training at the end of that year. I started my job in February of 2004. There was a 4-year rotation where you do 6 months of training in each specialty. Deepti has already, I think, must have mentioned different specialties that that you can work in the UK. Next slide, please, Santosh. So that's 4 years of what used to be called senior house officer training. Now that is called as core training or ST 1 to 3. So like Deepti said, you finish your MRC Psych part 1 during that time. Used to be 2 parts then with clinical and theory aspects of both parts. So I did that and finished that in 2006 and became a member of the Royal College in early 2007. Then things changed, the training opportunities changed, they changed a lot of the way training and appointment for training worked, so that messed up things for a lot of people in the UK, and that is when we saw the huge exodus of people moving, trainees moving to Australia in 2007 and 2008. So I did a couple of 1-year posts which were called locum appointment for training. They were recognized as training posts, but they were not run through training, so it's a 1-year contract that I did, and eventually got into training ST 4 to 6. Next slide, please, Santosh. So what used to be called the specialist registrar training in those days, which is currently equivalent to ST 4, specialty training 4 to 6.
So I did a one-year job in inpatient unit in Turkey, which is referred to as the English Riviera. And then one-year rehabilitation unit in Wanford Hospital. That's the picture of Wanford Hospital in Exeter. It used to be an old asylum. It was established in the 1860s. And we heard stories of consultants being able to play tennis in the afternoons in those days. Life was different then. But they have a new inpatient unit as well. So while I was doing those training, I did my hypnotherapy training from London in 2011. And when you do your SPR training, you get an opportunity to act up as a consultant. So for up to 3 months, if there's an opportunity, you're still doing your training, but you can act up and act as in a consultant role, of course supervised by your senior consultant as well. So I did that in Ivy Bridge, and I did a clinic in Kingsbridge as well. People will be familiar with Kingsbridge. It comes in the Aaron Brooks Cognitive Assessment. So that's where I used to run a clinic once a week. So then once we get into that, once I finish your training, Deepti mentioned there's no exit exams. There is what is called the ARCP, Annual Review of Competency Progression. So you have to demonstrate your competencies, demonstrate evidence that you've achieved the competencies, and a panel which involves the local dean from the local peninsula, the local deanery. They will review your evidences and sign you off as having achieved those competencies. And once you do that, then you get your certificate of completion of training, and you get to register with the General Medical Council as a specialist. And now I did my specialist training in general adult psychiatry, so I'm registered as such. So then I got opportunity to do a locum post 1-year contract with the Devon Partnership Trust in the same hospital. So I did that, and then things changed. We decided to move back to India, joined Schema in 2013, and I've been doing this job since. And every now and again, I go and do 2 to 3 months of locum jobs in the UK for 2 to 3 months at a time. Next slide, please. So career pathway for UK psychiatry, Deepti has already mentioned that, so I won't go through that again. Next slide. Right, current opportunities in the UK. One is the usual PLAB route, especially for undergraduates. They finish your MBBS, and that would be the route. The only difference would be foundation training is currently 2 years. Sometimes they do recognize the 1-year internship that you do here, so you can get away with 1 year of foundation training. Post MD, Deepti has mentioned the specialist, associate specialist route, that's the SAS grade. If you have 3 to 4 years of experience in psychiatry, you get to do what Deepti is doing as a specialty doctor, which is usually 40 to 60% of the consultant pay. Consultant pay currently is about starting with around 100K per year. It goes up to 130,000 pounds a year. And if you have more than 10 years of experience, you get to become almost like a consultant, an associate specialist, and the pay is a bit better as well. It goes up to 80,000 pounds a year. In that pathway, the jobs can be offered as a clinical fellow. There are different names for the different jobs depending on what is involved. They call it clinical fellow, staff grade job, trust grade doctor, or a specialty doctor. MRC Psych is preferred, but some trusts do offer jobs as long as you have the training without your MRC Psych as well. And those can be locum jobs for indefinite period of time, or sometimes it can be fixed term locums for 4 months, 6 months, a year, couple of years, or they can be offered as permanent positions as well. Most NHS trusts do want people to stay on because the recruitment costs are quite high, so they want people who can stay in job for the longest possible time. Next slide, please. Requirements, IELTS is a requirement, MRC Psych is preferable, or you should have the PLAB, one of those at least, and GMC registration. If you have the MRC Psych, you are eligible to become a member of the Royal College, and you should be able to get into higher specialty training as well. But you should be able to demonstrate the competencies that are required for CT3 completion. When you apply for jobs, look for extra packages offered by trusts. Sometimes they do offer, I know a trust in Midlands do offer family accommodation for up to 2 years, which is very helpful when you move first time to the UK. Some people do offer pastoral support as well. That includes allocating a tutor for you to help you with the GMC registration, opening a bank account, finding an accommodation, helping you through with exams and things like that. Just the regular things that you would need. Some trusts do offer a master's training course, MSc course as well. They sometimes offer it as an in-house training, so you're expected to finish that and you get to do a course for free. Sometimes they can partly fund that course as well. Next slide, Santosh. This is an example of the international recruitment program from one of the trusts in the Midlands. They offer GMC sponsorship, they offer 2 years visa, they support with professional development and mentoring, and with the postgraduate medical education to help you with your MRC Psych exams. Sometimes they offer a new starter package as well, including relocation costs and transition costs. Next slide. Same thing, relocation support, immigration support, exam support, career support, pastoral support. These are the kind of extras that many trusts do offer these days. Next, please. Right. Any international medical graduates joining for the first time, they go through an induction program, and this booklet is available online for free from most trust hospital websites. It's a 78-page document. If you're planning to go to the UK, worth going through that document because it is explaining what you can expect when your first job in the UK. Next slide, please. Right, locum consultant positions, which is what I'm doing every now and again. There are lots and lots of jobs available currently. But 2 things are essential. Most locum consultant positions does mean that you need to do work under the Mental Health Act. So that's detaining patients, treating patients who are already detained under the Mental Health Act. That requires that you are registered as a Section 12 approved doctor under the Mental Health Act of the UK. And you have to be eligible to act up as an approved clinician as defined by the Mental Health Act, which is a bit of a challenge for international graduates, and you need to maintain that. Some trusts do offer, after COVID, distant working opportunities. Most trusts have taken that away. You are expected to be at your workplace physically. But I know Devon Partnership Trust, and I know a few friends who still do remote working while they're doing locum positions, sometimes in permanent positions as well. And there are lots of part-time working opportunities as well. Lots of jobs are being advertised as 3-day, 4-day positions. Mandatory requirements are absolutely necessary. That includes your mandatory registrations with the GMC, with the Royal College. You have to have your annual appraisal documents done. You have to have your indemnity insurance. You need to be covered for your medical, clinical work. So if something goes wrong, that trusts are not to be blamed, and you have someone to insure your competencies. There's something called mandatory training that includes, things like safeguarding vulnerable adults, safeguarding children, knowledge of the Mental Health Act, knowledge of the Mental Capacity Act, and there's something associated called what is called as the deprivation of liberty safeguards for people detained under the Mental Capacity Act, fire training, basic life support, those kind of training. So you're required to have that done as well. CPD, continued professional development. So you have to show that your knowledge and skills are up to date, and you're registered with the Royal College for your CPD, and you're in good standing. From Royal College gives you a certificate. For that, you have to be part of a peer group, and the peer group approves your academic activities that you've done. Once they approve it, you upload it onto the Royal College website, and you get a good standing certificate from them. So those are the essential things to work as a locum consultant. Next slide, please, Santosh. There are some useful websites. The GMC, General Medical Council website, has a section on international medical graduates, worth visiting that. The Royal College also mentions support and information for international graduates. There's a website called imgconnect.co.uk. That's quite a useful website as well. You may need to sign in and become a member on that website. I think there's a forum where you can exchange information as well on that. Looking for jobs, Deepthi already mentioned the NHS jobs website, but there's also another website which called apps.track.jobs. Again, you need to register on those websites, and you'll be receiving applications, and you can apply for jobs online as well. I think that's probably the last slide I have, Santosh. Thank you.
Thank you so much, Shishir. Thanks for being succinct, very precise. I just want to know from the organizers, we run beyond time. How much, I've already got 11 extra minutes. How much how much can I have?
I'm being told we got 5 minutes, Santosh.
Okay, all right, okay. Okay, can I ask if there are specific questions from the audience then, rather than me sort of posing questions? I'll ask if there are specific questions in the audience. In the meanwhile, whilst we are waiting for questions from the audience, I might just go over some of the things that my team, I think the panelists said. Both Shreyas and Deepthi, I think, talked about the importance of documentation and having good logbooks while you're looking at going overseas and working. The rule is, if you haven't documented it, you haven't done it. So if there's something that you can probably take from and use during your training, during your work in India and looking at going overseas, be mindful of that. The second thing, again, something that Shreyas highlighted quite a bit, was the assistance that we get from alumnus and other people who are already overseas, the advice you get. So please reach out to people. There are many of us who are quite willing to help in case you have questions. It might help make your decision about coming. It might help make your decision about not coming overseas, not going overseas. So either way. Have you got any questions yet, Shishir?
None from the audience as of now, Santosh.
Okay.
Sorry.
So, I mean, that's all right. We all talked about the good. Oh, sorry, you got a question.
We do have a question from Dr. Nagesh Pai.
Santosh, can you hear me?
I can hear you very well, sir.
Good. One of the things which some of the members would like to know here, what if I have to shift now after, say, 10 years of working here? Would you have any tips or tricks for them? What your impression is? Somebody's worked here as a consultant for 10 years, now feels maybe I should have gone. Is it too late to go?
Okay, thank you, sir, for the question. I look around to see who's the most qualified to answer that question, and it comes back to you, sir. The most qualified beyond doubt about who can answer that question. But I suppose I'll ask if Deepthi would be willing to answer that question. I mean, Deepthi, you worked in India for quite some time, had a reasonable private practice, had a family, as in a family who's school-going children and so on, and you had to make the move. So how did you adjust? What tips would you have for people who are moving overseas a bit later in life?
Yeah, I think it depends on the individual's expectations from the West. What exactly you're looking into? Is it the finance? Is it the career growth? Is it the work-life balance? So I would suggest to keep a realistic expectations. But yeah, if it's your dream, then work towards it. Do a proper homework before relocation. What are your needs, comforts, and possible challenges you may face? Because when you're moving as a family, it's not only about you. You'll be thinking it will be about your partner. It will be about your child. So what I did is I did my homework back in India itself. So the school, as Dr. Santosh rightly mentioned, reach out to people. That's what my strong suggestion is: reach out to the people who are currently practicing or who have moved, and to know the system, because it's not about only the career. You need to think about housing, commute, childcare, weather. There's a lot to it. So once you've done, so why not try? Unless you try, you wouldn't location or experience of what your expectations are. And I feel the grass is greener where you water it and you nourish it. So if your choice is to come and see the West, yes, definitely, and you have the ability to water and make it greener here, or if you want to be in India and you're happy and you can do there also. Yeah.
Deepti, just following on from that question, what do you think about when you moved overseas and had that later in life, the emotional toll on the family, older children moving away from close family, the children moving further away from schools, their friends, the cultural shock, the having to establish new connections all over again. How was that a barrier? Is that sometimes a barrier? Is that something that you probably miss?
To be frank, I think we are blessed with people here. We have got a good circle of friends from Shema who have also kids. So we were in constant touch with them before moving into UK. So that's why I said to your homework. I was worried about my child, like how he will adjust. But then the COVID, if you remember, we had this lockdown and it was all online. I don't know if that helped my child to actually talk to his friends over online. I know social media, it can affect, but we're taking the positive aspects where you can regularly talk to your friends, parents. And here also the school were very welcoming, the teachers, and he was able to make friends. To an extent that whenever I went to drop him, they used to call by his name. He got awards for his studies, and right now we have again moved into the other school because there's a primary and secondary. He is getting along, and we are mindful about the culture, so we are in constant touch with our parents back, and we make sure we visit India at least once or twice a year because it's a 10-hour direct flight. Yeah, it's a challenging, but there are ways to work to make things happen what you want as a family.
Thanks for that, Deepti. I think we ran out of time unless there are any pressing questions, Shishir. Otherwise, what I'll do is I'll just ask if anyone, the panelists have anything to say before we wind up. Shishir, any further questions?
We don't have any questions from the room? Okay. I think if there are any further questions, I think, do we have any? Okay, that's the question. Where's the grass green? I think Deepti already answered that. Grass is greener where you nourish and water it. So I think Deepti said it beautifully. It doesn't matter whether you're in India or abroad. It's what your priorities are. And that's the only thing that I wanted to mention, Santosh. When we decide to either stay or go somewhere, there will be push and pull factors, what you don't like here and what is attracting you on the other side. So you be clear on those criteria, and if you're sure about it, then yes, do make decisions. If you haven't tried something new, you won't know. One of the good things about working abroad that I've experienced, especially in London, where we come across people of different cultures, you get to understand the human story, the human experience so much better, which is absolutely vital in psychiatry. Sir mentioned that in the keynotes address this morning. So that is something that you get to experience when you've moved out and worked at different places. And yes, just be clear on those factors which drive you away from the place that you are in, and the factors that attract you, because things do change. We thought abroad was much more much more interesting. 25 years ago, yes, there was a lot of difference between working here and working abroad. The lifestyle here in India has improved so much that you don't feel out of place when you go abroad, or someone visiting here are equally comfortable when they visit India. So the differences have somewhat reduced, the gap has reduced, I suppose. So it's a personal choice what works for each one, I suppose.
Yes, thanks Shishir for that, for summing it up for me very nicely. Appreciate that. I just asked if Shreyas or Namrata had anything in particular that they wanted to add, or they're happy with what they've said so far.
I was just going to add, for those who want to actually test the colours, there's another pathway in Australia which is called a specialist short-term pathway, SST pathway, which Santosh actually suggested I mention. And it actually offers overseas trained specialists, particularly in psychiatry, to have a supervised short-term training program for up to 2 years and acquire skills and experience that can significantly benefit their own healthcare system. Yeah, so that's another way to test the color if you're looking at it.
Thanks, Reyes. Namrata, was there anything you wanted to add?
Not really, but if anyone's coming to Australia, please feel free to reach out to me. I'm more than happy to help out.
Lovely. Thank you so much for being supportive. To all the alumnus, we are all one family, so it's good to hear that. I think I'll wind up without taking much time. Thank you so much to the panelists, to Shreyas, Namrata, Deepthi, and Shishir. You've all been busy. I've pestered you quite a bit to prepare slides or have a think about what we're going to do. And in amongst your busy schedules, you've took out the time and helped. I also thank the participants for being patient, and we've gone 20 minutes overboard, not throwing rocks and stones. So I appreciate the patient participants. I think I'll stop here. Shishir has summarized the whole thing quite well for me. He's done my job lot easier. Thank you.
Thank you, sir.
Thank you, Santosh.
This concludes our panel discussion. I would like to extend our gratitude to our chairperson and panelists who joined us online even with conflicting time zones and have been patient with the technical glitches. We hope this discussion has been insightful and informative for those interested in pursuing medical practice abroad. Now, we shall proceed to the next session.
Thank you.
Before we kindly note that 4 KMC points will be awarded for attending this CME. Also kindly note that spot registrations shall not be considered for CME credit points. All the delegates who have attended the program or CME can generate their attendance certificate through KMC website by using their user ID and login password. The same certificate will be considered for renewal of KMC registration. For all the CME programs conducted after 1st August 2023, KMC will consider the certificates downloaded through their website by the delegates who have attended the CME. Organizers need not send any certificates to KMC for signature. Our next session brings a refreshing approach with a case-based discussion led by Dr. Anil Kumar MN. He will guide us through intriguing case studies, offering practical insights and stimulating discussions. This session promises to be both interactive and informative. I am honored to introduce our next speaker, Dr. Anil Kumar MN. Dr. Kumar is an associate professor in the Department of Psychiatry at Kasturba Medical College, Mahe, Manipal. He brings a wealth of experience, having worked as a senior resident at Shema, Mysore, and later as an assistant professor at MMCRI, Mysore. Notably, he also spent 3.5 years working in community psychiatry at Melbourne Health, Australia. His areas of interests include clinical work and research in community psychiatry, suicide, psychopharmacology, and common mental health disorders. Dr. Kumar has been recognized for his contributions with awards such as Dr. P. Raghurami Reddy Best Research Paper Award at IPSOCON 2022 and Dr. Rama Murthy Foundation Early Career Psychiatrist Leadership Award from NIMHANS, Bangalore. Please join me in welcoming Dr. Anil Kumar MN.
Kindly note, the hard copies of the cases have already been distributed. If anybody hasn't received, kindly reach out to the MC desk.
Thank you for the kind introduction. So this session is focused for postgraduate students. May I request all the postgraduates to please occupy some of the front rows so that our interaction becomes easier, or else I will have to come all the way. That is not needed, sir. They can ask. So is that all we have? 4 or 5 postgraduates, or we still have more? So this is a real case, real patient. I hope all of you have read it. It was given to you much earlier. The only thing is the names of people and the places have been changed for the confidentiality issues. So otherwise, this is the real case, and so I'm not your teacher. This is not an exam, but we can just make it more interesting by being more interactive. I just want to know how many of you are first year postgraduates? Okay, fine. And second year? Thank you. Third year? So more or less a fair distribution. And how many of you are from Kshema? Okay. Father Mullah? Fine. Ennapoya? KMC Mangalore? So Mangalore has been well represented. AJ? Yeah. Did you also raise your hand for another college? No. Srinivasa? Okay. Do we have postgraduates there in Srinivasa? No. Anybody outside Mangalore? Kerala? Yesterday there was a quiz participant from Kerala. No? Okay. Anywhere other than Dakshina Kannada? Okay, so most of you from, all of you, almost all of you from Mangalore. Yeah. Given that you have gone through the scenario, I want one of you to formulate some first year postgraduate student. Do we have? I think I have used that one so that no, I don't know. Let it be here. Check. So as I said, there is no exam here. I am not your teacher. We all can contribute. It's not that one person has to give the entire diagnostic formulation. We'll also ask others to contribute. Where? Hand mic? No, okay. Some first years. Yes. You can give a summary or a formulation, whichever you are comfortable with. Diagnostic.
Good afternoon, everyone. I'll try to make it as
Yeah, sure.
18-year-old single female, Muslim by religion, coming from Kapu. With no significant family history. well-adjusted pre-morbid personality came to Kshema OPD with complaints of episodes of screaming out loud and trying to attack whoever is in the vicinity, the episode lasting for 5 to 10 minutes from past 2 weeks.
Okay, you want to pass it on? Thank you. Thanks. So, somebody wants to continue, some second year postgraduate? Ah.
Anybody who raises hand, they will get one cap prize. Okay? I'll keep it. Okay.
Sure. Will give? No.
Yes, we'll give it.
She told first.
Anybody tries?
Yeah.
So, a 18-year-old female from a rural population with well-adjusted pre-morbid personality,
Yeah.
who was adopted and with no family history of mental illness, has had history of sexual assault 1 year ago, followed by
alleged
sexual assault 1 year ago, and history of failed relationship following the assault, alleged assault, and history of multiple episodes of aggressive behavior since 2 weeks, and history of multiple episodes of loss of consciousness, and also history of voicing out strong beliefs which are not attuned to her social or cultural background. And history of previously being treated with antidepressants and anxiolytics and not being adherent to treatment.
Somebody from that. Yeah. Oh, inni ellaru bandilla.
And currently having history of active self-harm, episodic aggression and suicidal thoughts, and also on mental status examination, a patient being aggressive and trying to be physically aggressive towards the treating doctors, and normal cognitive function and subjectively non-persuasive sad mood, and also reports of being possessed on and off, and also being dead due to trouble of her parents, and voices about persecutory ideas, and also multimodal hallucinations in the form of seeing and hearing voices with grade 3 insight.
Good job. Anybody wants to add to it? Any final year resident? Good name? Sandesh also gets a chocolate. Any final year postgraduate wants to add, modify? Okay.
18-year-old single girl belonging to Islam from Kaup, studied till 10th standard with well-adjusted pre-morbid personality, past history of multiple episodes of sudden weakness and falling onto the ground with loss of consciousness, with the family history of being being adopted at 20 days of age, with the personal history of interpersonal relationship issue with the partner and alleged history of sexual assault by the partner, presented with the complaints of screaming and violent behavior with self-harm behavior since 2 weeks, of which the patient does not have clear memory, and episodes of non-throbbing diffuse dull aching headaches. On mental status examination, the patient was cooperative but had an episode of aggressive behavior towards the interviewing doctor, which was after which the patient was calmed down, and she had non-pervasive sad mood, reports being possessed on and off with intact cognitive functions, and death wishes present with persecutory ideas of black magic and multimodal hallucination with grade 3 insight.
Okay, thank you. Your good name? So Shreyas, so we can see how the confidence in formulation is becoming better and better as once you are getting more familiar and also becoming more senior from first to second to third year. So with this formulation, I just want some of you to, I mean it's not very difficult to guess the diagnosis. Somebody wants to guess the diagnosis? Personality disorder. Okay. I mean, there can be multiple options. We'll just explore it. Anybody wants to give another possibility? Sorry? Acute transient psychotic disorder. Fine. Anything else? Dissociative identity disorder. Very good. Any other possibility? Sorry? Adjustment disorder. Fine. How many of you are now, you have started using ICD-11 in your day-to-day practice? Nobody? You are still using ICD-10? Anybody using exclusively DSM-5? No. So all your diagnosis is based on ICD-10, right? Whatever you mentioned, isn't it? That's all, or any other possibility you are thinking of? Complex PTSD. Okay. Now, if we had more time, I would have asked you for justification of your diagnosis. But who told dissociative identity disorder? Can you justify your diagnosis? Sorry. Oh, I think maybe closer, or this one is better, I think. I will keep this here.
She has these episodes where there's seeming lack of awareness when at that time she doesn't claim to have even any awareness of what she is doing, the acts that she is doing, and they last for short periods of time, triggered by a stressful event or a memory, and following that she just claims to be possessed, but she does not exactly say what all she does at that time. So
yeah. So is there anything closer to this? Dissociative identity disorder, something closer to this in the same group? Sorry? Trance and possession disorder. You meant the same thing, or you meant trance and possession, right? So then can you tell me the difference between the two? Anyway, so all of you covered all these things, but possibly there were a few things that were confusing. We will come to that, which which made you all not to formulate it very clearly, isn't it? But most of you tried to cover all these points. So, diagnosis, as of now, I have asked you, there are multiple diagnostic possibilities that you have discussed. We will come there again. So, we will start with trance and possession disorder. Okay. I am now discussing the ICD-11 version of it, because that is what we all will be using in future, and some of the places have started using it. This is known as possession, there is no laser pointer, laser pointer. It's okay. So, in ICD-11, what they discuss is essential features first. Unless until specified within the diagnostic category, all features should be met in essential category. And then they discuss additional features. And this holds good for all psychiatric disorders in ICD-11. Okay. So, we will see what are the essential features. So, there should be a trance-like state where there is marked alteration in the individual's consciousness. That has to be demonstrated, and the individual's normal sense of personal identity is replaced by the possessing identity. So, this kind of some circumscribed behavioral change that is happening for some time has to be demonstrated. This is most important. And then trance episodes are attributed to the influence of the external possessing spirit. Like in this case, she says, I see Farida. Okay. I mean, she has some vague memory of it. She says, I see Farida, but she is still not able to very clearly say that I am possessed by Farida. But family members see that she is possessed by some ghost by name Farida. Okay. Then trance episodes are recurrent. As you see here in the vignette, that there are recurrent episodes. And the possession trance state is involuntary and unwanted. So, which is not very explicit, but she doesn't like really whatever is happening to her. In fact, she thinks that I am a burden to my family because of my illness. So, you will make out that this is something that I do not want. And also not accepted as a part of the collective culture. There is something in the vignette again which mentions family, it is alien to the family. So, not just that, the usual points which distinguish this from anything that is occurring because of another mental disorder or any substance use. That is also clear here, that she is not having any other comorbidities, and obviously this should present with difficulties in other areas of life. So, all these essential features, if they are met, then you can diagnose it as trance and possession. See, just read the portion that is highlighted from the vignette. Episodes where she screams in loud voice and tries to attack whoever is in the vicinity by attempting to throttle them, or at times by trying to harm herself by cutting the forearm. Okay, such episodes last for 5 to 10 minutes mostly, and then she returns to her usual self. In some episodes she just keeps weeping throughout and gives a different name to herself. Then another bit of evidence from your vignette. During some episodes, Salma even calls herself as Farida. In such episodes, she repeatedly says so, which means that she is very sure that she is not Salma, okay? That she is Farida. Total possession of another person. So when the episode ends, Salma has no memory of the finer details of the event. However, she knows that she is Farida. So there can be total amnesia or there can be partial amnesia. Both are accepted. However, such beliefs are alien to the family. Family as such does not have any superstition, and she is unable to maintain her premorbid baseline functioning due to the illness. So the last criteria of there should be socio-occupational dysfunction. So this is the last bit in the vignette. The MSc also, the interviewing doctor could witness an episode. Now coming to the additional features. So additional does not mean that they should always be there. They can be there, cannot be there, but their absence will not rule out the diagnosis. Diagnosis may still be valid, but some of the additional features sometimes helps you in guiding to the diagnosis. Trance and possession disorders tend to involve recurrent episodes, but in some individuals it can be just one episode that lasts for days together. If that happens in somebody, then also you can go ahead diagnosing as possession and trance, but usually it is episodic. So that's what the first point says. Possession trance disorder is usually characterized by full or partial amnesia, we have discussed that, and actions performed during the trance state are not very complex, but during the possession trance state are complex. Again, ICD-11 has classified this into two, trance disorder and possession and trance disorder. In trance disorder, there is just some motor abnormality which is not attributed to another person who has possessed, person or spirit. The person may just fall or just have a blank stare without attributing to anybody. So this is not a complex movement or verbalization. Whereas in possession and trance disorder, they also say that I am this, I am that. So this ICD-10 has not classified this into two. Both are subsumed into trance and possession disorder. So here you can see like how the point 3 says, during possession trance states, the activities performed are often more complex and frequently culturally accepted as belonging to a particular possessing agent. Here what they mean is that if you try to mimic somebody, lage raho munna bhai, there it's not possession, but he used to talk to Gandhi. Now if you mimic somebody who is historically a popular person, the other will know that yes, this fellow is trying to mimic this person. You may mimic Bhimsen or Hanuman, whoever. So culturally somebody knows that such a person existed, okay? But again, this is an additional feature only. It need not be always present. People may not know that who this person is trying to mimic, but it can happen. And finally, presumed possessing agents in possession trance disorder are usually spiritual in nature. So that's what she says, that there is a spirit by name Farida. So these are the additional features. So now forget the background, just read the letters in red. Screams in a loud voice and tries to attack whoever is in the vicinity by attempting to throttle. This is a complex behavior, isn't it? That's what the additional feature says. Again, red letters. Episodes happen almost daily, at least once a day. So this was the second point where it said it is usually episodic, but it can happen as a single episode, which is prolonged. Repeatedly says so. So repetition of the movement. Salma has no memory of finer details and screams in a loud voice. Again, another repetition of the dissociative complex behavior. Yeah. Now somebody says, this is normal, why you want to label it? I have seen this fellow behaving like this today and then tomorrow he is fine. What do you say? Can it be normal? Anybody who wants chocolate? Yeah. Yeah. So one most important thing in the diagnosis of this possession and trance, especially possession trance, it can apply to other disorders also, but this one you have to see whether there is a mass cultural acceptance. How many of you have heard of Siri in Hiryadka? Yeah. So mass annual hysteria that happens in a temple, Sri Veerabhadreshwara temple in Hiryadka around the months of English calendar of March and April. So one day in that year you can see people getting hysterical en masse. So you can't go and give a diagnosis to them there, even though you can clearly see that they are being possessed. So that's what this says. Experiences that are accepted in the individual's context as collective cultural phenomena or as part of religious practice, then you exclude it, even though you are explicitly seeing that there is a possession, and do not result in significant distress or impairment. The person again here is fine tomorrow. He was only possessed for a particular span of time. And in the context of pre-existing mood disorder, sometimes in other disorders, especially PTSD also, you will see dissociative episodes when the distress is at the peak, but that's very transient. Okay. So the longitudinal or established hierarchical diagnosis of mood or anxiety disorder is what remains. So, but there can be periodic dissociative episodes. Then also you are not supposed to give a separate diagnosis of this disorder. I forgot the chocolate for you. Please. Okay, so especially with trance and possession, be careful before you roll out whether it is normal, whether it is culturally accepted. Now I am giving you another scenario here. The same Salma, if she presents like this, Salma was brought to Kshema by parents who are worried that over the past few weeks she has started recognizing herself with different names. At times she calls herself Christilda and at times Fatima. When she becomes Christilda, she will behave as though she is a bold and confident police officer and speaks a lot of different things related to legal issues and convicts in India. On the other hand, when she says that she is Fatima, she will become a different person altogether, a pious, religious and kind lady who wants to help those who are in pain. Sometimes she will be like this for an entire day as a different person, and nowadays they are rarely seeing her as Salma, they are seeing her either as Christilda or as Fatima. Now, if this was a presenting complaint, what would have been your diagnosis? Sorry? Dissociative identity disorder. Any other possibility? Yes, you are good. You are correct. There are two different personalities here. So, in the possession and trance disorder, there is possession that happens for a brief period and it is attributed to a possessing agent or possessing spirit. Whereas in dissociative identity disorder, there is no attribution. I have become that person. I am totally a different person now. Internally, externally, okay. I may change even my walking style, which won't happen in possession and trance. Okay. I may change the way I speak. My accent can change. All these happen in dissociative identity disorder. Okay. So if you are very clear that this is there, both internal and external transformation of the person has happened, there should be at least two personalities. If it is one, again, no. What does ICD-11 say about dissociative identity disorder? Is there any classification again like how it was for trance and possession trance? Anybody? Okay, again this is classified into two: partial dissociative identity and dissociative identity. In partial dissociative identity, there is only one fully formed another personality. Now Salma is there and Christilda is there. Fatima keeps interfering with Christilda. Fatima is not a fully formed personality. Okay. Fatima is half formed. Whereas Christilda is an established another person within Salma. So this half formed personality interacts with another fully formed personality, which not only Salma, even Christilda doesn't like. Who is this interfering with me? Okay. Then it is partial. If it is complete, then there are two independent personalities that exist at different times. In most times, Christilda won't know who is Fatima and Fatima won't know who is Christilda. Okay. So those things are there yet to be cleared, but if this is the presenting complaint, whatever you guessed was right, that it is dissociative identity disorder. Yeah. So how to differentiate? Possession trance disorder is a marked alteration in the individual's normal sense of personal identity that is attributed to the external possessing agent. This is distinguished from dissociative identity disorder and partial dissociative identity disorder, which are characterized by the experience of two or more distinct alternate personality states that are not attributed to the external possessing agent. So these texts are directly from ICD-11. So Now this is another possibility. Now your Salma is presented like this. Parents report that Salma has become irritable and hostile for about a month and believes firmly that her boyfriend's family has done black magic on her. Salma appears perplexed at times as though she is under the influence of some force. She hears a spirit asking her to harm herself so that she can take her to meet her boyfriend. Now she even responds to the spirit by yelling at it. However, according to Salma, the actual plan of the spirit is to kill her through abatement of suicide rather than uniting her with her friend. You got it? Now if this is the presentation, what is your diagnosis? Paranoid schizophrenia, yes. So you are very clear about it, that the presentation is delusion rather than possession. So boundaries with schizophrenia, again the text taken from ICD-11. Intrusive symptoms of possession trance disorders such as hearing voices, insertion of feelings and thoughts, or exhibiting behaviors attributed to the possessing agent are distinguished from symptoms of schizophrenia and other primary psychotic disorders because they occur primarily during the possession state. Now, you should be able to appreciate these gray areas. The dichotomy of psychosis, neurosis is long gone. Okay? You can always find some psychotic symptoms in some neurotic disorders, but that will be in the context of that particular possession, so short lasting. So there can still be some psychotic symptoms. Which all other conditions you see psychotic symptoms? Non-psychotic disorders? Sorry? Personality disorder, good. PTSD, very good. Depression is not included in this because it exists, as a typical psychotic symptom, whereas psychotic-like symptom can be there in other disorders which are transient. You really don't consider them as psychotic symptoms, but they are still there. See, in this case, it was the persecutory ideas against the boyfriend's mother, okay, and multimodal hallucination. Most of the time, when you actually do a very careful interview, you will still be able to know that this is a pseudo hallucination, but the face value of it appears to be a hallucination. Usually, if there is a multimodal hallucination like this, okay, visual in addition to auditory, in addition to somatic, then usually it is non-psychotic disorder. Okay. PTSD also presents with multimodal hallucinations. So that is something that we can also appreciate in this case, that there can be psychotic symptoms, but they are not psychosis. Now this is another situation. Following the incident at the beach where Salma was drugged and sexually abused by her friend, she was deeply hurt. A few weeks later, Salma started experiencing the event in the present as though it is happening now. She would hear and see her boyfriend even though he was not present there. This would make her go to a state of trance and cry loudly. She would be too alert and emotionally aroused, especially when she is in public, and would startle if she saw a couple arguing or fighting. She even started avoiding any such stimulus by not going in public and specifically avoiding beaches. What is this? Yeah, PTSD. So most of you said, I don't have so many chocolates. So what is the essence, the core of PTSD? Reliving. Huh? Yeah, somebody said reliving and you said avoiding. Anything else? Hyperarousal, very good. Anything else? Most important than all these. Sorry? Very good. So trauma. First there should be trauma. Okay? Lot of patients, people after trauma may not experience PTSD. Okay? If they are very resilient, they'll just ignore it. Then it's not PTSD. However severe the trauma is. Yeah. So after trauma, 1 or 2 months later, when you see that the patient is having reliving experience. Now this reliving experience has also changed in ICD-11 from ICD-10. What was it? What's the difference ICD-10 versus 11 for reliving or re-experiencing? Anybody? This answer I will give you chocolate. So in ICD-10, reliving experience was just a memory. Now you think about it, that's enough. Whereas in ICD-11, it is a reliving experience of happening here and now. Now I am feeling somatically, somatosensory feeling that I am being raped now. Okay. So that experience is actually reliving, otherwise it becomes a memory. Okay. So that experience should happen which is there. Number 2 is avoiding. Because this experience is happening, why should I expose myself to the cues, the stimuli of this experience? I will avoid. Okay. Avoidance. And number 3, whenever they are still exposed, they have to go to a place with family, public place. Now they are very aroused, hyper arousal. Any kind of a noise or any trigger, any cue that makes them remind that will actually make them shaky. Okay. They are extremely alert of this. Whereas in ICD-10, trauma and then reliving was enough. Avoidance may or may not be there. Okay. It's not an essential feature. And hyperarousal is not at all there. But what they say is autonomic symptoms. Okay. They don't use the word hyperarousal. There can be panic attacks. But here it doesn't mean panic attack. It's just a state of alertness, state of extreme alertness that I should be very cautious now. Okay. So this is the revised concept of PTSD in ICD-11. Yeah, so if this is the presentation, then it is PTSD. Complex PTSD, it adds another thing, probably we will not go to that now due to want of time. Yeah, boundary with PTSD. So ICD-11 says PTSD and complex PTSD may include flashbacks or other dissociative trance-like states characterized by narrowing of awareness of immediate surroundings and re-experiencing of the traumatic experience as though it were happening here and now. See, in this case, she still feels, she would hear and see her boyfriend as though he was present there, and this would make her go to a state of trance. So trance is happening here, but you should not diagnose trance because it is in the largest picture of the PTSD. Okay. Now what is the ICD-11 diagnosis? Not this one, the original vignette. ICD-11, what's the term? Yes, trance disorder. Is it trance or is it possession trance? What is the difference between trance and possession trance? Trance disorder, you don't complain that somebody has possessed me. In possession trance, it also includes that complaint. So it is possession trance disorder. Now, what is your ICD-10 diagnosis? Yeah. So it is trance and possession disorder, which includes both. It's not differentiated into two. What's your DSM-5 diagnosis? Trance and possession. Any other DSM language? In DSM, it is classified as dissociative identity disorder. Why? Dissociative identity disorder is entirely a different thing, right? But why DSM-5 calls it as dissociative identity? So, see, this is one paper published by Subramaniam et al. In 2020 in the Indian Journal of Psychiatry. Now, he has compared how when you are faced with the problems of consciousness, identity, memory, what is the difference between the Western manifestation versus the Eastern manifestation? This may not be in the absolute sense because in the 21st century the this fusion of East and West is an ongoing process. Not all of them may present like this, but then it is still a lot more relevant when you compare West to East. So when there is a splitting of consciousness, our people manifest dissociative trance, whereas the Western people manifest depersonalization. That doesn't mean that depersonalization will not be diagnosed in India. No, it is still there. But most manifestations happen this way. That is why we don't see a lot of depersonalization in India. How many of you have seen D syndrome? Nobody, right? But you all might have seen the dissociative trance. So this is the cultural difference. Even I have seen very rare cases, maybe 2 or 3 cases of depersonalization and derealization syndrome, but a lot more of the trance. Because the culture, the Western and Eastern culture, this is how it manifests. Then splitting of identity. See, here lies your answer. Possession and trance disorder, possession and trance with external control is our manifestation, whereas dissociative identity is the Western manifestation. So what DSM-5 has done is they have subsumed all cases of dissociative trance and possession under dissociative identity. So it is like a small brother of dissociative identity. So that is why there is no separate term for this. Even though it is trance and possession, in DSM-5 you are going to diagnose it as dissociative identity disorder. So the bigger version of it is the actual identity disorder that we discussed earlier. Even the treatment, see the cultural difference. For us, we can even suggest a faith healer. Our patient themselves goes to a faith healer and they will be cured, be it a placebo, but still it has a therapeutic effect. Can you send a British national to a faith healer like this? So it won't work, right? Even the opposite of that is true. See, for them, they need a therapist who resolves dissociation and hypnosis. Can you send a very remote village, uneducated, or some tribal man to a sophisticated psychotherapy? It won't work. Yeah. That kind of a sophistication and psychological mindedness is needed. Okay. Again, this is not in absolute sense. As I told, the East and West fusion is happening, so a lot of our people can also respond to such kind of sophisticated therapies, provided they have that kind of a awareness and knowledge. So, but still this kind of referring to a faith healer and referring to a therapist across cultures, it is still valid. Yeah, so we have done the assessment now. Based on that assessment itself, we came up with that history. But I will again emphasize to give importance to the cultural context in the case. Okay? Otherwise, the diagnosis will not be valid. Understanding and cultural and religious background of the individual is crucial, as beliefs about possession can vary widely. So I will ask you, how do you manage? Now, some first year JR should give me the management plan. Who will give? Now you know the diagnosis. So tell me what you will do. No, management plan. Yeah, first scenario only. The others I just discussed, what can be other possibilities that can be related. Now let's come back to the case vignette. Your first year? No, yes. Nobody to judge, even Srinivas Bhatt is not here. So. Whatever you do, you don't worry about whether you are read in a book or not. What comes to you?
Basically, sir, the what dissociation is basically is could be because of poor coping strategies or what they're repressing their feelings.
Yeah.
So the acute condition we might treat with to calm the patient down, we can give medicines. But for a long-term basis, we need to consider what exactly causing those dissociative episodes. So for that, we need to find out what the background conditions, if there is any traits which is causing it, and if there any the case of rape case which is there, was it subconsciously still there? She was not addressing to those that could be addressed. And then regarding her being the initial stage, they've shown the boyfriend was not very good to her, but despite that, she continued being in that relation. Even her having those thoughts that she might have raped him, but she still continued to like him. So that thought process also need to be addressed, and remaining many other factors is what that could actually help out to make those dissociation episodes calm down. So this is what I thought.
Very good. See, you have answered well. So yeah, so the priority is different when it comes as an acute case as well as in the ongoing stage. So what is important is, again, I would point at the cultural context, study it, whatever helps to the patient who belongs to a particular culture, whatever is more relevant. So deciding upon that, and then the biopsychosocial model, what is biologically, psychologically and psychosocially essential for the patient. Multidisciplinary approach, which can include your faith healers. And then plan acute, intermediate and long-term management according to the need of the patient. So I would work according to these pillars. So coming to the cultural context, now this patient, Muslim by religion, familiar to the tradition of coastal Karnataka and familiar with Bhuta Kola culture, and also family does not believe in superstition. So these are the points that may be relevant to you while you take up the psychosocial management. Biopsychosocial model, so biological understanding of dissociative disorder as a medical problem which needs medication, and then psychological intervention that is dissociation focused. So what she mentioned, you need to focus on those episodes, why exactly they are happening, what is happening. I will finish before this. And then how to integrate those dissociated parts of the self, and then psychoeducation of patient and family support to parents. They also may have a lot of carer burden. So this is your overall biopsychosocial assessment which will guide you to the treatment. So multidisciplinary approach, psychiatrist, psychologist, social worker, psychiatric nurse, medical doctors, cultural healers, spiritual advisors. I mean, I am not forcing you to go to some cultural leader, but you can actually have a open discussion. You can just discuss with them as to when such a crisis has happened in the past, what has worked with you, what has helped you. They will come up with some things like this. You can tell them, be free, be open to discuss with me, and we are not going to judge. So when they say that we go to this particular Maulvi, then you say, I encourage it. No, whatever is helping you in addition to this, I am not against any of these things. So what helps you is that patient can actually have more trust in you, because a lot of patients do all these things before they come to you, but they won't tell you because they think that you judge them. But when they know that you are not actually judging them, that trust will increase. So having this discussion is helpful. Then SSRI, which has the most evidence for dissociative disorders, but not for dissociative disorder as such. For the invariably these patients will have some depressive symptoms or some anxiety symptoms. So for a symptomatic remedy, you can give SSRIs. You can give anything else also, but usually most research is on any of the SSRIs. And then antipsychotics, again, wherever there is a symptom like this where the patient is presenting with aggression, a low dose of risperidone or any other antipsychotic can help. And ECT also can be considered, because she was having this particular patient herself, when she was in the hospital, there are many layers to this. I just gave you the crisp of what is relevant for this dissociation. There are the case is even more complicated than this. Okay. So once she went to the toilet and the bathroom tile was broken, and she opened one of the broken pieces and then she slit her wrist. It was deeper and then she needed stitches for it. So consider ECT when you are seeing a very active and lethal self-harm attempts. And dissociation focused therapy is the treatment of choice when you consider the longitudinal treatment. Okay. This involves psychoeducation, stabilization, trauma processing, integration, building a coherent narrative, strengthening identity and autonomy in different stages. Okay. So this is how you plan your multidisciplinary approach. Then again, finally, the acute, intermediate and long-term plans. Acute plan IP care, inpatient care. In this case, definitely yes. Then parenteral medication to begin with, and then slowly shift over to oral medication, and then consider ECT if that's not working. Okay. Then psychologically, grounding techniques, emotion regulation. Okay. So relaxation, emotional support to patient and family, and then intermediate stage, stabilize on the oral medication dose, see what is the least, the best effective dose. Start trauma focused or dissociation focused techniques. Now this is the stage when they are settling down, you initiate the therapy. And then family education or carer burden for the family. And in the long term, consider medication tapering based on improvement and stability, space out therapy sessions, and plan termination or any psychosocial supports as needed. Yeah. Yes, that's the end of my session, but any questions are invited. Yeah. You need this? Huh. No. So, yes, I told you there are many layers to it. She had, this happened somewhere around 6 months ago, not today. And that too, it's her claim. She says, I woke up from that sleep in the beach and I suspect that he has done something to me. Not even, she doesn't openly say penetrative sex. She says, she has probably done something to me because my body was aching. And not only this medical examination, even the forensic evaluation also has happened, and that has been documented, registered. Okay, thank you. Any other doubts? Srinivas.
This transcend positional states. There are attribution towards the lower intellectual levels. For example, lower social maturity, social deprivation, means even lower educational level, and the culturally backwardness. The root origin of this dissociation is basically psychological in nature, where there is psychodynamically the phenomenon of dissociation, which is the continuum of the basically deprivation, which results into the conflict, sub-level, subconscious conflict. Okay, so there are many instances where we have seen attributing the cause to low social maturity, social deprivation. So you want to add something on that?
See, most of the things what you mentioned is right, because that's one of the cultural difference, East versus West. Unfortunately, the national average IQ of India has still not crossed 70. So that is how most of our vulnerable population are prone for this kind of a disorder. So
suppose
Yeah.
You see this side, this Bhuta Kolas, the many places you see, the commonest is the possession with the goddesses. It may be like our side you see Saudati Lamma or something like that. So it and more is seen in the female population. Female populations. So this, there are some studies which they have done on the ground. They have attributed towards the lower education, social deprivation, and the low intellectual, intellectual levels.
Yes. Yeah, all points are valid because that's how the most of the eastern population is. Their poverty levels are more, education levels are less. So the presentation with this kind of a symptom is more. Okay. Okay. If there are no more questions, I will stop, and I thank the organizers, Dr. Srinivas Bhatt and Satish Rao sir especially, and the whole team for having organized such a wonderful event and giving me this opportunity to interact with you all. Thank you.
Thank you, sir, for a truly engaging and insightful case-based discussion. Your expertise and interactive approach has provided us valuable perspective. We greatly appreciate the time and effort you have dedicated to this session. Thank you once again for your excellent contribution. I would now like to call upon Dr. Niveda to kindly present a token of gratitude to Dr. Anil Kumar MN.
Now comes the most exciting part of the entire event, that is felicitating the winners of various programs conducted yesterday. First, let's begin with the paper presentation. For presenting the awards to the awardees, I would like to call upon Dr. Nagesh Pai sir to kindly felicitate them. Award for the best paper goes to Dr. Tanvi Mittal, GMC Koikor. At second place, we have Dr. Juhi Shuri.
The poster presentation awardees, I would like to call Dr. Aruna. Now, award for the best paper goes to best poster goes to Dr. Nishant Aithar from Aegis Shetty Institute of Medical Sciences, Mangaluru. The second place goes to Dr. Tanvi Mittal from GMC Kozhikode.
Moving on to the quiz competition. For felicitating the awardees, I would like to call upon Dr. Anil Kakunje sir. The first prize for quiz competition goes to Dr. Tanvi Mittal from GMC Koikor. First prize, sir. The second prize goes to the team of Dr. Nitish Juntra and Dr. Nandana Muralidharan from K.S. Hegde Medical Academy.
And the third prize goes to Dr. Priyanka Jha and Dr. Priya Datta.
Now, moving on to the next session, the topic is psychosis in elderly, clinical insights and management strategies. It is my pleasure to introduce our esteemed chairpersons for the session, Dr. N. Manjunatha and Dr. Srinivas Koski. Dr. N. Manjunatha due to some reason, Dr. N. Manjunatha will not be able to join us. So introducing the other chairperson, Dr. Srinivasa Koski, who is currently affiliated with Dharwad Institute of Mental Health and Neurosciences. He was working as medical officer in Yenepoya Medical College, Mangaluru in 1998 from September till December of 98. He was working as a lecturer in the Department of Surgery, Yenepoya Medical College from December of 98 till Jan of 99. He has also worked as mental health officer in Raichur. He was working as junior resident in Department of Psychiatry in Imhans. He has also worked as a assistant professor, Department of Psychiatry in K.S. Hegde Medical Academy from October 2006 till 2012. He was also working as an associate professor, Department of Psychiatry, Dharwad Institute of Mental Health and Neurosciences, where he is working till date. He has also been the medical superintendent in the same institute from March of 2017 till April of 23. He has various areas of interest as well, including family therapy as well as clinical research. He has been celebrated with various awards and recognition. Firstly, being a principal investigator, Center for NAIN 2.0, Host Institute under Department of Electronics, principal investigator in MedTech platform, as well as the principal investigator in Center for Music Therapy for Mental Disorders. I would now request our chairperson, Dr. Srinivasa Koski, to kindly introduce our speaker for the session.
Good afternoon, everyone. Today's the speaker I'm going to introduce. This is Dr. Apurva, Senior Resident, Department of Psychiatry, NIMHANS, Bangalore. I'll request her to come to the stage. She has experience of, she has done diploma in psychological medicine at Kasturba Medical College, Manipal University, MD in psychiatry from K.S. Hegde NITE, deemed university. After that, she has pursued a postdoctoral fellowship in geriatric psychiatry at NIMHANS, and she has done a senior residency in community psychiatry at NIMHANS. So she has various areas of interest, working with geriatric psychiatry, community psychiatry, psychiatric rehabilitation, and adult psychiatry, especially in schizophrenia. She has been recognized with awards. She has received a gold medal for Best Outgoing Student for academic year 2018 in the Department of Psychiatry, Manipal University. After that, she has been awarded with Dr. H.S. Subramanian Memorial Best PG Award at CANSIPS 2020, awarded IAGAMH INTAS Award for Best Paper National Conference of Indian Association for Geriatric Mental Health in 2023. Author of various articles and chapters in reputed journals and manuals. I'll request her to start the session.
Thank you, Srinivas sir. So good afternoon everybody, or rather good evening-ish everybody. Sleepy, tired, little. Coffee is on its way. So bear with me for a little while. So the topic for now which has been given to me is psychosis in elderly. I won't take a lot of time on this, and we'll have it like more of a didactic session. Sorry, not a didactic session, and more of an interactive session, because I think it's been quite some time since we are just listening. So this whole session for the next 30 minutes, you are going to be teaching us psychosis in elderly. And right now, we're going to be doing it under the assumption that you all already know what is psychosis in an adult person. In the sense, the not child and the non-geriatric person. The assumption is you already know that, right? Hey, don't say no. All your consultants are here only. So let's make it interactive. Let's make it a little enthusiastic. We know you all are very enthusiastic from last night. So let's not pretend. Let's go ahead with this. So beginning with this, let's see two case scenarios. Say there is a 25-year-old male. Screen is visible, right? Like everybody is able to read it. So say we have a 25-year-old male. He has persecutory delusions, auditory hallucinations, social withdrawal, and some behavioral changes from 2 months. What are going to be your differentials? There's no chocolate here, so just say. Fast. Paranoid schizophrenia, okay. Then, substance-induced, excellent. Then, you have to be really fast. Something spontaneous will come to you, right? 1 month or 2 month history of some psychotic symptoms. What else will you think of? Organic causes, okay. Traumatic brain injury, okay. In a 25-year-old person, may not be the first thing, but okay. Then, maybe delusional disorders. Mood disorder, nobody will think of. Mood disorder, mania with psychotic symptoms. Then substance-induced psychosis, and maybe some organic psychosis, right? So focus on this, that if there is a 25-year-old person, say in the earlier to middle age group person, in the second decade or third decade of their life, if there is a symptomatology of purely psychotic symptoms, these are the common things we sort of think of. There is a 65-year-old female. She comes with same symptoms, behavioral changes for 1 month or 2 months, hallucinations, delusions. What all will you think of? Explain organic. Dementia, okay, very good. Dementia, so dementia meaning psychosis related to dementia, which is BPSD of dementia, okay. Then, be loud. Excellent, space occupying lesions or some organic pathology in the brain, very good. Then, stroke maybe? Will you think of stroke? Somewhere stroke happened, some organic pathology happened in brain and psychotic symptoms happened. Space occupying lesion. Infections, maybe. I didn't exactly say that there is fever, but then there could still be some underlying subsyndromal infection. Then of course we will also think of schizophrenia, that can also happen. And delirium, which you all didn't say, but delirium also is another common thing. And of course our dustbin diagnosis, psychosis NOS. So here what you all need to focus is how your own interpretation or how your own differentials changed when the age, just the age of the person changed, just with the age. So now, going with this background, so now I understand that you all know that with the age, there is some set of differentials you think of, and yeah. So keep this case scenario in mind, because this is the case scenario we're going to be basing the next 30 minutes on. 65-year-old widow woman, she's living alone, has hypertension, chronic kidney disease. She's brought to emergency department by her neighbors for behavioral changes and food refusal. Patient says she hears voices. She's paranoid with false persecutory beliefs. She's become socially withdrawn, refusing food, not able to take care of herself. She believed that people can pass through her door and enter her house without her opening it. She claims that sometimes she can also see these people who were usually her deceased family members. Premorbidly, she is known to be a little suspicious, sensitive, quarrelsome behavior. So she was more lonely, like children would not visit her, and she had very few friends. When you did examination, she is alert, unkempt, fidgety, consciousness oriented only, occasionally muttering to herself, speech is tangential, coherent, suspicious. Clinical examination is otherwise unremarkable, and there is a corroborative history from family. It revealed no significant recent events and patient was not taking any drugs. So in this particular case scenario, every line is important. Okay? So your major question is going to be, how will you approach? You get to see such patients in your practice. Wherever you're working out, you get to see such patients. It should be fairly common, I suppose. So we will be speaking about first, what is the difference between a young onset, late onset, and a very late onset? Is it really important to know all of this? What are the differences between these three, organic versus non-organic? What are the differentials? And what is the management approach? I personally feel that every topic has to have some history, and history is the one which gives it a kick and makes it really interesting. So for late onset psychosis per se, it was started by Kreplin, of course, somewhere in the year 1917 or something. He gave the concept of paraphrenia. You all have heard of paraphrenia? What is paraphrenia? I didn't know when I was in first year, so it's a very nice thing that you know. What is it? Say something. I'm already impressed that you know, or you've heard of it. Paraphrenia is psychotic symptoms without a significant functional impairment. So there are lesser affective symptoms, lesser personality changes, lesser negative symptoms, but predominant psychotic symptoms. So Kreplin came up with this concept of paraphrenia. He didn't exactly mention the age, but he said it happens somewhere in the later part of the lives, and it's similar to dementia precox. Dementia precox, I'm sure you all know, was earlier called as schizophrenia only, with lesser disturbance of emotion and volition. Here came Manfred Bleuler. He's son of Eugene Bleuler. In 1943 or something, he said we will call it as late schizophrenia. Late schizophrenia is anybody who's having onset of symptoms after the age of 40 years. And symptoms are similar to early onset only, except the volition and emotional problems. Then Roth and Morrissey said, no, 40 years is too early, we'll call it after 60 years. So anybody who has onset of symptoms after 60 years is called to have late onset, and they have predominantly paraphrenic delusions. So again, mostly the similar things. Personality is preserved, but they have some passivity feelings, less volitional disturbances, and more hallucinations. फिर उसके बाद came American Psychiatric Association, DSM-3, DSM-3R. They said if anybody who has onset of psychotic symptoms after 45 years, we won't call it schizophrenia only. But then people did have. So then in DSM-3R, they gave an entity of late onset schizophrenia as a specifier to anybody who was having onset of symptoms after 45 years. So with so much going on, so many fights happening between so many people, there was no proper consensus that what exactly is late onset and is it even there. So then International Late Onset Schizophrenia Group, they divided it in three: non-late onset, and very late onset. Non-late onset is anybody who is having schizophrenia-like symptoms, onset is before the age of 40 years. Late onset is onset of psychotic symptoms between the age of 40 years and 60 years. Very late onset is onset of psychotic symptoms after the age of 60 years. So this is how they divided it. And little bit difference is what they told was that in late onset psychosis, it resembles early onset only, but the symptom severity is less and there is lesser executive dysfunction. Very late onset ones, they said that it happens more in women. There are more of non-auditory hallucinations. There is more prevalence of persecutory and partition delusions. Lesser FTD, lesser negative symptoms, lesser family history, and this usually there is also a lot of comorbid illness and accidents. So now our organizers have given me 1 hour to talk about this. Is this topic really important? Or In other words, how do we decide that studying about a particular topic is important or not? Prevalence, that how common is it in the society? Yes. Then burden of the disease, which is talking about the prevalence itself. Then morbidity, and also probably we all already know adult schizophrenia, no? So what is it different in elderly schizophrenia that we actually need to have a topic on that? So yes, we will see these two things. Prevalence is definitely important. As per epidemiological catchment area, which is one of the most important epidemiological studies, they say that the prevalence of schizophrenia, which is the point prevalence, it is 0.6% and 0.2% in late and very late. However, the lifetime prevalence is almost equivalent to what we see for a schizophrenia. Giving a very crude example, India's population is almost 145 crores, which means 1.45 crores are the people who are having schizophrenia. 1.45 crores is a pretty huge number. And likewise, if you do some proportion in your head, utna maths I don't know, but if you do a similar calculation, it's actually a very, very huge number who need to be addressed in that particular age group, which is post 45 years. Community-wise, there is still, the prevalence reaches almost up to 4.7%. And if you see, in nursing home and in IP care, the late onset psychosis prevalence shoots up to almost up to 50%. What could be the reason for that? Why is it that we see more of psychotic symptoms for people who are either admitted or who are in nursing? Chalo, you have one positive reinforcement also. They can have delirium, exactly. There are higher chances of more severe illnesses, more delirium chances. Since sir gave, so you deserve the first chocolate. Anything else? Lack of stimulation, where? Okay, yes. So in IP person, the people are already sick, and plus there are additional lesser sensory stimulations in them. Okay, so yes, the different various conditions like delirium, neurocognitive disorders, delusional disorders, they are at a much higher frequency and more severe when they are in IP setup. So definitely the prevalence is high, it needs to be addressed, and it needs to be studied in a different way also. Next, as per the Western literature, the annual cost of this schizophrenia is very high. The emotional cost for the patient and for the family members is very high when they're taking care of a schizophrenic patient. The caregivers feels there is some sort of loss of identity and a significant burden, and we read a lot of articles on expressed emotion. That is very high. When an elderly person doesn't come just alone. They come with a myriad of, physical problems and so many things. Treating them is complicated, and of course the research on this is very scarce. So does this make it important? Study on geriatric psychiatry makes it important? Yes, it does make it important. But then all of this is important for policy making, Western literature. Do we care about it so much? We do care about it. More than that, our Southeast Asian roots makes us more emotionally responsible for our grandparents. So not just for these policy reasons, but also for our emotional reasons that we do want to care for our grandparents. They should be in a healthy mental health. So geriatric psychiatry becomes of again utmost important. So coming back to the case scenario, I'm not going to read it out, quickly read it out and tell me what are the risk factors you see in this lady. Because there's chocolate to give. Living alone. Comorbidities. She's first. Premorbid personality. Okay, you already got one, no? Next. The quicker you answer, the quicker the session will get over. You can see. Living alone, widow woman, hypertension and chronic kidney disease, and of course the premorbid personality. Hypertension and chronic kidney disease, is that not a risk factor? It probably is, yes. So most of you, I think, covered most of the things. Risk factor in an elderly person, for them to be prone to having a psychotic symptoms are these. Sensory deficits, we all know as we age, our vision goes down, our hearing ability goes down. Social isolation because of the upcoming nuclear structure of the family, the obvious age-related death of the family members, etc. Age-related cognitive decline, pharmacokinetic, pharmacodynamic changes, cerebral structures, neurochemical changes, etc. Like we discussed, an elderly person will almost always have some polypharmacy, medical comorbidities, frailty, and other psychosocial factors. Here in this slide, what you all need to remember is, whenever a person comes to you, there will not be anybody who will not have any risk factor. Something or the other, at least the age-related things will almost always be there. And if there is one risk factor, that person is more prone to other risk factors also, which means if somebody has sensory deficits, visual and hearing deficits, they will also have other medical comorbidities. They might also have other comorbidities. They might have other cognitive decline. If they can't see, if they can't hear, their thinking abilities also slow down. So we have to be very, very mindful of whoever has what risk factor in an elderly person. Again, same case scenario. Now, what are the main signs and symptoms in this patient? Fast, fast, fast. Sorry? Food refusal, okay. I'm talking about the classic, this thing. Okay, hearing voices. Or persecutory ideas, delusions. Incapable of self-care. Socially withdrawn. The ones which you need to focus on. Yes, who said? Visual hallucinations, excellent. He's saying that she can see people who are usually deceased. Anything else which you normally don't see? There's something, one very classical thing there, which I had not seen till I saw a geriatric patient. Have you commonly come across this phenomena of, she believed that people can pass through her door and enter her house without her opening it? Suna hai kabhi? Have you heard of this? What is this? Phantom border syndrome, or also partition delusion. Yes. So in this patient, the clinical features are, like you all said, behavioral changes and food refusal over the past 3 years, hearing voices, paranoid beliefs, incapable of self-care, people passing through her door, see these people, unkempt, fidgety, tangential speech, suspicious, and muttering to self. So, clinical features of early onset, late onset, and very late onset. Remember, the symptom profile of people who have late onset and very late onset are more or less similar. It's just that there is lesser affective flattening and the prognosis is relatively better. Visual, tactile, olfactory hallucinations, more common. Partition delusions are a lot more common. And of course, the other third person and other auditory hallucinations are common. They are a lot less likely to display formal thought disorders, affective flattening, and blunting. And if the onset is happening after 60 years, which is very late, then the formal thought disorders and negative symptoms are even more rare. All right? So we are not going to be talking about what are the psychotic symptoms, we're just talking about the differences. So talking about the cognition now. Late onset people, if you compare them with early onset people, people who started having psychotic symptoms early versus late, the difference in them is that late onset will have better speed, better thinking speed, better memory, abstract and flexibility of thinking. But if you compare them with healthy controls, a 50-year-old male who has psychotic symptoms versus 50-year-old male who does not have psychotic symptoms, they might perform poorer on executive functions, motor skills, learning and verbal abilities. Okay. So you understand where the cognition is different. For very late people, very late onset people, they may have some impaired functioning in learning and memory retention as compared to their healthy control people. So when you're taking history, remember 6 Ds. 6 Ds are delirium, drugs, disease, depression, dementia, and delusional disorder. and you remember it through the duration. So if the duration of symptoms you are getting in days to weeks, think of delirium, think of drugs, think of other disorders. If the duration is somewhere from weeks to months, think of depression and other affective disorders and psychotic symptoms related to it. And lastly, if the psychotic symptoms we are getting are from months to years, think in lines of schizophrenia and BPSD. Going with our proformas, family history with related to schizophrenia, late onset and very late onset, it's usually less. Personal history wise, they have lesser rates of substance use, they have better premorbid functioning, better education, better occupation. So this is one very good table I found in one of the psychiatric clinics of North America. This was published, I think, in the year 2017 or 18. In this, I want you to focus on how early onset and late onset, they are a little similar. And very late onset and POD is psychosis of dementia. How is that similar? So if you see, family history is seen in early and late onset. However, the negative symptoms are also seen in early and late onset. But cognitive impairment, that is more prominent in very late in persons with dementia. Thought disorder is more commonly seen in early and late onset. Auditory hallucinations are again more towards the very late in dementia side. This is giving me a hint that maybe schizophrenia lies in a spectrum which starts with early onset, late onset, and they are kind of a similar entity. Very late and dementia, psychosis related to dementia, they are coming up to be a similar entity. It's not proven. There are still studies which say otherwise, but it's something to think about. Physical examination wise, of course, we will do our vitals, all the vitals, we'll do pickle, we'll do our systemic examination, higher mental functions, cognitive function test. Which examination in this should be done for our patient? Importantly, or which is the examination which we can skip? Something. We'll skip vitals. Okay, which can we skip? All we have to do is the right answer. We have to do all the examination in an elderly person without fail. There is no other way around to it. Even if the person comes to you walking in completely healthy state, physical examination is a must, and no step in physical examination can be missed. Investigation wise, you have to go through all the investigations, whichever is possible, at least in your setup, right from your complete blood count, liver, renal, electrolyte, metabolic, thyroid. I don't think I need to say all of this in detail. Emphasis is that all the investigations have to be done. Brain imaging wise, it has been studied that patients who have late onset and early onset schizophrenia, they have larger ventricular size, larger thalamic volumes, and some periventricular white matter and subcortical hyperintensities. So when a person comes to you, when an elderly person comes to you with some neuropsychiatric problem, with some psychotic symptoms, think about a medical and neurological workup. Then you think about medications and substance use. Then assess for cognitive impairment. Then think of primary psychosis. The highlight of this particular slide is, see where is our primary psychotic symptoms coming. The highlight is that you have to first rule out everything else, then you have to focus on psychosis. Coming back to our case again, what would be your differentials? Stroke, okay, very good. Then dementia, then it can be dementia. Delirium, okay, very good. Delirium is a very important one. Even though the timeline doesn't really agree, but yes, delirium is an obvious thing. Reason being, in an elderly person, it's not necessary that delirium will happen only for like a week or 10 days. Delirium can be protracted also, delirium can stay back for a longer time also. So yes, delirium. Then कहाँ क्या कल का excitement? बोलो. Catatonia. Catatonia is a symptom. It's a psychotic symptom. I'm talking about disorders. What all differential diagnosis can you make in this? Organic. What inorganic? Space occupying lesions, okay. Infections, okay. Maybe medical problems, right? Autoimmune disorders. Depression with psychotic symptoms. So mood disorder with psychotic symptoms. Very nice. So I think most of you have already told it. Most common cause in an elderly person is delirium for psychotic symptoms, wherein we have to keep a special focus on medications and infections. Hallucinations, delusions are seen in almost more than half of the patients. Remember, in delirium, visual hallucinations are more common than auditory hallucinations and then any other modality. Usually, psychotic symptoms are seen in hyperactive delirium. Next comes, we got another one, BPSD, which is behavioral and psychological symptoms of dementia. We'll start with Alzheimer's dementia. Rate of psychosis in BPSD in Alzheimer's is almost up to 40%. Hallucinations are again more commonly visual than auditory, and usually those auditory, the visual hallucinations they see are of things in people who are important to them. Delusions, most common beliefs are of theft, infidelity, abandonment, etc. Usually this happens, like the BPSD symptoms in Alzheimer's happens somewhere in the middle to late stage of dementia. And if somebody has psychotic symptoms in dementia, it's sort of suggestive of a rapid decline. Lewy body dementia, visual hallucinations, we all know it's a little bit more common. Psychotic symptoms are a little bit more common. Parkinson's, the prevalence of psychotic symptoms reach almost up to 60%, and usually psychotic symptoms comes again in the later half or later stages of Parkinson's disease. Extrinsic causes are a lot more common than intrinsic causes. So how do we differentiate if something has dementia, if a dementia is because of Lewy body or because of Parkinson's? Thought of something, okay, sensitivity, yes. Can you say again? In which one? Yes, you're very right. So this deserves a chocolate actually, and a round of applause also. So, like she rightly said, in Lewy body dementia, the Parkinson's symptoms start, then within 1 year, usually the person starts having some cognitive decline. In Parkinson's disease, after motor symptoms, usually after a year, almost after 1 year, the cognitive decline kind of starts. That is the difference between, which is indicating about the rapidity. So this is one table again I found, a very nice table, which is talking about the difference between psychosis of dementia and schizophrenia. So when somebody has dementia, the psychosis prevalence is a lot more as compared to the general population. The delusions are more bizarre and more complex when it's schizophrenia, not in dementia. The first rank symptoms are more common in schizophrenia, not in dementia. Past history is usually rare in psychotic dementia. Usually the psychosis remits with a lesser dose in dementia as compared to schizophrenia. Then talking about psychotic depression, usually delusions are more common and they're mood congruent. So there'll be nihilistic delusion, delusion of sin, guilt, somatic delusions, etc. And like she said, catatonia, which is a sign of more severe depression. Delusional disorder, most commonly persecutory delusions, and specifically in elderly, parasitosis, delusional parasitosis, misidentification, sense of present, partition delusions. These are some characteristics delusion which are relatively more common in an elderly person with some obvious risk factors which we have already spoken about. Coming to substance induced, again more common in men. If at all there are any hallucinations or delusions in a person, think it could be because of withdrawal also and because of intoxication also. There are various medications which can cause psychotic symptoms in elderly, right from our anticholinergic, analgesics, anti-neoplastic, Parkinson's, corticosteroids, interferons, etc. Medical causes, I usually remember it with the mnemonic of MINE, M-I-N-E, metabolic, infections, neurological, endocrine, and anything and everything can actually cause psychotic symptoms in an elderly person. And I think, interestingly, we had two posters which were presented here. One was by Dr. Aisha from AJ, and one was by Dr. Shibbil. Dr. Aisha's poster, if I remember, it was on SLE. So 75-year-old person had SLE and had psychotic symptoms. And Shibbil's was, I think, somebody developing mania or psychosis after the use of ATT drug. So normally, probably in us, we may not develop psychosis if we take an ATT drug. But because those are elderly people, the brain is a little bit more degenerated, more prone, they are more prone to getting psychosis. And also, in these two papers, what at least I understood was that the medication which was required to keep them on maintenance was relatively lesser. Like Shibil said, in his patient, they were maintaining the patient at 2 milligrams of risperidone, and patient is okay. Which brings us to the treatment. So what do you think is the dictum in an elderly person when it comes to treatment? Start slow, go slow. Before that, there is one more dictum. First of all, eliminate all the possible secondary causes of psychosis, for which you have to start with delirium, all the metabolic causes, the whole of mind, all the medications, etc. If you don't find anything, first try some non-pharmacological treatment. If that also doesn't work, then you think of giving an antipsychotic. And we have to see the risk versus benefit analysis. Like she said, the dictum is start low, go slow. So how usually, it's very difficult to remember the doses for everything. Like we already have a table for us to remember for adults. Elderly ke liye, how do we remember a new table? So I usually remember it as whatever you're giving for adults, give half of it. So if you're giving risperidone 2 milligram to an adult person, start with 1 milligram or even lesser if possible. There's no harm in starting a lesser dose. You can always build it up. So risperidone ideally should be started with 0.25 to 0.5. Slowly increase it. You can go up to almost 3.5 per day. Quetiapine, commonly used dose is 100 to 300, contrary to what we know. We usually, the antipsychotic dose of quetiapine is almost up to 800 to 1000, right? Olanzapine, 7.5 to 15. Aripiprazole, relatively safer, 15 to 30. I don't think I need to emphasize how important side effects are. We have to be mindful for every single side effect which a drug is capable of causing. Why do you think that is? Yes, definitely. They are more sensitive, their body is more sensitive, the brain is degenerating, and they are usually on multiple medications. So the chances of interaction is also a lot more higher. So the side effects we need to be mindful of are the obvious: cardiovascular, sedative, anticholinergic, metabolic, EPS, TD, hypoprolactinemia, agranulocytosis, NMS, hypotension. Hypotension, I would like to focus more because a lot of time we don't ask them, and ultimately the patient comes to us with a fall, and that's when we think, Acha, okay, there could have been a hypotension episode. So this is a table. I will pass on the slide so you don't have to take a picture or memorize it. But just understand from this one is that the medications are more or less similar. It is risperidone, quetiapine, olanzapine, same drug only. But the dose which is required for, say, late onset is more than dementia with BPH. And late onset and delusional disorder, the doses is more or less similar, but if the psychotic symptoms are because of dementia, the dose required is a lot lesser. Non-pharmacological treatment-wise, again, I won't go in a lot of details of it. The usual CBT, social skills training, cognitive training, if the person is capable of that. And there's also one interesting thing I found was functional adaptation skill training, which is like a group therapy kind of thing, wherein they are focusing on the functional adaptation of these older adults. Like in morning, KP sir was also saying, now the concept of rehabilitation and improvement is changing. It's not just your clinical remission. In elderly people, when you're talking about improvement, when you're talking about remission, it's more towards healthy aging. It's more towards successful aging and community integration, and not just clinical remission. Again, like we said, an elderly person doesn't come with just an age-related phenomena. They might have hepatic impairment, kidney impairment, then your heart impairment and all of that. In those conditions, we need to be a little bit mindful of what medication you can give and which one not. So this is all there in Maudsley. If it's an hepatic impairment, prefer giving amisulpride or sulpiride. Avoid drugs which have a longer half-life, which are more sedative for the risk of causing hepatic encephalopathy, and weekly monitoring of LFTs. Renal impairment, assume that all the old people have some form or the other of mild renal impairment. Usually we prefer giving aripiprazole, haloperidol, pimozide or acinapine. These are kidney safe drugs. do not give amisulpride or acylpride because they have an exclusive renal excretion. And we have to be a little cautious with risperidone, olanzapine, and so on. For heart disease, the predominant effect is orthostatic hypotension and QT prolongation. So the preferred drugs are more of aripiprazole, olanzapine, risperidone with a constant monitoring of ECG. So now is the final thing. How would you finally approach a person who comes to you? If there are psychotic symptoms in an elderly person, first of all, check for disorientation and changes in their consciousness. If it's okay, it's delirium, investigate and treat accordingly. If not, then take the detailed history, clinical examination, see what all drugs they are on, rule out medical causes, blood investigation, check for cognition. If then when you see the cognitions, if you feel that the memory loss is before the psychotic symptoms, treat it like psychosis secondary to dementia or behavioral and psychological symptoms of dementia. In that, your first choice should ideally be acetylcholinesterase inhibitors, donepezil or memantine. After that, you can think of giving some antipsychotic. If you feel that no, there is no memory loss, think of treating it as like primary psychosis. In the primary psychosis, if you find any form of polarity, treat it as bipolar affective disorder, mood stabilizers, or antipsychotics. If there is no polarity also, treat it like schizophrenia or delusional disorder and start them on antipsychotics. Is this okay? Next. Choice of antipsychotic will depend on what are the lab investigations, what is the patient's choice, usual preferences, atypical antipsychotics. Additionally, if somebody is catatonic, suicidal, it's safe to give ECT. Dictum, usual dictum, start low, go slow, keep the minimum effective dose possible. Then you can slowly adjust your medication according to the patient's tolerability and their response. If required, it's okay to add sedative, but at a lesser dose with very frequent monitoring. Assess it over 6 to 8 weeks. If it's effective, continue at the same dose. If it's not effective, try some other atypical antipsychotic. Still not effective, give clozapine. And if the person is having poor compliance, they're not just taking medications, assess what are the causes of poor compliance, give psychosocial support, therapies, investigate other causes, and treat accordingly. Right? So coming back to our case scenario, how would you treat this patient? What would be your drug of choice? How would you want to now do? Not talking about risk factors or anything. Now we are talking about the final drug. And it can have multiple answers, so anything is fine. Abhi bada chocolate. It's a woman with hypertension, chronic kidney disease. She has late onset psychosis, rather very late onset psychosis. What would you want to give? With how much dose? With what monitoring? Assume you've done all the investigations, it is very late onset psychosis. Aripiprazole, how much? And with what monitoring? Start with 5 milligram aripiprazole. Once in 2 weeks. Monitor for akathisia. Okay, then. mg may not be preferable, but maybe up to 15-20 mg with a regular monitoring of akathisia. Start with 5 mg and we can increase up to 30 mg. Excellent. Say aripiprazole doesn't work. Next, what would you give? He took the easiest answer. Risperidone. How much? Give it like properly. 0.5 milligram. EPS. Along with EPS, do you want to monitor anything else? Okay, drowsiness then. She's a heart patient. I mean, she's cardiac, so hypertension and kidney disorder. Do you want to monitor anything else? So you want to monitor for ECG, you want to do RFTs, start at risperidone 0.5 milligram, increase up to 2 to 3 milligrams, and then very slow. Jaldi jaldi bolo. Or increase it accordingly. Okay. Aripiprazole also failed, risperidone also failed. Next. There's only one answer. I told no. Clozapine. How will you give clozapine and how much? 12.5. Okay, very good. What all would you want to monitor?
The RFT and the RFT, LFT and serum electrolytes. Seizure. Then she's comorbid, so fever and pneumonia. Myocarditis.
Excellent. So this is how our usual approach is going to be. Start with aripiprazole, doesn't work. Try risperidone, doesn't work. Give clozapine, right? So is it clear? So clear? Okay, I think we can have a big round of applause for Nitish. I'm sorry, your name. Ayush and Bharat. So the take-home points are psychosis in elderly, early onset, late onset, very late onset, more common in females, more positive symptoms, lesser personality and cognitive involvement, earlier remission, reduced chronicity, treatment, start low, go slow, monitor tolerance, polypharmacy, medical issues, acute onset late life psychosis, consider organicity unless it's proven otherwise, and always keep a broad differentials, especially neurocognitive disorder. Right? So these are my references, and thank you very much.
I think she has captivated your attention. It was more like an interactive session. I should congratulate, we have more younger teachers who has given everything prepared. And suppose you get a question like this in approach, definitely if you could write whatever she has enumerated here, like you will get a full marks. So it was a very nice presentation, madam. And she has taken it right from history. We know that without knowing history, we don't know how to create a history. I think she has taken from the baseline, like how this evolution of the elderly psychosis has come, and how their different views have over a period of time has changed with respect to the age criterias. And she has also given different types of classification. When you look at as a late onset and very late onset diseases. And she has also spoken about the epidemiology, what is the current scenario of the epidemiology and how we approach, what is the different hospital-based, the population which suffers from elder psychosis. And also she has given the account of how the elderly psychosis can be a burden in terms of financial burden to the family and their approach towards it. And I could enumerate, but I'll just try to cut short. And she beautifully explained all the aspects, right from its the understanding psychopathology, treatment, understanding the adverse effects of the disease, and how to approach. It's a very wonderful presentation, and thank you for this wonderful feast.
Thank you. Thank you for being such a wonderful audience. I know you all are very tired, but thank you so much for your active participation.
With this, we come to a conclusion of this session. Indeed, elderly presenting with psychotic symptoms is rather challenging. I'm sure this presentation, which was very interactive, helped clarify doubts regarding the presentations, possible differentials, and management of the same. We thank our speaker, chairperson, and audience for being a part of the session. Now I would request Mr. Paul to kindly present a token of gratitude to Dr. Apurva. I would also like to call upon Mrs. Agneta to present a token of gratitude to Dr. Srinivas Koski. Moving on to the next session for the evening. The topic for the next session is Understanding Psychosis in Youth, Challenges and Interventions. It is my honor to introduce our esteemed chairperson for the session, Dr. Virupaksha Devramane. He is a consultant psychiatrist at A.V. Baliga Memorial Hospital, Udupi. He has an experience of being a consultant psychiatrist from 2008 in Dr. A.V. Baliga Memorial Hospital, Udupi. Member Parenting for Peace Volunteer Organization in Surat. He was also the chairman, Addiction Prevention, RI District 3182. Runs the Rural Psychiatric Satellite Clinic at Karkala. His areas of interest lies in spreading awareness about problems faced by children due to parental addiction, public awareness talks to teachers, parents, and community on child psychological well-being, coordinating with experts from fields of art, music, and theatre to spread awareness about mental health through media. He has also authored 10 books in Kannada on concepts of preventive psychiatry. He has won S.S. Jairam Award for Mental Health Writing and Dr. A.S. Dharendra Memorial Endowment Award 2024 for Mental Health Literature. The speaker for the session is Dr. Kinnari Doshi. I now request our chairperson to kindly introduce our speaker.
Thanks, organizers, for the opportunity to be chairperson to this wonderful session. I think all of you are awaiting for this session. Adolescent related issue. As a postgraduate, I think I had seen hardly a few cases, less than 10 child and adolescent cases. And now, every day, you must be also seeing many child and adolescent cases day in and out nowadays. Immediately when getting into profession, we'll feel that we are not equipped well to deal with adult cases. Somehow we manage. There is no one who will blame, or everyone will cooperate if the adult cases are quiet in a day or two. But adolescent cases, neither the patient is happy to come to you, nor the family members are very grateful if you decide on some management plan according to you. So here we have an expert in the field, Dr. Kinnari Doshi. She is alumnus of this esteemed institution, KS Hegde Medical Academy. And after this, she went on to do her postdoctoral fellowship in child and adolescent psychiatry from Vijayawada Institute of Mental Health and Neurosciences in Andhra Pradesh. And currently, she is the registrar in Department of Psychiatry, Bharat Dr. Baba Saheb Ambedkar Municipal General Hospital, Mumbai. Very, very proud to see these designations, Kinnari, being alumnus of this institution. Consultant psychiatrist at Campos Mentis Mind Clinic. This is another, she is entrepreneur also, or what we call psychiatripreneur or mental health preneurs. So she is starting up a mental health startup where she wants to involve all faculties along with her in the board. Her areas of interest is child and adolescent mental health, study of adverse childhood experiences. If you have been here in the morning, Dr. Pai's lecture, a whole lot will make sense if you are giving interest from now. what is this adverse childhood experiences and prevention of child abuse, prevention of childhood trauma, childhood emotional neglect. So these terms will become, very, very, very important terms to you, because when you look at the preventive psychiatry aspect of it. So substance use disorders, sexual wellness, obsessive compulsive disorders, prevention of suicide and self-harm in skill building. And she has been principal investigator for quite a few studies, and she is author of many articles in reputed journals. And proudly, she has taken 3rd place in Spandana quiz held at IPS South Zone CME in 2019. More than this, she is very friendly psychiatrist and dancer by herself. So that's where I think she'll make a very expert in the child and adolescent psychiatrist too. Kinnari by name herself, I think she is a musical expert and goddess of wealth. So let's see what is she has store to tell us about her specialty, the psychosis related to adolescence, please.
Hello everyone. Yeah. Good afternoon everyone. I'm here to present the last topic of discussion for today, which is understanding psychosis in youth, challenges and interventions. I'm very thankful to Kshema Psychiatry to give me this platform to have a discussion on a topic of child and adolescent psychiatry. I'm very thankful to Dr. Virupaksha to give such a pleasant introduction to me. I'm hopeful that after the amazing presentation of Apurva, I will continue to have your attention. Anyway, so let's move on with the topic. So before we start the hardcore discussion about, one second. Yeah. So with the, before we start the core discussion about psychotic symptoms and the schizophrenia in early onset cases, let us just again briefly revise what are psychotic symptoms. So psychosis, as we all know, is an umbrella term for a range of qualitatively different than normal experiences affecting thoughts, feelings, behavior and perception. So when we say qualitative, means it is different than the quantitative differences which we see in neurotic or affective cases. The various psychotic disorders which come under this umbrella term are schizophrenia, schizophreniform disorders, schizoaffective disorders, delusional disorders, organic psychosis, acute and transient psychosis, and a lot of other psychotic disorders which already Apurva has also talked about. Now, clinical diagnosis of all the psychotic disorders in all age groups is by certain operationally defined criteria, and majorly two clusters are important, which we will be briefly going through, the positive and the negative symptoms. And today we will specifically focus on schizophrenia, which is considered as a chronic psychotic disorder, and hence it's considered as a more serious and debilitating illness. Now the positive symptoms, again briefly running through it, are hallucinations, delusions, the passivity phenomena, disordered thought and speech, an inappropriate emotional reactivity to a particular situation. The negative symptoms are, they represent the reduction or a loss of normal function, which includes the poverty of thought and speech, blunted affect, impairment or loss of volition, motivation, and social withdrawal. Hallucinations, again, as you all know, these are sensory perceptions without an external stimuli. As we just had a session on late and very late onset psychosis, she had specifically mentioned that in the late onset cases, what we see is more of visual and other hallucinations rather than auditory. In early onset cases and in schizophrenia particularly, we tend to have more of auditory hallucinations. Now these auditory hallucinations could be first person, second person or third person. So first person auditory hallucinations are thought echo, is when the person can hear his own thoughts speaking out loud to himself. Second person auditory hallucinations is when he can hear the hallucinations or the voices talking to him or addressing him. They could be derogatory, they could be commenting on him, they could be even commanding him. The third person auditory hallucinations are wherein there are certain voices which are talking about him, discussing him, or even planning against him. So this is what they hear. Now delusions are again firm, fixed, false beliefs, which are out of proportion to what we expect from the cultural or educational background that the person is from, and they cannot be explained by whatever whatever reality testing we let it go through. Passivity phenomena can again, it mainly includes the major three thought phenomena, that is thought insertion, thought withdrawal, and thought broadcasting. Disordered thought and speech is wherein the person can either have increased volume or increased emotional reactivity, increased volume of speech, or certain thoughts wherein there is, like, you can describe it to be chaotic mind or the chaotic thoughts in the mind, and an inappropriate emotional reactivity for the same. Negative symptoms are, they are kind of self-explanatory, whatever is written here. Now, depending on the age of onset, so symptoms of schizophrenia, they typically emerge during the classic schizophrenia, which we have learned in our textbooks, the adult onset schizophrenia, that is the one which typically emerges during the late adolescence or adulthood, like early adulthood. So around more than 18 years of age, we classically see around in their early 20s. But depending on the age of onset, we can divide it into various, like early onset, very early onset, late onset, very late onset schizophrenia as well. So today I would primarily be discussing the early onset schizophrenia, which is when the schizophrenia symptoms come at the age of less than 18 years. And very early onset is when the schizophrenia symptoms come at the age of less than 13 years. Biologically and clinically, early onset schizophrenia is also continuous with the typically adult onset forms. Okay, so the symptoms, as Dr. Apurva mentioned, a lot of differences in the psychotic symptoms in late and very late onset. It's not as different in early onset schizophrenia. They are quite typical of how an adult would also present with schizophrenia. So this kind of implies that there is diagnostic stability of the early onset schizophrenia symptoms into the adult life as well. Now, just talking briefly about the clinical phases of what a person goes through when, or what a child goes through when he's been having symptoms of early onset schizophrenia. One thing is that in most cases, like especially in 20 to 30% of cases of early onset schizophrenia, we see there is an association with early developmental delays. Now what does this mean? Now this early developmental delays could be gross delay or even subtle neurodevelopmental delays. So there could be delay in, say, certain aspects of motor skills, fine motor skills. There could be lower IQ. So a global delay wherein the intelligence quotient of the child or the adolescent is a little lesser than what we see or what we consider as normal average IQ. There could be poor receptive language skills as well. And this association is a bit more common than what we see in adult schizophrenia, adult onset schizophrenia. Also looking, so when we take it as a retrospective thing, okay, we try to look behind and we see that such subtle neurodevelopmental problems are quite typical and common in the early onset cases. 30% of the cases could be having impaired social skills as when they were a child. 30% of the cases may be having pre-morbid IQ of less than 70. But interestingly, just the way we look behind and we find that, yeah, most cases, like around 20-30% cases have neurodevelopmental delays as a part of their history. when we try to prospectively look into it, so if there is a child in front of you who has a neurodevelopmental delay, does not always mean that he is going to have schizophrenia or early onset schizophrenia in the, at the age of 18 or so. It just tells us that there are chances that history will have some sort of neurodevelopmental delay. Hence, it is very, very important that when you take a case of child with an early onset schizophrenia, it's very important that you focus in detail about the developmental history. Now, even in the cases of neurodevelopmental delays, it's not necessary that each and every child with any sort of delay will have schizophrenia only. There could be other varied outcomes. The child may be prone to having ADHD, autism spectrum disorder, or even say obsessive compulsive disorder or other anxiety and depressive disorders. Now, pre-morbid psychopathology. So when we, just like we talked about the early, the neurodevelopmental delays that can be present or are associated with early onset schizophrenia, there are chances that the child may have a pre-morbid psychopathology of, say, attention deficit hyperactivity disorder, autism spectrum disorder, conduct disorders, or even other depressive and anxiety disorders. This is very, very commonly seen in the clinical practice as well. So, if I have to just talk about one case wherein the child when the child was 17 years old and he came with the symptoms of paranoid delusions. But when we looked into the development history, it was still not a full-blown schizophrenia. But when we looked into the history, the developmental history, there were minor delays in the socio-occupational social functioning, a bit withdrawn behavior when it comes to, the mingling with other kids at school. And I mean, when he was around 12 or 13 years of age, and also he was having symptoms of autism spectrum disorder, wherein at the age of, when he was a toddler, around 3 to 4 years of age, he was having issues with maintaining eye contact or talking, he was used to talk to himself rather than answering very specifically about what the person is asking him. So if you ask him that, how are you, rather than saying that I am fine or I am good, he would ask again, how are you? So this is also one of the things which tells us that there might be receptive speech or expressive speech delay. So such cases we see quite often. There is a strong link also between self-reported psychotic symptoms and early onset schizophrenia. Now, this self-reported psychotic symptoms is something that I frequently see 13-year-old, 14-year-old, like so 8th or 9th grader is coming to me and telling that, sometimes they hear voices, but very occasionally, just like once or twice they have had such episodes when they were sitting by themselves in a room, very dark room, or they were probably listening to something and then they heard somebody, they felt that somebody is behind them and things like that. So these are very attenuated psychotic symptoms, not continuous, very brief, but still they report about it because it's not necessary that they have had a continuous episode for 2-3 days or even longer, but they've had only 1 or 2 such episodes and they reported it to somebody. Most times they even forget about it. So you have to keep digging into the history whenever a child presents to you or a teenager presents to you with early onset schizophrenia. Such isolated attenuated psychotic symptoms along with developmental impairment is a very important risk for developing early onset schizophrenia. Now a very interesting phase. I think most of you know about this thing, prodromal phase. We talk about it a lot. In all adult onset cases also, we see that there is a phase wherein there is a gradual non-specific decline in the functioning of the person. So in a very, very similar way, when it comes to child or a teenager, we see that there's a gradual, non-specific but marked decline in social and academic functioning. So the parents will come and tell you that since since a year or since so now right now if the child is in say 10th standard, the parents may come and tell you that since 8th grade I don't know what has happened to him, but then he would not talk much with the kids. He used to have a lot of friends in the past, but then now he's not interested in talking to them. Or again, it's a very, very classic thing, like whether this interest or decreased interest, whether it's an affective symptom, whether it's the anhedonia related to depression, or whether it is a socially withdrawn behavior because of the prodrome. So that's also something which you always have to keep in mind. You cannot just consider that every socially withdrawn child is having a prodrome or a psychotic episode, but something like that, and along with that there would be decline in academics and all. Now here also, if such a case comes to you, the differential which you first would think of is depression or say anxiety, not of a prodromal psychosis. But then suppose if the same case and along with that there is a self-reported psychotic symptom, like and then once he complained to me that he could hear somebody, or maybe he is talking about some voices in his head or something like that, so then definitely you should keep your antenna open that maybe he may be going into a prodrome or is in a prodrome or may have early onset schizophrenia. So yeah, anyway, so there is a social or academic decline. There is development of odd eccentric behaviors or ideas. So this is what kind of makes it different than the anhedonia in depression. So there are some developments of odd behaviors and odd ideas as well. There could be some, so many times if there are no hallucinations also, they may have these symptoms wherein the parents pick it up that just once he was just talking very oddly, he talked something which is very irrelevant. Otherwise he's a very smart chap. Why would he say something like that? So, or maybe he would just once or twice say, I think mama somebody is following me, or somebody has followed me in the past, or when I was passing through that I heard people talking about me, I heard them taking my name. So something like that also should make you suspicious that probably there are some psychotic symptoms on the way. There may be some unusual or bizarre perceptual experiences, as I just told you about. There could be affective changes which are kind of out of proportion than what you expect. So if somebody has scolded you in the class, okay, if there's a teacher who kind of commented about something and the child came home and kind of reported it to his mom and cried about it, maybe, okay, a normal response, I guess. But then if the child has stopped going to school for the next 2 weeks just because there was one scolding by one teacher, a little more than what you expect. So this is how you have to again focus into very subtle changes or very subtle affective changes as well. So all of this, when we call it as a prodrome, means it is something which comes in the onset or before the onset of a full-blown schizophrenia. It can last up to even 1 year. So the parents would come to you when there are full-blown psychotic symptoms. They would not probably come to you during the prodrome, and it is your job, your clinical skills, to keep asking them that how was he or she 1 year ago, or when did you start noticing a decline in the academics or some other functioning, and whether there were any odd behaviors or not. This could be very limiting symptoms, limited transient symptoms. So again, history is very, very important. This could be wide variety of experiences. So I think I've given you quite a few examples on what kind of anomalous experiences that could be. Yes, there would be a sense of fear or puzzlement. So you guys may have read into the about delusional mood and other, those like how the psychopathology develops. So how the delusion finally has all its vectors. So before that, when, it is that phase wherein the delusional mood is in the process. So you may just look at the child and then you'll understand that, oh, he looks very puzzled, he looks very confused, and then he says 1 or 2 odd things, and then, you'll understand that it's probably schizophrenia. Again, prodromal phase is a retrospective concept. So you don't, many times you don't really get a person in the prodrome phase. Most times you would get when the full-blown episode has started. Another interesting concept which has taken a lot of emphasis in research, because when we talk about early onset schizophrenia, when we talk about any kind of schizophrenia or any kind of mental disorder, we want prevention. And one of the ways that we can prevent schizophrenia from developing as well is if we pick the person up or pick the child up during this particular phase, that is the prodrome phase, or if we are able to pick up if the child or the person is in at risk mental state. So this is called as ARMS. It is also known as ultra high risk state. This concept describes the clinical characteristics of those who are at greater risk of transition to psychosis or schizophrenia. There is again presence of attenuated psychotic symptoms. It's a prospective concept. So when you see that there is a person with who is at risk, who is in the state of having at-risk mental state, there is a modest prediction that the person may develop psychosis. The prediction to schizophrenia is modest, for it is important for facilitating early detection and intervention. The transition rate is, however, lower in adolescents than adults. The young ones with ARMS has a mixture, they may have a mixture of other symptoms as well. So this at-risk mental state does not only mean psychotic symptoms. Be very careful. In children and adolescents, comorbidity is a rule. You will never get a very classic case of depression or of anxiety or of psychosis. You will get, in most cases, a lot of mixture. There will be anxiety, there would be a bit of sadness or, anhedonia kind of a thing. There would be social withdrawal, and there might be psychotic symptoms as well. And a very, very important other concept, that there could be signs of emerging personality disorder. So the sense of self would be quite, dysregulated. There would be, there would be these concepts that, this way that the self-concept is not made, or the child would not be able to have that confidence, enough confidence to really do something and even give exams. And you cannot just think about it as depression, but you'll have to think that probably he's at risk of developing depression or at risk of developing even schizophrenia. When we get somebody in the phase of at-risk mental state, it is also important to see if the child has had any experimental or has been having any regular substance use. Because we get a lot of cases these days wherein 13-year-old, 14-year-old have already started using, say, nicotine, cannabis, alcohol as well. It's considered, again, very normal, or it's normalized among the urban societies. And they may not report it to you. Even the parents may not report it to you. So it's very important that you can give that comfort to the child, and in that environment, if he can confide in you, maybe you may find something like, there's one singular use of cannabis or maybe alcohol, and after that there's a temporal association with the symptoms. The course of childhood onset or early onset schizophrenia is typically chronic. Full remission is less common. Worse, if you compare early onset schizophrenia with early onset affective psychosis or a bipolar mood disorder with psychotic symptoms, the early onset schizophrenia has worse outcome. So that is why the early intervention, early detection is extremely important. Social functioning in the future is severely impacted. So, if you are able to pick up somebody at the prodrome, if you are able to intervene through different techniques, which we will talk about later, there is a high chance that you would prevent, or you would actually give him a lot of, or many years of proper or adequate social and academic functioning. The better outcome would be if there is an early detection and intervention. I think we've talked a lot about it already. Full recovery within 3 months of onset. If you are able to achieve that, it is great. So there are chances that the schizophrenia will not run as, the course would not be as dangerous as you would expect it to be otherwise. Poor outcome if the pre-morbid impairments are present, that is the developmental delays that we talked about. If there is a prolonged first episode psychosis, so if the psychotic symptoms even after treating them have stayed for even longer than 6 months, have required different drugs at higher doses, then probably you're looking at something which is going to definitely convert into an adult onset, convert into schizophrenia with poor prognosis. If there was an extended untreated phase, so many times the lower socioeconomic background, they don't care about the academic dysfunction, they don't care about the social decline that the child might be facing, and they come to you maybe 6 months or 1 year after the onset. So of course, the untreated phase has already extended. You have lost, the crucial time period where you could probably delay the schizophrenia and the other symptoms, but yeah, there's nothing much you can do. The outcome is going to be poor. Negative symptoms are also kind of an indication of a poorer outcome. Coming to epidemiology, so self-reported psychotic symptoms is they actually have a high prevalence, wherein there are studies which have shown that almost 20% of adolescents from 9 to 12 years of age report of having 1 or 2 symptoms here and there where they had unusual experiences or so. And between 13 to 18 years, it's about 88%. However, when we talk about clinically defined criteria for early onset schizophrenia, it is rare. So it's not necessary that every person who has had some psychotic experience will develop into having schizophrenia. The incidence is around 15.2 per 1 lakh population, and the point prevalence is 4 in 1,000, so it's quite rare. Childhood onset or the very early onset is extremely rare, even more than what we see in early onset schizophrenia. Whenever there is adolescent onset, so around say 13 to 18, it is said that there is equal sex ratio. This is again a bit striking because the more you read about neurodevelopmental disorders, whether it is autism, attention deficit hyperactivity disorder, even schizophrenia, most times males kind of have, there is a male preponderance there. But then in cases of adolescent onset schizophrenia, there is an equal sex ratio. So this is a bit different, which I think you guys should remember. Genetic risk factors, so as we all know, schizophrenia in general is highly heritable. Early onset is also highly heritable, but sporadic cases are also present. There are multiple genetic variants. We are not going to go into the details of what all genetic variations can lead to early onset schizophrenia because it's kind of out of scope of the current lecture. But what you can distinctly remember is that whichever candidate genes are also present or kind of are known to be the reason for adult onset schizophrenia, there are similar genes which are implicated for early onset as well, but they have higher penetrance. Okay, the common variants which you should know is the role of major histocompatibility complex on the chromosome 6. That has a very remarkable role. It can probably help you in MCQs as well. Few rare variants are when I think you may have heard about copy number variants in the genetics of psychiatric disorder. So copy number variants is when there is probably a deletion of a part of chromosome or a loci, and even sex chromosome. So not a complete sex chromosome, but then a part of it has a deletion. And that is leading to some sort of psychiatric disorder. So in that, what I distinctly want you guys to remember is something called as velocardiofacial syndrome. It is one of the most substantial individual risk factors for developing schizophrenia. So somebody who has the copy number variant deletion of 22q11, which is causing the velocardiofacial syndrome, 20 to 30% cases are bound to get schizophrenia. Now, environmental risk factors. Now, this is something, I don't know, like if I want to run through it, I can run through it like in 2 minutes, but then in clinical settings, this is something which is very important because the parents sitting in front of you are going to keep on asking you, why did my child get this? And you may have to sit and explain them. When you are psychoeducating them, you may have to explain that what could be the probable risk factors or causes on, you know, having schizophrenia in your child. So one of the very important risk factors, remember, for all neurodevelopmental disorders and most childhood and teenagers, teenage psychiatric disorders, is advanced paternal age. So there are studies which show that more than 34 or 35 years of paternal age is an independent risk factor for most neurodevelopmental disorders, especially autism and ADHD. But more than 30 years is also a risk factor. And this advanced paternal age is it is not dependent on the maternal age. So we all know, mainly, you know, as an MBBS graduate, we would only focus on advanced maternal age leading to Down syndrome, but then we don't really focus on the paternal age. So paternal age is in fact the more important reason or a more important factor which can lead to schizophrenia also in the early onset type, and also other neurodevelopmental disorders. So whenever I start taking the history for a child, I think this is one place wherein we start with the family history first, and we start with the antenatal history first. We start that, okay, what was the age of the mother and what was the age of the father at the time of conception. So it's important. Apart from the paternal age, okay, so if you ask me that why paternal age is so important or why is it a risk factor, it's mainly that the chromosomal deletions or certain loci deletions are more common in them. The DNA repair mechanisms are kind of depleted, okay, as the age progresses. And also other thing is substance use. So a lot of times we see a lot of males having more substance use than than the females. In general, it's higher, and that also indirectly affects the DNA repair mechanisms. So the chances of de novo mutations is high, and that is why the genetic disorders are quite high in children whose fathers have been at a higher age. Antenatal and birth complications. So obstetric complications, again, a very detailed history is required whenever you take a child case, right from, like when she probably conceived, and even pre-conception sometimes, that whether it was a stressful environment for her, whether was it a wanted pregnancy or an unwanted pregnancy. Even that history also becomes important, because that just gives me an indication if, probable stress was there during the pregnancy or not. Everything related to the antenatal care, so whether gestational diabetes was there or not, any other medical disorders, autoimmune disorders. So like again, there's a rise in autoimmune cases these days. A lot of ladies going, again, a lot of females conceiving after the age of 30, 32. So in general, that is also a risk factor for having a lot of obstetric complications. Okay, I have 5 minutes left. Okay, so that is important to be known. Birth complications, again, everything related to it, cesarean or say whether it was a normal delivery, abnormal presentation, etc. The role of infection inflammation is important, because cytokine mediated neurodevelopmental disorders can be there. During the pregnancy, there is a hypothesis that influenza during the pregnancy, even that torch infections, so whether there was a history of that or not, that kind of tells you if at all it can be a risk factor. Cannabis use, it is said that a mean duration of 7 to 8 years is of regular cannabis use is required, like to have the development of schizophrenia, but in general it increases the risk twofold to develop psychotic symptoms and schizophrenia. In early onset cases, we find it very less, because that 7 to 8 duration is not completed. So that is why, but it's again a very important risk factor. Childhood abuse and neglect, again, I will not be able to talk in detail about it, but then there's a lot of research going on trauma and childhood trauma and adverse childhood experiences. sexual abuse, emotional abuse, and even emotional neglect, and their relation with psychotic symptoms and other things. Now coming to the diagnosis, so it's quite similar to adult onset schizophrenia. So it's I'm not going to go into the details of diagnostic criteria. The few variations which you should remember are that in early onset cases, it's much more insidious in onset, more negative symptoms. The negative symptoms can be preceding. So in that prodrome phase, there would be more negative symptoms than the positive symptoms. There is more disorganization in thought and sense of self. Not very persecutory delusions. So you would not get a classic paranoid schizophrenia case in case of early onset schizophrenia, and comorbidity is very common. Clinical challenges which you will face is that a lot of times the children or even the early teens, they are not able to describe the symptoms very properly. Okay, you will, so when we see or when we look into this, that the vectors of delusion and whether the hallucinations, whether they're coming from the outside objective space or whether somewhere else inside and all of that, they are not able to answer that. So it takes a lot of time for them to understand it. Even the children, like a lot of children and even early teens, they have this concept where they would talk to imaginary friends. They may have transient hallucinations under stress. So this cannot be again reported as schizophrenia. Certain loose associations while speaking may be a part of normal spectrum of development and may be a part of somebody who has had speech delay as well. So you cannot call it again psychotic. There would many times there would be difficulty in understanding or trying to localize the hallucinations. As I said, they may think that it's the inner thought. They may think that okay, I'm only talking to myself, and or maybe it is maybe God talking to me. So you cannot really differentiate that. Okay. Coming to clinical assessment, so a good engagement with the child and the family is important. As I have emphasized already, detailed developmental history, the antenatal history, family history. You may need multiple informants, that is the family as well as sometimes school teachers or even tuition teachers are important to be called. Sometimes we have to give them some questionnaire and we have to ask the parents that please go and fill the questionnaire and come, like ask the teacher to do it. We may have to screen for comorbidity. We can never miss substance use. Risk assessment in terms of whether there were the paternal age, the sexual abuse. I cannot emphasize more on how important the childhood abuse is. Also assess for self-harm or suicidal risks. Physical examination is important for genetic syndromes. Okay, a lot of times psychotic symptoms can be present in case of seizures. So again, MRI becomes important. A lot of neurodegenerative disorders can mimic or can have psychotic symptoms, can mimic schizophrenia. So I've written here that how you can differentiate. The investigations to consider. So it's very important that we rule out functional disorders and organic disorders, and that is why urine drug screen again becomes important. As I said, that people may lie about the substance use, so it's just better if the child or the adolescent has used any substances and if that is the cause of psychosis. EEG, just to rule out complex partial seizures or anything else. Also, I frequently tell this to parents that if there are very transient psychotic symptoms, to take a video of that, or any abnormal behavior, please take a video and get back to me. Whether it's a seizure, whether it's a dissociative symptom, we don't know. MRI brain, again, the reasons that it is important, it could be, and also like in cases of schizophrenia, you would see more of gray matter loss than white matter, whereas in cases of, say, for example, metachromatic leukodystrophy or Wilson's disease, there would be more of white matter loss or basal ganglia degeneration. These are certain things which I'm anyways sending the slide so you can see whether what is important. This is just for MCQs that I've written, that metachromatic leukodystrophy can you need to check aryl sulfatase, serum ceruloplasmin for Wilson's disease and so on. Karyotyping can be helpful to rule out any genetic disorders. Okay, another very important extremely, young children, like say 10 years, 11 years, having psychotic symptoms, you can never forget looking for autoimmune encephalitis, limbic encephalitis. So, the presentation would be something like acute psychotic symptoms within, say, less than a week or so, and there are severe headaches, there may be seizures, some dyskinetic movements, abnormal gait. Please get an autoimmune panel done. So it could be NMDA antibodies, voltage-gated potassium channel antibodies, and so on. If we are planning to start antipsychotics, baseline ECG becomes important. These are the rating scales. Again, we don't really use it very frequently in the clinical setting, but it's there. You can use it. It's similar to, again, PAN-SS and other positive and negative symptom scales. Yeah, one abnormal involuntary movement scales is important because neurological examination becomes important in any childhood onset or teenage onset cases. Now, whenever coming to management, whenever you have to see a child or a teenager with psychotic symptoms, or if you have diagnosed that there is early onset schizophrenia, only giving medicines is not going to help. It's never going to help. Pharmacotherapy is just a part of the treatment. But more than that, there is family intervention, there's psychoeducation, psychotherapy also may be required. Managing the comorbidity is very important. And with all of this, you are literally, you are treating a teen. You are treating a teen whose entire life is still pending. He has to study, he has to go to college, make friends, have relationships, friendships as well as romantic relationships. So everything can go wrong if you are not treating those aspects very well. So educational, social and vocational rehabilitation becomes very important. Whether the child will need an inpatient or outpatient care, I think I don't really have to emphasize or explain that. It would be dependent on the complexity and severity. But care should be in an age-appropriate setting. For at-risk mental states, there would be this question, there may be this question that should we medicate a person if we see him in prodrome, or if we see when the person is in at-risk mental state. So there are chances that we may try antipsychotics, but then the studies have shown that they may do more harm, and they have similar efficacy to cognitive behavioral therapy or family intervention. So it is better that if you are getting somebody with at-risk mental state, please try to find out what the risk factor may be or the causative factor. Try to treat it with other interventions rather than pharmacotherapy, and then see, do a repeated thing of assessment after 3 months or so, and then see if medicines are required or not. Also, there is some studies telling us that omega-3 polyunsaturated fatty acids may be helpful. For early onset schizophrenia, again, I'll just take, I think, 3 more minutes. So antipsychotics have all the antipsychotics have similar efficacy, but remember that children and teenagers have greater sensitivity to side effects. First generation antipsychotics should be avoided. I think you know the reasons. Second generation antipsychotics can lead to metabolic syndrome. But however, second generation antipsychotics are more preferred. Just a few points to remember. So all of these medications which I've written here, they are found to be effective. Risperidone is usually the first line. Aripiprazole is the second line. The doses are, most times we start again at lesser doses or lower doses than what we would start an adult with, but again it depends on the weight of the person as well. Risperidone has a higher risk of or the greatest risk of hyperprolactinemia, so I would rather not prefer it in a girl, but maybe in a boy. Quetiapine, aripiprazole have the least chances. Aripiprazole, the good thing is it does not have effect on QT prolongation. In children, even aripiprazole can lead to sedation. So remember that. So in that case, you can even use aripiprazole. You need not add something for sleep. You can just continue with the same aripiprazole dose, and you can expect that the child would sleep fine. The risk of akathisia is highest with aripiprazole. I think I have I have a 17-year-old who reported of akathisia only with 5 milligrams of aripiprazole as well. So, I mean, it's that high. Olanzapine has the risk of greatest weight gain. One important thing with, an interesting thing with olanzapine is that in child or adolescent cases, olanzapine is something which you should try before shifting to clozapine. Okay, so again, I have seen this personally. So we've tried the child on risperidone. I've tried her on, I had tried her on aripiprazole, I think up to 20 milligrams, but still there was no improvement. And olanzapine 10 to 20 milligrams started showing improvement. So before labeling it as treatment resistant and, you know, being very enthusiastic to start him or her on clozapine, it's better to give a trial of olanzapine. It may work. Risperidone, quetiapine have modest risk of weight gain. Aripiprazole has the least. Clozapine also has higher risk of seizures and neutropenia in children and adolescent cases. Ziprasidone, asinapine, we don't really use it as amongst the first lines. The same thumb rule applies here. Adequate trial of 4 to 6 weeks with adequate dose is important. We would try an atypical first, then the second atypical, maybe olanzapine later, and then clozapine. Monotherapy is ideal, but most cases of child you will get comorbidity, so it is okay if you have co-pharmacy. You may give a benzodiazepine, a small dose, just, you know, to calm the child down, to have a bit of anti-anxiety effects. You may need melatonin. On top of that, you don't want to like give an extra dose of antipsychotic. You may have to give, even if there is, for example, ADHD symptoms or autism symptoms, you may have to treat that as well. Usually, once the treatment is done, we still kind of continue it for 2 years. I mean, even if the child is showing recovery, 2 years is like the minimum. These are the baseline investigations which I would want every person to do for a child, just to know what the metabolic, what the metabolic panel looks like. Also, we would like to do prolactin levels and the levels over here written after 12 weeks. Yeah. So with this, I come to an end. I just want to tell you a brief about the child abuse and psychotic symptoms. So very interestingly, I've seen both kinds of cases wherein in cases of, there was a case wherein the child was molested at the age of 12 or 13. She is, I think, 18 now. And it was, it was not very, very significant as we would say, but then still definitely there was a lot of preoccupation surrounding the sexual abuse. And currently I'm treating her for schizophrenia. Again, kind of treatment resistant. She was the same case where I had to give her olanzapine and only then see a bit of improvement. Also, she was going into depression or depressive kind of symptoms. Somewhat the picture changed into schizoaffective after a while. And there was another case wherein again there was a history of sexual abuse, molestation, but rather than the schizophrenia, like a proper schizophrenia like symptoms, what she ended up having was a self-reported like repeated voices in her head. Like she did not have any other thing. There was no odd eccentric behavior, nothing else which would probably make her diagnose of having schizophrenia. It looked more like, say, obsessive compulsive disorder, repeated thoughts again and again, everything related to her body, related to her self-esteem. And but those same thoughts she would kind of get confused whether it's a thought or a voice. So she would repeatedly say that there is somebody inside me who keeps telling me, like, go die, you are not useful for anything, you've just been, abused or something, and then there's no point in living. So again, it's a very confusing picture. It's not necessary that every person with sexual abuse or child abuse would have childhood onset schizophrenia, but it's important that we look for it. Okay. Thank you so much.
Thank you. Thank you, Dr. Kinnari, for that vast discussion from causation and comorbidity and other detailed things, and especially the clinical challenges to treat. Yes, all of us agree that listening to whole lecture, she gives lot of caution when we are treating with adolescents. So take home message is that, unlike adult psychiatry, you have to really, the presentation is different, the clinical challenges are different. You have to answer many people before, I think Dr. Pai will agree, when you are starting treatment to adolescent, you have to convince many people. So that challenges, she has done justice to her presentation. Thank you, Dr.
sir.
Kinnari, for coming all the way from Mumbai and
Thank you, sir.
being there with us. Thank you. Thank you.
Thank you so much. Thank you.
Thank you, Dr. Kinnari, for an enriching session. I'm sure everyone present here has immensely benefited from this comprehensive session. We thank our chairperson and audience for being a part of this. I would now request Ms. Sindhu to present a token of appreciation to our speaker, Dr. Kinnari. I would also request Mr. Manjunath to present a token of appreciation to our chairperson, Dr. Virupaksha Devramani.
With this, we conclude the last session of our scientific program. We hope that it was useful. I would now like to call upon Dr. Satish Rao, Dr. Nagesh Pai, Dr. Srinivas Bhatt, Dr. Shishir Kumar and Mrs. Agneta to grace the dais. I request Dr. Nagesh Pai to kindly give the closing remarks as conclusion to this 2-day-long CME and alumni meet.
Good evening. Okay. Good evening. I'm actually amazed at the enthusiasm every postgraduate have to stay back at this late hour on the second day. It's a commendable job. Congratulations. And that was possible only because of the very organizing committee. My particular thanks to the postgraduates associated with organizing these events. You people have done commendable job. I can't really thank you enough. It really is heartening to see Kshema is indeed a family, and this does bring in an important thought to me. We have 5 postgraduate psychiatric centers. Maybe it's time for you to brainstorm and see whether you can have some common teaching program, even once a month for 2 or 3 hours. Join all the 5 medical school faculty. It's a rich amount of resources. I was talking yesterday with the alumni that we really need to encourage having visiting staff, even if it's an online lecture. That will really help the postgraduates to grow. 20 years almost since I left here, the amount of enthusiasm and the courage postgraduates have has really gone up. And again, congratulations. Lastly, the speakers. I would have been tired. I would have finished my lecture in 15 minutes. Both Kinnari Doshi and what's the other? Apurva have really had enormous amount of energy to keep the CME program going till the end. Fantastic show. That shows the alumni really have gone up and done. It's really heartening to see the quiz yesterday, the paper presentation, the posters, which are all taken extremely seriously, and I hope these things will continue, if not every year, maybe once in 2 or 3 years. I think something which we need to think about as an alumni committee. And I thank you all. Wish you all the best.
A very good evening, one and all. You're all tired, you're all filled with knowledge, I know that. And we as, not tired, okay fine, that's nice. Sir is telling not tired, but I have to ask the delegates whether they are tired or not tired. Enriched, okay, then very good. Okay, so as joint organizing secretary, we all, as a team have slogged a lot since 2 to 3 months, 3 months now. And this is the outcome that we have come today. For the 2 days, we have finished our CME in an enriching way, as the delegates and the resource persons and the chairpersons say. So I would congratulate all my team, okay, along with the, actually it's on behalf of our HOD and our Professor Dr. Satish Rao. I congratulate everyone, and also thank you to all the resource persons who have traveled from far and near, and also our students who are the alumni and our resource and source who have come here, shared your knowledge, shared your expertise, and you have done a great job, and we are very proud of you. And thank you everyone for staying till now, even the delegates. And we would also thank the pharma reps who has contributed a lot for this a session for the CME. And also I would like to thank on the outset our photographer, our operators, and the YouTube person who is dealing with these things. So thank you everyone. Have a great time and a great evening, and please keep on coming here and keep in touch with us. Thank you.
Thank you, ma'am. We extend our heartfelt gratitude to everyone who has been part of the event. Kindly note that the certificates can be collected from the registration desk right outside the hall. Thank you.
The second prize for the poster presentation was won by Dr. Juhi Suresh Babu. Kindly give a round of applause for her. She is from Rajeshwari Medical College, Bangalore.
Everyone from Department of Psychiatry, please, Shema, please come to the dais. We'll have a picture.